from KEMC. He did his training from Glasgow, from UK, and then pulmonary training in Royal Bumberton Hospital, UK. He remained in Saudi for a longer period of time, currently working in PKLI, has multiple research in a peer-reviewed journal internationally and nationally, and he is the author and co-author of multiple book chapters, national and international guidelines. He is a reviewer of Journal of Former Associated Annal of Thoracic Medicine, speakers in international Congress. He is a founder member of Office Bearer of Saudi Thoracic Society, Gulf Thoracic Society, and MENA. And he has special interest in asthma, pulmonary hypertension, respiratory failure, sarcoidosis, and sleep-related breathing disorder. Welcome, sir, on the chair. So, without delay, I am going to invite my first speaker, who I call as a father of pulmonary medicine, and his name is Professor Nadeem Rizvi. He has done his graduation in 1982 from Dow Medical College, and then he did his training in UK and completed his MRCP, FRCP later, and he worked there in UK for 10 years. He is a pioneer in starting critical care, thoracic, and as well as non-invasive ventilation. He trained multiple undergraduate, postgraduate, and he has 14 years of experience of training them. Has 100 of the postgraduate training. He has multiple research paper with him, and he's currently actively working in Pakistan Chest Society, and we learn a lot from him. Welcome, Professor Nadeem Rizvi, and he's going to talk on a very important topic.
Thank you, Irfan, for your kind introduction. With the permission of Chair, I would like to start the talk on this asthma, which is one of the very common subjects. But before that, I would like to thank the organizers for inviting me to talk about this topic, which is a bread and butter for not only chest physicians, but all family physicians also, and general physicians also. So my talk will be very basic. I'm not going to go into details about it, but the problems which, as a pulmonologist and even as a general physician, we face, I would like to discuss those problems and how to tackle with them. Now, before starting a talk again, I would like to introduce my baby. This is the chest unit of Jinnah Postgraduate Medical Center. With the help of the philanthropists, this was established from a ground level and is 110 bedded with a 16-bedded ICU. So this is my achievement. Now coming to the point, asthma. I always find it difficult to define than actually diagnosing and treating asthma. It's a big definition, but it is very important for anybody to know when they are diagnosing and treating, because all these points which has been in the definition help us in diagnosis. So it's number one, it's a chronic inflammatory disorder in which various cells take part, which causes inflammation, leads to hyperresponsiveness, and hyperresponsiveness leads to variable airway obstruction. And this is the point which differentiates asthma from COPD. So I will come to this common cause of asthma from work and schools. We have got very little knowledge about the local prevalence of this disease, but this was a study which was published long ago, published in Lancet in children from 9 to 14 years, checking their allergies and asthma, and they found that it was around 14%. Then from the platform of Pakistan Chest Society, we have done a survey in adult population, and it came out to be around 5% in adult population. Multan was the place where it was the highest, I think if I'm not wrong, 5.5%. Coming to the pathophysiology, still there are a lot of confusion regarding the understanding of pathophysiology of this disease, but basically the mast cells, which are the culprit cells, they are being blamed for initiating the cascade of inflammation in bronchial asthma. When a person gets sensitized to any allergen, IgE molecules are being made by the beta lymphocytes. They get attached to these mast cells, and when the subsequent exposure to the allergen, which is big enough to bridge the gap between these two IgE molecules, a series of reactions start taking place in the mast cells. There are certain preformed mediators which are already present in the mast cell, they are immediately released, and they are responsible for causing bronchospasm, which is responsible for causing breathlessness. But then there is the rupture of these mast cells. The phospholipase, which is present in these mast cells, acts on the lipid membrane, produces more mediators, and they causes chemotaxis to the various cells. They all come into the mucosa, and an inflammation take place in the airways. So in a nutshell, if I have to describe that anybody who is genetically predisposed, along with the environmental factors, will develop airway inflammation, and airway inflammation will lead to hyperresponsiveness, and hyperresponsiveness leads to variable airway obstruction, which is responsible for causing the symptom of asthma. There's a beautiful movie which have explained whatever I was trying to tell you, but because of the limited time, I will skip this showing. Now, as far as the diagnosis is concerned, asthma diagnosis is mainly clinical. If you have anybody coming with repeated attacks of coughing, breathlessness, or whistling sound coming out of his chest, you should suspect that this patient has got an asthma. Unfortunately, in our setup, these patients who have repeated bouts of coughing, without thinking about asthma, they are being treated with antibiotic, cough syrups, and it's helpful, particularly if a patient is coming in between the attack. But if it is having an acute attack, then the signs are so obvious that you don't need to worry. It's not difficult to diagnose then. And to confirm the diagnosis, clinically you have a suspicion, and to confirm the diagnosis, you need a simple gadget which is called peak flow meter. If you can show that there is a reversibility of 15% by checking the peak flow, you confirm the diagnosis of asthma. This is a gadget which is around 800 rupees available in Pakistan, but I have not seen many family physicians using it. Even chest physicians don't tend to use it. Without that, you cannot assess the severity. Without that, you cannot diagnose asthma, you cannot assess the severity of the asthma, and you cannot assess the response to your treatment. So it's so important, simple gadget which you should be using. This is a spirometry finding, but the same thing you can do with a simple gadget. A spirometry is costly, 2-3 lakh rupees, but the same thing you can do with the peak flow meter. Check the peak flow. The normal reading is this blue, and in asthma, because of bronchospasm, it will come low. You give them 2 puffs of bronchodilator like salbutamol. 10 minutes later, check the peak flow again. If you find a 15% improvement from the baseline, you confirm the diagnosis. The problem is that many of these patients may have already taken bronchodilators when they come in, so you may not see this reversibility immediately. What you can do is to give them, because there is an airway inflammation, you can give them inhaled steroids or an oral steroids. Check the peak flow before starting, and after 7 days of starting or 10 days of starting, again you will find a reversibility and you confirm the diagnosis of asthma. So it's not difficult. Even if you can't do that, just give him a peak flow meter and ask him to check morning and evening peak flow. The morning peak flow, because of the catecholamine surge, will always be low. And in the evening, the peak flow will always be high. This is the evening and this is the morning. If this variability is more than 15%, ask him to make a diary. You confirm that this is an asthma. And finally, there is another simple test which you can do in a clinic. Check the peak flow. This is a very peculiar phenomenon in asthma which do not occur in any cause of breathlessness. And that is bronchospasm induced by exercise because of hyperventilation. So check the peak flow, ask the patient to walk fast for 5 or 6 minutes, and check it again. You will find that there is a drop in the peak flow. And an intelligent asthma patient will tell you that when I'm climbing the stairs, I do not feel short of breath. But as soon as I reach the landing, I become short of breath. And this is a very peculiar symptom of asthma. And this is what you are trying to prove with the exercise testing of the peak flow. So with that, you can easily do that. Management, very simple steps. That first, make a diagnosis, eliminate those causal factors which are responsible for aggravating asthma, initiate the therapy. Education is the main issue in any chronic illness, and that's what I'm going to briefly talk about it. And then finally, monitoring the compliance. The treatment is by 2 types of drugs. One we call reliever drugs, which immediately relieve the breathlessness or the symptom of asthma. They are the bronchodilators, and then we have got controller drugs, which is responsible for reducing the inflammation which is there. So these are the two groups of drugs which are available, all are available in Pakistan. They are all available in Pakistan. So you have to use these two drugs. So management is very simple, and inhaler are the best way of treating these asthma patients because the drug reaches directly into the airway, doesn't produce side effects. But again, not many patients in Pakistan are being treated with inhalers. They are mostly on tablet or injections form. Anybody who is requiring a bronchodilators once a week should be on anti-inflammatory drug or preventive drugs. This is again a very important point that you have to remember, because if you do not give them preventive drugs, you are just relieving the bronchospasm which is there, but the underlying problem is the inflammation. You are not addressing that. So you have to give them a preventive drug. And inhaled corticosteroid is the most important drug, which not only reduces the frequency of exacerbation, but also severity of exacerbation. You will not see patient dying or getting admitted if he is regularly using his inhaled corticosteroid as per prescription. Inhaled steroids act on all phases of inflammation, so they are the mainstay of the treatment in asthma. This was a long, very old study which was done in New Zealand and presented in Oslo. What they were showing is that as in New Zealand the sale of inhaled canisters increased, the sale of inhaled corticosteroids increased in the market, the mortality started coming down there. So this should be remembered that almost all patients of asthma need inhaled corticosteroids. This is again a data which I took from the pharmaceutical company, and you can see that the majority of our patients, almost over 85% of our patients, are only on bronchodilators. They are not using inhaled corticosteroids, and that is the main problem. Mr. Chairman, do I have a few minutes more? कितने मिनट देंगे आप मुझे? 2 minutes. Chale, if you want 2 minutes, I will finish in 2 minutes. So this was my main topic, that asthma beyond prescription. To prove this, I'm going to show you 3 shortly prescriptions. This is Mr. Malaria. This is a very short prescription, oral medicine. This patient, when you prescribe that, if the diagnosis is good, this patient, you can rest assured that the patient is going to get better because he's going to take medicine. Mr. Diabetes, again, this is a chronic illness. Prescription is well written. Do you think this patient? Yes, this patient will remain, because the patient himself inherently knows that he has to take the medicine. If he doesn't take the medicine, the consequences will be apparent next day. His blood sugar is going to up. His family plays a very positive role. The wife is always after him to take the medicine. But coming to the asthma, again, the prescription is okay, but we do not know whether this patient knows which inhaler has to be used when, how to use the inhaler. That is very important. And again, the family plays a very negative very negative influence when it comes to asthma, and if you have prescribed inhaler to these patients. सबसे पहला कहा जाएगा कि अरे आपने इनहेलर दे दिया तो हैबिचुएटिंग है, इसको तो हैबिट हो जाएगी इसकी, तुमने बच्चे को स्टीरॉइड दे दिया, how come that possible? You cannot give steroids to a child. So all sorts of impediment is there when you are treating. Treatment of acute and chronic illness is different. In acute illness, you just need clinical acumen and diagnostic blindness and cutting-edge treatment. But in chronic illness, success comes from doing simple things correctly, doing them repeatedly correctly, and taking the patient along with them. So this is the steps of treating asthma, chronic illness like asthma, that you have to go along with the patient as in educating them. Asthma is a do-it-yourself kind of disease. Just 2 simple statements I want to make it, that drugs work where they reach. And drug only work for them who take their medicine, who take them. So this is very simple. In cases of respiratory system, there are a lot of challenges when you are using asthma, because you see, nature wants to avoid anything going into the airway. Your nose is at an angle with your face. You have got hair in your nostrils, which are beating outwards. You have got turbinates, epiglottis, glottis. These all things are trying to prevent anything going into it. So inhaler, meter dose inhaler are such that they circumvent all these issues and take the medicine directly into that. But remember that it is a double-edged sword. If it is taken correctly, you will have the desirable effect. If it is taken incorrectly, you will have no effect whatsoever, and patient lose in faith in inhalers. Inhalers are available in different form. They are very convenient devices, but convenient devices only when they are being used appropriately, non-inappropriately. Those who cannot use, they should use the spacer. Then we have powder dose inhaler also available in Pakistan. Nebulizers are overprescribed in Pakistan. This is the biggest issue. They think that children cannot use inhalers. If you know how to give them to children, every child should be using inhalers. So everybody can use inhalers. So I will stop here. There are a lot of things which I wanted to discuss about asthma, but what I'm trying to say is that if you really want to treat your asthma patient, the treatment starts after writing a prescription. Diagnosing and treating asthma is not a rocket science. It is the time which you spend with your patients after you have written a correct prescription. I stop here. Thank you very much.
Sir has to go. If you have any question, you can ask, sir, with the permission of a chairperson.
Ji, Javed Saab. Thank you.
Some people with the reflux disorder, at night and in the morning they do get very common. So would you suggest to give them PPIs or something in routine, or just wait? And Azimul MABs now are being used for intractable asthma, disease-modifying drugs that we use. Oscilumab we have been using for. So what is your experience of using Oscilumab in intractable asthma? And thirdly, for my junior colleagues who are here, sometimes it becomes very difficult to establish the reversibility of the disease. And there is an element of chronic bronchitis and asthma overlapping. What would you suggest them to do a challenge and do the reversibility right there in front? We welcome our patron, Professor Aftab Vora, who is the Professor of Ijaz Vora, who is the chief guest tomorrow at our inauguration. So can you, these three small questions?
Well, I will try if I can recall that. First of all, I would also like to welcome teachers of teachers, Dr. Vora. Thank you very much for coming, sir, and joining us. Dr. Javed Akram has asked so many questions that it will be very difficult. The first question क्या था इरफान याद दिलाओ, मैं तो उनकी बातें सुन के भूल गया सारा कुछ. PPI, सबसे पहला PPI है. Yes, it is very important, and remember that bronchodilators when you use, they all not only relaxes the airway, they always relax the sphincters of the stomach also. So this is a very common problem. If somebody comes to me with the nocturnal symptoms, I always ask the symptoms, and at least if I do not give anything, I would always like to incline their bed from the head and side of that. That is not a difficult proposition. But if I have a confidence, then I will definitely prescribe PPI to them. We have also published a study in JPMA in which 80% of our asthma patients do have reflux symptoms. We did not diagnose it, but the symptom of reflux was almost present in 80% of our asthma patients. So it is a very common problem. Secondly, आपने बात की थी omalizumab की use करने की. मेरा limited experience है. I have used it very successfully. I mean, patients, but problem is that I see physician prescribing even for minor asthma. एक दवा का नाम पता चल जाता है हर किस्म के. वो patient जो कि usual drugs जो हमने prescribe किए हैं उनसे ना manage हो सके, बार बार उसको oral steroids देने पड़े, तो वहाँ इस 5th stage of treatment को we should bring it. The problem is that it has this injection, this is available in injection form. It has to be given after every 3 weeks or 4 weeks, and one injection costs about 35 to 40,000 rupees. So not many patients can afford. I can recall one of the MPA wife was asthmatic. She was fitting into the category. ماشاءاللہ ان لوگوں کے پاس پیسہ کافی ہوتا ہے. تو شی کنٹینیوڈ فار 2 or 3 years اینڈ شی ڈیڈ سو ویل کہ اس کو اورل اسٹیرائڈ کی کوئی ضرورت پھر نہیں پڑ رہی تھی. تو ایسے 2-3 پیشنٹس ہیں جو میرے ہیں, بٹ اٹ از اے ویری یوزفل. آئی وش فرام یو وی کین ریکویسٹ اف وی کین produce this medicine here and we can cut down to affordable level. There are definitely few patients who will be needing. اور کوئی سر کا سوال تھا؟ ہاں, ریورسبلٹی کا. سر چیلنج ٹیسٹ جو ہے دیٹ از یوزلی ڈن فار ریسرچ پرپسز اور فار آکوپیشنل کمپنسیشنز. وی ڈو ناٹ ڈوز چینل ٹیسٹ ایز اے روٹین. ریورسبلٹی سر بہت آسان ہے. اگر کسی نے کوئی برونکو ڈائلیٹرز نہ لیے ہوں اور اس کو ایستھما ہو تو 5-10 منٹ میں آپ یہ پروف کر سکتے ہیں. میں نے جیسا کہا کہ اکثر ہمارے پاس پیشنٹ آتے ہیں جو آلریڈی میڈیسن لے رہے ہوتے ہیں, تو وہاں ہمارے لیے پرابلم ہوتی ہے. پھر ہم اس کو ایک شارٹ کورس آف اورل اسٹیرائڈ دیتے ہیں. اف دیر از اے سگنیفیکنٹ improvement, you will see that. جہاں تک آپ نے chronic bronchitis کی بات کی ہے, یہ ایک usually ہم ایستھما جب کہتے ہیں کسی پیشنٹ کو تو وہ ایک دم اپریہنسو ہو جاتا ہے. ہی از ٹیکن ابیک. ڈاکٹر صاحب مجھے ایستھما تو نہیں ہے نا, یعنی اٹ از اے لیڈنگ کویشچن. وہ جواب دے رہا ہے, خود ہی جواب دے رہا ہے کہ آپ یہ کہیے مجھے ایستھما نہیں ہے. تو کچھ لوگ ہمارے اس کو الرجک برونکائٹس کہہ دیتے ہیں. دا ادر نیم آف الرجک برونکائٹس از ایستھما. دس از ہاؤ آئی ٹیل مائی پیشنٹس کہ جی یہ ٹھیک ہے آپ کہتے ہیں اٹس الرجک برونکائٹس, بٹ اس کو دوسرا نام ہے ایستھما. دا ریزن وائی وی وانٹ ٹو ٹیل دیٹ اٹ از این ایستھما دیٹ دے ہیو ٹو ٹیک دا ٹریٹمنٹ آن اے ریگولر فار لانگ ٹرم بیسس. تھینک یو. یہی تھے نا سوالات, اور تو نہیں. چل, تھینک یو.
One question, please.
Sir, we have another question.
With the permission of chair. Professor, there are certain situations where the syndrome of bronchial asthma is rather curable. For example, tropical eosinophilia, or simple, you see, parasitic infestation in children, intestinal. Would you not caution the doctors that they should try to see these things, especially in Karachi? Because in 1969 I was in Karachi JPMC doing my FCPS. So I saw a few cases of tropical eosinophilia here.
جی بالکل. I mean there are tropical eosinophilia cases which may present, but usually when you do a CP in the complete blood pictures you will find a high level of eosinophil count in that. Yes, children ہمارے لیے ایک problem ہے کہ they might have parasitic infestation which may help, which may make it difficult to control their asthma. But when we come across that, we always take a history from the mother that have you ever noticed such things. تو یہ چیزیں معلوم کرنے کی ضرور ہیں. اف اٹ از تو ڈی ورم کرنا چاہیے. اور یہ ضروری ہے جو کہ ہم نے پیڈیاٹریشین سے لرن کیا ہے کہ اف یو ہیو ٹو ڈی ورم somebody you have to ڈی ورم the whole family. ایک سے پھر دوسرے کو اگلے دن لگ جائیں گے پھر سے. تو the whole family have to be dewormed, but unless we have an evidence or we are having difficulty in treating asthma in children, we don't do as a routinely.
Would you advise stool examination at least?
Sorry sir?
In intractable cases, stool examination.
دیکھیے stool examination جو زیادہ is the importance, the history of from the mother, which we can note that. The mother will know the habits of the child, how is he eating or not. یہ ساری چیزیں ہیں. Stool examination, it may not always be positive, even if the patient has got worm infestation. So yes, you can do that. There's no harm in doing it.
So nowadays patients are presenting with dry cough. And if you treat on the line of asthma, they are cured. Number one. Number two, I will ask you, what is the role of cough suppressant syrups?
Sorry? Acha, cough suppressant. پہلی بات تو یہ ہے کہ yes, you are absolutely right. A lot of these patients who have got asthma, they just present. ایک اور چیز ہے post nasal drip, وہ بھی اس طرح سے present کر سکتی ہے, but asthma should always be taken into consideration because these patients may not have breathlessness. So remember that treating them for few days for inhaled corticosteroid or showing the reversibility in them, you can confirm that there is a diagnosis of asthma. Cough syrup, یہ so much misuse ہے کہ I can't tell you. It's a big market. UK میں in the national pharmacy there was only 3 cough syrups. You cannot go and buy on the counters. لیکن I remember جب میں انگلینڈ سے ٹریننگ لے کے آیا, پہلے 5-7 مہینے میں نے سوشل سیکورٹی میں کام کیا تھا سمر شیرہ صاحب کے ساتھ, تو میں نے بند کر دیے سارے کف سرپ. میرے خلاف نعرے بلند ہو گئے کیونکہ پیپل گیٹ ایڈکٹیڈ, ان کو نیند نہیں آتی ہے, پورے وال چاکنگ ہو گئی. یہ ڈاکٹر کون آ گیا جس نے کف سرپ, ہمیں وہ تھیلیوں میں بھر بھر کے کف سرپ جاتے تھے ان کو. तो ये it's a very addictive, लोग सो नहीं सकते without that. I don't prescribe as a routinely cough syrups in certain except certain conditions which have got intractable cough. Otherwise asthma के लिए कभी cough syrup नहीं देना चाहिए. Cough is something, ये ऐसे ही है जैसे किसी को डायरिया हो जाए और आप उसको एंटी डायरियल दे दें. Let him wash it out. तो अगर cough हो रही है तो nature wants to make him expectorate. Let him expectorate. आप उसको hydrate कीजिए, उसके बलगम निकालने में आसानी कीजिए rather than उसको suppress करना. I think this is wrong treatment which should not be given to asthma patients. Thank you, sir.
Thank you so much, sir, for enlightening us on a very important topic. Our second speaker, a very eminent personality, pleasant face, smiley face, Professor Ali Zubari. He did his graduation in 1992 and he works in USA. He's a diplomat, American Board of Internal Medicine, Pulmonary and Critical Care. He is Professor of Medicine, Aga Khan University, and has more than 100 publications with his name. He is running ILD clinic and pulmonary infection and his director ILD program. I welcome Professor Ali Zubari. Thanks.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. Thank you, Irfan, for a nice introduction. And thank you, PSIM, for giving me an opportunity to be a speaker here. I do not have any conflict of interest. COPD, as Professor Nadeem Rizvi said, that obstructive lung disease, including asthma and COPD, is the bread and butter practice of pulmonology. It is the third leading cause of death, and unfortunately, it is rising, especially in our part of the world and other low to middle income countries. What is COPD? The best definition comes by GOLD, which stands for Global Initiative for Obstructive Lung Disease. This is a program which was established in 1998 with the consultation of healthcare professionals and public health advisors, and this has been updated quite frequently. The first report came out in 2001, and the last report is in 2022. So they have defined COPD as it's a common, preventable, and treatable disease. It is preventable, and we'll see why. It is characterized by persistent respiratory symptoms, unlike asthma, in which you see intermittent symptoms, and airflow limitation that is usually progressive. Alveolar as well as airway abnormalities can be caused by significant exposure to the noxious particles or gases, and the main reason of COPD, as you all might be aware of, is cigarette smoke. Exacerbations and comorbidities contribute to overall severity in individual patients. So the burden of COPD, as you can see in this slide, is huge, significant. Cigarette smoking responsible for 80 to 90% of cases, third leading cause of death. More than 6.9 million people are suffering from COPD in Pakistan, and it affects more than 300 million people worldwide. So you can appreciate that the burden of COPD is significant. If you can recall from medical school, the word COPD was an umbrella term which was divided between chronic bronchitis and emphysema. I'm sorry that, there's iski wo thodi si out ho gayi hai. So the blue blotters versus pink puffers. But this classification is more or less obsolete now, what we call together now and lump together as COPD. Chronic bronchitis की pathophysiology में air tube narrowing होती है, lot of mucus production होता है, उसी की वजह से they bring up a lot of sputum, and it is because of the increase in size of mucosal glands and in the number of goblet cells, which causes ciliary damage and thickening of the muscles. In the emphysema, we know that there is an air exchange abnormalities because of the destruction of alveolar wall, which leads to loss of elastic recoil and eventually the destruction. So the diagnosis of COPD requires three things: risk factors, symptomatology, and then you confirm by spirometry. So risk factors of COPD, as I said earlier, that cigarette smoking is the most common cause, and that includes pipes, water pipes, shisha jisko kehte hain, uske alawa marijuana use, cigars, all these things are notorious and they can cause COPD. But another very important cause that is actually the most common cause in women, especially in this part of the world, is atmospheric air pollution. And as you can see in this slide, unfortunately, the two major cities of Pakistan, Karachi and Lahore, you can see the air pollution because of different reasons. And in the outskirts of both cities, one is from Lahore and the other one is from Karachi, you can see these atmospheric air pollution contributing. This is the neighboring India, New Delhi. and some other part of India. So COPD की atmospheric pollution जो है इस part of the world में is a very important risk factor. Symptomatology में I think all of you are aware of it, लेकिन एक symptom जिसको मैं emphasize करना चाहूँगा is excessive tiredness or fatigue. So if you see an elderly gentleman who is a smoker or ex-smoker is complaining of fatigue, think about COPD, because sometimes they not tell you that I have dyspnea, or they consider dyspnea as a part of aging process. So typical COPD का जो मरीज होता है हमारी setting में जाहिर है कि cigarette smoking is more common in males, so male gender, but don't forget that females can also develop COPD because of atmospheric pollution and the use of hookah in the villages and the rising trend of smoking in women, unfortunately, in this part of the world. Smoker or ex-smoker, dyspnea is the main symptom. They might have cough or sputum production. So think about COPD if you encounter a patient who comes with any of these symptoms and have exposure to risk factors. COPD is confirmed by spirometry. That's a standard test, which can be done in the office setting as well, but it is highly recommended that you do at least initial test in a PFT lab, in which you measure the forced vital capacity and forced expiratory volume in 1 second, and you calculate the ratio. So the post-bronchodilator ratio, if it is less than 0.70, it confirms the presence of airflow limitation. So spirometry should be highly considered to confirm your diagnosis and to assess the severity of airflow obstruction. And sometimes it is also helpful in the follow-up assessment, especially in making therapeutic decisions. COPD, this is a very important slide, and this is very important to educate your patient that it is crucial to quit smoking. I have seen that physicians don't spend enough time. If you spend even 30 seconds or 60 seconds, कि आप smoking तो नहीं करते, आपको ये छोड़ना पड़ेगा. And be confident, you have to tell them कि डॉक्टर साहब हम आहिस्ता आहिस्ता करके कम करेंगे, that doesn't work. You have to tell them कि अगर आप ये smoking की habit नहीं छोड़ेंगे तो ये दवाएं काम नहीं करेंगी. And as you can see in the slide कि regular smoker का fall in FEV1 after the age of 25 is much more rapid as compared to the person who has never smoked. We do know that FEV1 falls with the aging, but that is not significant enough to cause dyspnea. But in smokers, it is much more rapid decline in FEV1. कुछ और additional diagnostic tests जिसके बारे में आप सोच सकते हैं. Chest X-ray itself is not diagnostic for COPD, but it is helpful to diagnose other comorbidities, for example, concomitant interstitial lung disease or heart failure. Sometimes you recommend to get the full lung volumes and diffusing capacity अगर आपको concomitant diseases का clinical suspicion हो, or if you hear crackles, particularly coarse crackles or velcro type crackles जिसमें आपको interstitial lung disease का suspicion हो, along with COPD, and then other testing if as required. Severity of classification of airflow obstruction by the GOLD is on 4 grades. GOLD 1 is mild, in which FEV1 is more than 80% of the predicted value. GOLD 2 is moderate, which is FEV1 less than 80% but more than 50. GOLD 3 is FEV1 less than 50 but more than 30, and very severe is FEV1 less than 30% of the predicted value. And then there are other symptoms को score करने के लिए एक कहलाता है MMRC, Modified Medical Research Council dyspnea scale, जिसमें आप grading करते हैं just like New York Heart Association NYHA for CHF, जिसमें आप 5 grade लेते हैं from 0 to 4 depending at what point you develop breathlessness. I'm going to skip this, not going into the details because of the sake of time. जो इससे ज़्यादा useful जो tool है, that is called CAT, COPD assessment test, because it is not dependent on dyspnea alone. इसमें और भी symptoms को consider किया जाता है, जिसमें cough है, flame या sputum production है, chest tightness है, dyspnea है, activities at home है, जिसको ADLs कहते हैं. इसके अलावा sound, sleep है, and fatigue, जैसे मैंने आपसे कहा था कि that is something new which has been added recently by GOLD. This is a very important slide. GOLD highly recommends, especially for us, the pulmonologist, that you should use the ABCD assessment tool, जिसमें आप confirm करते हैं कि yes, this is COPD, post-bronchodilator ratio less than 0.7. You assess the airflow obstruction based on the GOLD gold criteria 1, 2, 3, 4 जो मैंने आपको बताए, and then you merge them together along with the exacerbation history and symptomatology. तो symptomatology में you can either use MMRC or CAT score. अगर वो कैट स्कोर 10 से ऊपर जा रहा है तो वो बी एंड डी हो जाएगा, अगर वो कैट स्कोर कम है तो ए एंड सी हो जाएगा. इसी तरह एक्सेसरबेशन हिस्ट्री में आप पूछते हैं कि आप पिछले 1 साल में आप एडमिट तो नहीं हुए बिकॉज ऑफ सीओपीडी एक्सेसरबेशन, या आपकी आउट पेशेंट सेटिंग में एक्सेसरबेशन तो नहीं हुई है. तो इफ 0 or 1 not leading to hospital admission, this is A and B, and if it is more than 2 outpatient or 1 or more than 1 leading to hospital admission, this is C and D. I know this is a little confusing, but it is very helpful for us. So consider 2 patients, both patients with FEV1 less than 30% of predicted value, both with CAT scores of 18, one with 0 exacerbation in the past year and the other with 3 exacerbations in the past year. तो दोनों को gold D according to the prior classification to hai, but with the new refined assessment scheme, the subject with 3 exacerbations in the past would be called gold grade 4 group D, and the other patient jisko exacerbation nahi hui hai, wo grade 4 to rahega because of the FEV1, but it will be group B. So this is important that treatment of stable COPD में आप symptoms को कम करने की कोशिश करते हैं और reduce the risk. So how we do that? I have highlighted in this slide that smoking cessation is the most important part, depending on their exposure to risk factors, and then there are other things mentioned over here. This is a whole list of inhalers and then the devices mentioned over here. I'm going to skip this slide because of the sake of time, but it has conveniently been divided into short-acting agents and long-acting agents. इसमें beta-2 agonist, anticholinergics, और आजकल जो हम use कर रहे हैं वो combined agents हैं, जिसके बारे में I'll briefly talk about it. And this is just a picture I took from the web of the different inhalers available in Pakistan. तो bronchodilators का जो rule है stable COPD में, याद रखिए कि LABA, long-acting beta-2 agonist, and LAMAs, long-acting muscarinic agents, are preferred over short-acting agents, except for very mild disease, जिसमें occasional dyspnea होता है, उसमें you can still use PRN medications as a short-acting. Otherwise, it is highly recommended that you pick either one of the two or combine them if the patients are progressive. Patient may be started on a single long-acting bronchodilator therapy or dual long-acting bronchodilator therapy depending on the severity of the symptoms. Dr. Nadeem Rizvi ने only highlight कर चुके हैं कि inhaled bronchodilators are highly recommended over oral bronchodilators. So you have to educate the patient कि oral bronchodilators के side effects ज़्यादा होते हैं, ज़ाहिर उसकी absorption जो है वो systemic absorption होती है, तो उसमें आपको tremors भी ज़्यादा मिलेंगे, dryness भी ज़्यादा मिलेगी as compared to the inhaled form. Theophylline is not being recommended unless other long-term treatment bronchodilators are unavailable or unaffordable. For this part of the world, I would say that theophylline is still an option, but it is not a preferred option. So you can add on therapy में आप theophylline डाल सकते हैं, ensuring that the patient is using inhalers and is compliant and also the correct techniques. So that becomes very important. तो गोल्ड ने treatment of stable COPD के लिए जो group A है, which is the mild disease, उसमें उन्होंने कहा you can use bronchodilator of any type. They're not pushing you to use short-acting versus long-acting. So they have given you the option that you can use either short-acting or long-acting because the patient has mild symptoms. So you can use it on as-needed basis, जिसको PRN basis कहते हैं. Group B के लिए Gold recommends that you should use a long-acting bronchodilator, जिसमें LABA or LAMA group B में has almost equivalent efficacy. LABA is long-acting beta-2 agonist and LAMA is long-acting muscarinic antagonist. Group C के लिए, the clinical trials have shown that LAMA is superior over LABA, but if the patient has exacerbations or progression of symptoms, you can add LABA. Or the second option is that you can add inhaled corticosteroid. We'll talk about it very briefly. I usually avoid inhaled corticosteroid initially in COPD treatment because of the potential risk of pneumonia, but sometimes you have to add it. And then group D, जो सबसे ख़राब ग्रुप है, जिसमें सिम्टम्स भी ज़्यादा हैं, प्रोग्रेशन भी है, तो उसमें you start with LAMA and then you add LABA plus LAMA, Or, and then the third step, you can add inhaled corticosteroid. और अगर उसके ऊपर भी patient control नहीं हो रहा, तो फिर दो नई चीजें in the last few years which has come up is a PDE4 inhibitor कहते हैं, phosphodiesterase 4 inhibitor, roflumilast. लेकिन इसका अपना criteria है कि patient का FEV1 less than 50% predicted होना चाहिए and predominantly chronic bronchitis phenotype होनी चाहिए. And the second thing which has been on the horizon is the use of macrolide. I have honestly not used macrolide in any of my COPD patient because of the risk. खास तौर पे prolonged QT interval होता है, उसके अलावा जो है drug interactions होती हैं, and you see, you know, other side effects with the use of, and bacterial resistance, of course, because they get infectious exacerbations quite frequently. So, inhaled corticosteroid कब use करें COPD में? अगर patient लाबा और लाबा दोनों पे है और अभी भी exacerbations हो रही हैं या symptomatic है, yes, I do consider the addition of inhaled corticosteroids. If they're having 2 or more than 2 moderate exacerbations or blood eosinophilia. So CBC, simple CBC is a very useful test. तो अगर more than 300 cells per microliters हैं, या फिर उनको एक चीज होती है concomitant asthma, ACOS कहते हैं, asthma COPD, overlap syndrome, then you can use it. जो दो clinical trials in the last 2 years जो publish हुए हैं, one is called IMPACT trial and the other one is ETHOS trial. इसमें they have compared the use of triple inhaler, जिसमें you combine LABA plus LAMA plus ICS versus LABA and LAMA, has shown that there was a trend in a decrease in mortality in the use of triple regimen in patients who have moderately severe to severe exacerbations. And then there was another study that was published in Respiratory Medicine, TRICOP study, जिसमें again show किया गया कि in patients who have moderate to severe COPD, they had improvement in lung function, symptom control, and significant reduction. Anti-inflammatory therapies में PDE4 के बारे में मैं आपको बता चुका कि it is added as one of the last resorts in a particular phenotype who is predominantly chronic bronchitis, very severe to severe COPD, history of exacerbations, long-term azithromycin की भी हम बात कर चुके हैं. एक चीज जो जनरल प्रैक्टिशनर्स बहुत कॉमनली यूज करते हैं वो म्यूकोलिटिक एजेंट्स हैं. Although gold has not is not against the use of it. It is helpful in patients who have a lot of sputum production, or it is sometimes difficult to expectorate because of different reasons. Yes, you can add it, but it is not the treatment of choice. So I'm going to skip this. एंटीटसिव्स का कोई रोल नहीं है. डॉक्टर नदीम रिजवी से पिछली टॉक में किसी ने पूछा था. एक और बहुत कॉमन चीज जो हमारे यहाँ इंटरनल मेडिसिन एंड जनरल प्रैक्टिशनर्स यूज करते हैं कि अगर साथ में पल्मोनरी हाइपरटेंशन है, दे ऐड सिल्डेनाफिल. So there is no proven role of sildenafil in the treatment of COPD associated pulmonary hypertension. जो sildenafil approved है वो group 1 pulmonary hypertension के लिए, and there's some data on group 2. So group 1 को पहले idiopathic कहते थे, unknown cause, and the group 2 is mainly due to the left heart disease. So these are the only 2 indications of the use of bosentan and sildenafil. Otherwise, there's no proven role in COPD associated. Biological agents का के ऊपर कुछ trials हुए हैं, लेकिन ये कि that has also not been statistically significant. Oxygen use has been recommended in patients who have resting arterial hypoxemia, which is defined as the PaO2 less than 55 millimeter of mercury, or SpO2 less than 88, or PaO2 more than 55 but less than 60 with erythrocytosis or right heart failure. And then there are a couple of surgical options that I'm going to skip it, that you can sometimes refer your patients who can tolerate the surgical procedures. So acute exacerbation, I just take 2 minutes. Acute COPD exacerbation is an acute worsening of respiratory symptoms that result in additional therapy that is classified according to the treatment regimen that you give, and you can just Google it. The Rome definition that has been published in 2021 for the acute exacerbations is the most common one. Non-invasive ventilation के लिए indication is respiratory acidosis or clinical worsening which is not responding to continuous bronchodilator therapy and persistent hypoxemia. And if they are unable to tolerate non-invasive ventilation, yes, you have to put them on invasive mechanical ventilation. And there's a lot of data कि आप 1 या 2 दिन rest करके on invasive mechanical ventilation, you can extubate them to BiPAP. Vaccination, influenza vaccination is highly recommended. SARS-CoV-2, recently we had a pandemic. So that vaccination, pneumococcal vaccination, and the GOLD also recommends using vaccine against whooping cough and zoster vaccine. Comorbidities are common in COPD. COPD is now a disease. It's not only a respiratory disease, but it's a generalized disease. Here you can see the picture of the overlap syndromes. जो मैं आपको बता रहा था. You can see pulmonary fibrosis. You can see obstructive sleep apnea. And you can see asthma COPD in combination. And don't forget that the lung cancer is one of the common cause of death in patients with COPD. So if your patient is 50 to 80 years old and who is a current smoker and 20-pack year history of smoking, it is highly recommended that you should go for low-dose CT scanning because chest X-ray is not very sensitive. So this is one of my last slide, that summarizes. We do celebrate World COPD Day. November is the awareness month of COPD. We hold seminars and other activities to create awareness. Don't forget, smoking cessation is very important piece. And then, of course, medication adherence, teaching of the proper use of inhalers, all these things are extremely important. So thank you very much for your attention. I would appreciate if Dr. Irfan kahan gaye? If he can allow, take one or two questions. Oh, he's here. I'm sorry. He's too fast.
Sir has to go, so if you want to ask any question, you're more than welcome. COPD, third leading cause of death. No question. Thank you so much. Thank you, sir, for such a nice talk. Thank you. So our last speaker is Professor Jamal Ahmed. He's brigadier retired and he has served 32 years in Army Medical College, and currently he is working as a professor and head of department in Fauji Foundation Hospital. He has multiple research along with his name, and I welcome him, and he's giving a talk on a very, very important topic of pulmonary medicine. So,
Assalamu alaikum. Bismillahirrahmanirrahim. Today, first of I will talk about multi-drug resistant tuberculosis and extensively drug-resistant tuberculosis. First of all, I would like to thank Pakistan Society of Internal Medicine for asking me to talk about this topic. Multi-drug resistant tuberculosis. Tuberculosis is an infectious disease which is communicable as well and spreads through air droplets during coughing, sneezing, laughing, and singing or whistling. It is caused by genetically related mycobacterium called Mycobacterium tuberculosis complex. I will not go into the details of drug-sensitive tuberculosis because of shortage of time. I will first of all go into different definitions of tuberculosis, resistant tuberculosis. Monodrug resistant tuberculosis is called when there is resistance to one of the first-line anti-tuberculosis drugs. Then there is a polydrug resistant tuberculosis in which resistance to more than one first-line anti-tuberculosis drugs is found, excluding rifampicin and isoniazid. Now, rifampicin resistance is when the patient is resistant to rifampicin, and important point to note is that if we find rifampicin resistance, we treat the patients as multi-drug resistant tuberculosis. And multi-drug resistant tuberculosis is defined when there is resistance to rifampicin and isoniazid. These are two first-line drugs. Then there are other terms. One is pre-XDR, pre-extensively drug-resistant tuberculosis, in which there is multi-drug resistance plus resistance to any of the fluoroquinolones, levofloxacin or moxifloxacin, or second-line injectable drugs which include amikacin. Then there is another term which is extensively drug-resistant tuberculosis, in which there is MDR, multi-drug resistant tuberculosis, and resistance to fluoroquinolones and second-line injectable drugs which include amikacin. And there is a newer definition of multi-drug resistant tuberculosis, extensively drug-resistant tuberculosis, which includes resistance to bedaquiline and linozolid. Tuberculosis is still the 13th leading cause of death, and it is the second leading infectious killer in the world after COVID-19. And in 2020, about 1.5 million patients died of tuberculosis. And out of 10 million people, 56% were males, 33% were females, and 11% were children. And Pakistan is, out of two-third high burden countries, Pakistan is fifth among the two-third high burden countries in as far as drug-sensitive tuberculosis is concerned, and even in drug-resistant tuberculosis also. As estimated, there are about 5.5 new cases of multi-drug and extensively drug-resistant tuberculosis, and 1/4 of these patients have access to MDR treatment. And out of those who get treatment, 55% were successfully treated according to the WHO survey. This multi-drug resistant tuberculosis is mostly found in Russia and surrounding states, and Pakistan. In Pakistan, around 3 to 6% cases of MDR TB are found in the world. There are about 3.3 of the new and 18% of the previously treated treated tuberculosis cases were found to be MDR or rifampicin resistance in 2019, and fluoroquinolone resistance was found in about 20% cases of MDR TB cases. In Pakistan, Pakistan is also fifth among the high burden MDR TB cases, and about 25,000 cases were found in 2019. Now, when should we suspect MDR TB cases? If the patient is currently on treatment, if their disease keep on progressing, or their sputum culture remains positive after 3 months of treatment, or if the patient is not regularly using treatment, or the patient is using inappropriate regime, then we consider these cases as suspect multi-drug resistant tuberculosis in these cases. And if the patient does not have prior history of tuberculosis and they present to us with an exposure to, if they have exposure to an individual who is suffering from tuberculosis, a case of MDR TB, if they have near relative of MDR TB cases, or they are resident of a place where MDR TB cases are found, we consider them, we suspect multi-drug resistant tuberculosis in these cases. As far as the drugs are concerned, isoniazid and rifampicin, these two drugs, resistance to these two drugs is considered as multi-drug resistant tuberculosis, and isoniazid inhibits cell wall synthesis of the mycobacteria, and rifampicin inhibits messenger RNA synthesis. Now, there are two types of resistance. First is primary resistance, in which mycobacterium shows slow constant mutation resulting in mutant strains which are resistant to these drugs. And the other one is acquired resistance, which is very important to know. It develops as a spontaneous mutation in the genes, and this is due to suboptimal drug therapy, which is very important. If the patient is having multi-drug resistant tuberculosis, or and they are not adequately treated, or if the patient is drug sensitive tuberculosis and they are not adequately getting treatment, they can develop drug resistant tuberculosis. The organisms, mycobacteria, develop resistance because of mutation in different genes which inhibit entry of these antibiotics or action of these antibiotics into these bacteria. As far as symptoms are concerned, patients with MDR TB, they have similar symptoms of drug-sensitive tuberculosis, but these patients keep on their symptoms keep on progressing despite irregular or regular treatment of drug-sensitive tuberculosis. And at the time of diagnosis, usually the disease is very advanced. For diagnosing multi-drug resistant tuberculosis, first of all, we do acid-fast bacilli staining with and fluorescein microscopy. If we find mycobacteria, then we ask for gene expert test. Gene expert is an nucleic acid amplification test which checks DNA within an hour or two, and it detects Mycobacterium tuberculosis. And the second part is detection of rifampicin resistance. So this gene expert tells us about rifampicin resistance, and if we find rifampicin resistance, we consider these patients as multi-drug resistant tuberculosis and start treatment according to the guidelines. The other important test is line probe assay, which is similar to this gene expert, and it detects isoniazid resistance in addition to rifampicin resistance. Then we also ask for acid-fast bacilli culture sensitivity to check for drug sensitivity testing also. This is an X-ray chest of a patient of MDR TB in which the disease is advanced. There are multiple cavities in both lungs. This is HRCT scan of a similar patient with advanced disease. Now I will go into the treatment part of MDR TB. As far as treatment is concerned, multi-drug resistant tuberculosis is treated in programmatic management of drug-resistant tuberculosis according to the WHO guidelines by specified centers of National TB Control Program all over the Pakistan. There are around 31 centers where drugs are provided free of cost, moxifloxacin. These regimes are used for 6 months and have been effective in more than 92% of cases of MDR TB. The second and the third regime, short-term regime, is for 9 months, in which intensive phase is for 4 to 6 months, which include bedaquiline, linozolid, high-dose isoniazid also used, ethambutol, pyrazinamide, ethanamide, and clofazimine. And these 4 drugs are used for next 5 months after conversion of sputum to negative. Then if the patients are not included in the short-term regime, short treatment regime, then we use long-term regime. And for preparation of long-term regime, we add these drugs from group A. Then we choose drugs from group B. And if we require another drug, then we use drugs from group C also. These are different long-term regimes which are being used for treatment of multi-drug resistant tuberculosis. Intensive phase is for 6 months, and then after conversion of sputum to negative for 12 months. Total of 18 to 24 months of treatment is used. And in another regime, which is long-term 2 regime, in which there is moxifloxacin. This is for basically for pre-XDR tuberculosis, in which there is resistance to moxifloxacin or levofloxacin. And the third long-term regime is for XDR tuberculosis, in which there is resistance to moxifloxacin and amikacin, second-line injectables. In multi-drug resistant tuberculosis, the patient has resistance to MDR TB cases. In these cases, we start with drugs which can penetrate through CNS. For management of multi-drug resistant tuberculosis, it is very important to monitor the cases regularly by clinically assessment is done and audiometry is done if the patient is using amikacin, and then culture sensitivity is also done monthly. Then certain tests are advised, and all these management is done in PMDT sites of where management of tuberculosis is done by National TB Program. Surgery is indicated for multi-drug resistant tuberculosis after about 2 months of treatment, And important point to note is that it is not considered in bilateral extensive disease, but if the patient has localized disease and there is a cavity formation which is not improving, then surgery is considered. These are different 31 sites where treatment of multi-drug resistant tuberculosis is done in Pakistan, all over Pakistan. And drugs which are used for management of this multi-drug resistant tuberculosis, these drugs are not, number of these drugs are not available in the market. And the patients are being monitored and they are being given financial support over there. So I suggest if we find a case, we should refer the case to these centers for proper treatment, and their counseling is very important. Still, there is low detection of MDR TB cases. There is high loss to follow-up cases, high death rate due to delayed enrollment, poor contact screening, which is being managed by an NTP. And globally, there is incidence is falling at a rate of 2% per year between 2015 to 20, but it is halfway to the NTB strategy is laid down by WHO. This app is available on Android and iPhones, which can be very helpful to find out the guidelines of WHO guidelines about management of tuberculosis. These are different references which, from which I made this presentation. I thank you all for patient listening.
Thank you so much, sir. So, any question? Ji, sir.
Is there any legislation very compulsory isolation and treatment of multi-drug resistance, especially XDR?
Sir, isolation is very important, at least for 1 month, and isolation is recommended as we have been doing isolation for this COVID, in which patients are asked to wear masks when they come to the public. They use hand wash, and attendants should also use these observations for at least 1 month. If the patient is on MDR tuberculosis, and if the patient is drug sensitive tuberculosis, even they are pulmonary tuberculosis, then at least 2 weeks of isolation is important. And isolation can be done by wearing face mask and hand washing, as we have been practicing for this COVID pneumonia.
Dr. Jamal, is there any correlation with HIV as well for multi-drug resistance? Because atypical bacteria, we know that they are more likely to be in HIV patients.
Yes, HIV. In HIV, the disease progresses rapidly, and there is chances of drug resistance is also very common, because treatment becomes more difficult if the patient has HIV.
So do we have any data, local data?
No.
No. Thank you.
Mr. Jamal, may be riddled with cavities, that person is expectorating pus, you see, purulent expectoration, but he is not running any fever. What is the status of drug therapy at that stage of disease, if it occurs?
Sir, at times patients of pulmonary tuberculosis, they get treatment, and the tuberculosis is controlled with the treatment, and the lungs which are damaged, they keep on damage in the lungs keep on persisting. And in those cavities, patients develop recurrent chest infections, even they develop aspergillomas, and recurrent infections can occur, bacterial infections and fungal infections can occur in these cavities, in those patients. And even they go into respiratory failure and other problems.
Maybe some cases they used to be resistant to the anti-tuberculous drugs, or the immune system is absolutely destroyed, that even drugs don't act on these cases.
At times, patients develop resistance to these drugs if they are inadequately treated with anti-tuberculosis drug. Chances of resistance is more in these cases.
Thank you for your nice presentation. There are some cases of chronic liver disease. They have cirrhotic patient, they have operated, they have done their liver transplantation, now they are on immunosuppressant drugs, and unfortunately some of them having the tuberculosis that reactivate and become multi-drug resistance. In those patients, what medication we should give?
Drugs which are, these patients require close monitoring of their liver functions, because certain drugs act on they are toxic for the liver. In first line, especially first line drugs are toxic for the liver, which include rifampicin, isoniazid and pyrazinamide. Second line drugs, they can be used with caution, and I think these drugs can be used in chronic liver disease also. But close monitoring of the liver functions are important for management of this case, because multi-drug resistant tuberculosis is a serious threat for those patients. It should be treated properly.
Thank you so much. So may I request our chairpersons to kindly have a few comments on these talks. Professor Shamsuddin.
Bismillahirrahmanirrahim. First of all, I must congratulate the organizers of Pakistan of Society of Internal Medicine, especially Aftab Mohsen and Secretary Sumia Iqtidar, under the patronage of Professor Javed Akram, for organizing such an informative conference, and I wish them success in further few days also. Thanks to them for inviting me to be a chairperson of this session. Appreciation to the presenters, Professor Nadeem Rizvi, Professor Ali Zubari, and Professor Jamal for their nice presentation on to the topics, though they are common but very difficult to handle. हम एक चीज़ यही देखते हैं कि हर कॉन्फ्रेंस में, हर सेमिनार में, या जब भी कोई एक डे मनाया जाता है, कि we found that the number of patients is increasing in all the diseases or all the conditions, whether it is diabetes or hypertension or asthma. ये क्या हम सबकी नाअहली है? नहीं, खुश होना चाहिए. हमारे मरीज़ लंबी उम्र पाते हैं, इसलिए वो लंबी ज़िंदगी जीते हैं. And there is a further add-on of the patients also. As far as the asthma and COPD is concerned, they require the treatment or management adequate to make their life comfortable. They should be symptom-free, and again the attack should not occur of asthma or COPD, but you can't change the environment, you can't change or alter the environmental pollution, though we can advise them to manage their habits, especially smoking. They should avoid smoking. तो बहुत सारे मरीज होते हैं, और राइटली सेट के इसमें इंतज़ार नहीं, आहिस्ता आहिस्ता नहीं, एकदम से ये जंप मारेंगे तो बचेंगे, वरना तो फिर ये बढ़ता रहेगा. और जहाँ तक मल्टी ड्रग रेजिस्टेंस ट्यूबरक्लोसिस की बात है, कि हम भी खुश हो रहे थे कि ट्यूबरक्लोसिस का इंसिडेंस कम हो रहा है, लेकिन MDR और XDR tuberculosis, the number of patients, they are increasing. Again, वो isolation की बात हो रही थी कि isolation, it appears to be futile exercise, because we never know that how many patients he have infected in the past few days. So anyhow, we have to treat those patients with adequate treatment. जहाँ तक duration की बात है, तो I will prefer to go for the long duration rather than shorter duration. ये सब दूसरे ममालिक के चौंचले हैं. हमारे यहाँ एक लॉन्ग टर्म पूरा वो जो 20 या 24 महीने तक ट्रीटमेंट होना चाहिए, और बेहतर यह है कि इट शुड बी डायरेक्टली ऑब्जर्व ट्रीटमेंट एक्सेप्ट द वीकेंड्स, कि आप उस दिन के लिए एक दिन की दवाई दे दें उसको कि वो घर पे जाके खा ले, अदरवाइज़ वो. लेकिन वो ट्रैवलिंग फैसिलिटीज़ या उसके ट्रबलसम, और ख़ास तौर पर जो XDR ट्यूबरक्लोसिस है, दे आर वेरी मच इपैथिक उनकी कंडीशंस होती है. तो बहरहाल हम लोकल मैनेजमेंट करके उनको मैनेज कर सकते हैं. वंस अगेन थैंक्स टू द ऑर्गेनाइजर्स, and now I will hand over the mic to my other chair.
Assalamu alaikum. I would echo the appreciation of the organizers, as has been expressed by the chair, regarding the talks. Professor Nadeem Rizvi, the message to carry home was that in asthma is a different subject, and it is not just prescription writing. It is the delivery of the drug, the choice of the drugs, as well as the choice of the delivery system, because there are numerous gadgetry available, and it is there is many slip between the cup and the sip, and hence asthma is a different ball game. Then there was a very, very comprehensive presentation by Ali Zubari, and he ran through the whole structure of the recent COPD guideline of 2022. One thing I just note is that there has been the mortality of COPD may not have decreased during this time, but during the pandemic, the recurrences of acute exacerbations have significantly gone down, not only in the West, but I think we have also appreciated that. So what can be the reason other than the shielding, the masking, the lesser social contact, and more attention towards drug taking and health? So this shielding has been noted by the guideline 22, and they say that for aged people, which most of COPDs are, the doctors should try and advise them to continue shielding even otherwise of the pandemic. The other thing was that stress has been on an integrated risk assessment, which very clearly Ali Zubari told us that the importance of vaccinations, which has again been stressed, including the COVID vaccine, other than the pneumonia and the flu vaccines, and the DPT. Another trend has been identifying the predominant trait. Like we used to talk about A and B type of COPD, the blue bloaters and the pink puffers, that became obsolete. But again, attention is being paid to the predominant trait, and then the importance of blood eosinophilia, because when we decide for introducing an inhaled corticosteroid for the COPDs, the blood eosinophil count, if it is higher than 300 microliters, it is important that we should definitely do that. And if the count is pretty low, less than 100, then it is contraindicated, because more infections are often also seen in this low eosinophil count, like the Haemophilus, etc. The rest of the whole guideline has been discussed by Dr. Ali Zubari, including the importance of screening for lung cancers in COPD by the CT scans, low strength CT scans. The third presentation has been the most, I'm surprised how Brigadier Saab could handle it, and he handled it wonderfully. The whole gamut of MDR-TB he introduced. The topic is good for a 3-day workshop, I guess. To end this is that news which is exciting, a little exciting, that the WHO has sent an advance communique on the 2nd of May, such that the drug duration of the BPAM, as we call it, the pediculin-related protocols, has been shortened to 6 months. So 6 months MDR TB with this particular drug protocol, and this would also cover the XDR as well. So these were the important news that has just been received. But it was an excellent presentation. I think we have learned from all of these presentations. Thank you very much.
Sir Javed, sir.
Thanks very much. I wish to thank the organizers for inviting me. I think my colleagues had commented on the presentations. I had another request to the organizers. It's an excellent program. It's very, very busy. Pulmonary medicine has just, through our session, I understand the time constraint. But if you look at the 30% of emergency room visits are due to pulmonary medicine, due to respiratory diseases. Your own clinical practice is that pulmonary diseases is one of the top ones. Unfortunately, COPD is the only disease which the prevalence is increasing in the world. Number 3, it's underdiagnosed, it's undertreated. So we need to pick up those cases. Asthma is on increase. We do not treat asthma. We do not diagnose asthma in our community. We have cases which are difficult to treat asthma. They linger on from one clinic to the other clinic. I think we need to diagnose those cases which are underdiagnosed. Asthma management requires a lot of efforts, a lot of education. I think, I thought Professor Rizvi is going to talk about beyond prescriptions. It's education. Education of the patients, education of physicians, which is much more important than the patient. It's not mere writing a prescription that you give it, it's how to use it, how to recognize it. Another aspect is the perception. What the patient has a perception of a control of asthma. Everybody has a different perceptions. We need to make it clear as a doctors. We need to know ourselves what is our objectives, what are our goals in the management of asthma. It's very easy to give all the medications which are available, but the right medicine for the right patient and the right use, that's fundamentally important. The last thing, I was shocked. I will use the word shocked and surprised when I came to Pakistan in 2018 and I contacted the TB control program. Do you have any strategy for prevention of tuberculosis? None. None at that time. 1 in 10 in Pakistan is having latent tuberculosis. You have a huge pool from you're getting the active cases. What do you do for them? Nothing. Practically nothing. Until recently, this year, they have initiated our preventive program. 60,000 severe positive TB patients were missing for treatment from Lahore. This is the lab, this is a global fund. I think it's a disaster. They are the time bomb. They are the ones who are spreading the disease everywhere because they are diagnosed but not treated. They are not followed. I think the message from this platform I would request the organizers is awareness, give little more time to the respiratory diseases, create more awareness to diagnose those cases, appropriate use of medication in all cases. Please do not forget, if you have a difficult to treat asthma, which is less than 5% of all the asthmatics, send them to somebody who has a more experience of manage those asthmatics. Again, at the end, I wish to thank the organizers. It was an excellent program. Thank you very much.
Thank you so much. Thank you, sir. Rightly said, education, awareness, and evidence-based medicine as a theme of this conference. I thank all of you for patience listening, and a short announcement is you will have a tea break, and after 20 minutes you have to be here for a behavioral science lecture in Pakistan Society of Internal Medicine. Thank you so much. Thank you.
Please kindly be seated. Bismillahirrahmanirrahim. We are going to start the next session. It is about evidence-based medicine. As our Prophet sallallahu alaihi wasallam said, आपके झूठा होने के लिए इतना ही काफ़ी है कि बगैर तस्दीक के बात को आगे फैला दें. So, for us, for doctors, it is we are the liar if we are writing any medicine without evidence. So this, I would like to invite to chair the session Professor Iqbal Afridi. He is FCPS, FRCP, and he is Dean of Psychiatry CPSP. He is Dean of Jinnah Sindh Medical University. He is Professor of Psychiatry. He is ex-President Pakistan Psychiatric Society. Please welcome Professor Iqbal Afridi. Right to second chair, he is Professor Muzaffar Sheikh. He is Professor of Medicine at Liaquat University Medical and Health Sciences, Jamshoro. He is President PSIM Hyderabad chapter. Ladies and gentlemen, please welcome Professor Muzaffar Sheikh. Sir, please be seated as a chair. The speaker I am going to invite for this evidence-based medicine, he is a renowned person already. You know, if I took his name, you will recognize that the whole portfolio of that person with his name. His name is enough. But I will say, खुद ही को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से खुद पूछे बता तेरी रज़ा क्या है. He is working on the khudi, the psychological aspect of the khudi, and he is having a series of YouTube lectures where he is telling you what is behind the neurosciences of every emotion and how to achieve the self-awareness. So this chapter, this lecture is one of the component of that thing, that you must recognize your potential and you should identify, you should be self-aware what you are writing, how you are writing. So I would like to invite the Professor Muaddad Hassan Rana. He is FCPS, MRC, FRC Psych. He is gold medalist. He is honorary chair in many, I was searching, he was honorary chair in many institutes, in many positions, even in UHS. He is dean, honorary dean, and he is having uncountable research articles. He have written a textbook. Very few people have written the textbook. He has written the textbook of behavior sciences. And other thing, he got the Stara Imtiaz. No one among us had got the Star Imtiaz. Ladies and gentlemen, please welcome Professor Muaddad Rana.
Bismillahirrahmanirrahim. Honorable Chair, Professor Javed Akram, dear friends, colleagues, what a huge honor it is to be invited to the Society of Internal Medicine's conference. It's not often that psychiatrists get this privilege of finding their lost resource in medicine. In many ways, we are a bridge between the psychosocial care and the biomedical model of practice of medicine. So when my very dear friend, my old-time buddy from medical education, Professor Aftab Mohsin, asked me to be part of this activity, I felt hugely privileged and honored. And then I asked, what is the theme of the conference? And he said, evidence-based medicine up now. So I sent him probably my title of the talk within about 10 or 15 minutes or so of that particular iconic theme of the conference that he had chosen for this activity. Long time ago, 1977, ladies and gentlemen, many of you wouldn't have arrived in this world, particularly the females in the hall would not have been around surely. So around that period of time, I was waiting for my admission into the medical college, and suddenly I got a call from Army Medical College to join, which was in Rawalpindi, and we were to go there as the first batch of Army Medical College. I had not left home by that time and was so used to the comfort of living with my parents that it immediately struck me that from here on I am going to leave my apne. But the stare in the look of my parents said, out you go. I think they had had enough of it by that time because of my long hair and rather a wild state of mind that I used to have at that point in time. So I was thrown out into the realm of Army Medical College and hostel life, and I immediately felt that the first movie that I'm going to see, which was coming around that period of time, was titled this, Apne Hue Parai. Probably Professor Javed Akram might remember this movie from 1970s. The reason not only was the title of the movie, but also because of the fact that Sangeeta had recently come into the film industry and I was one of her fans. Amongst the millions of Pakistanis, she was a heartthrob of that time. If you see today's Sangeeta, you wouldn't recognize the Sangeeta that we had seen in those times. So I went to see this movie. But all that I really focused was Sangeeta. Didn't really saw much of the rest. Up now, evidence-based medicine, ladies and gentlemen, brings to you many questions. And probably those of you who are sitting here in this hall are going to see more and more of millennial and Generation Z postgraduate medical trainees as well as undergraduate medical students asking you questions which we as the baby boomers were not supposed to ever. The professor was a demigod in our times. So when he looked at us, we trembled. But today's medical student, today's postgraduate trainee is far cry away from that model of the teacher and the taught. And if you haven't come across this particular scenario so far, I can assure you that you would. Just have a read of this scenario. Now this is from psychiatry, but I'm sure this is not a very unfamiliar situation. This is something that has happened and is a reality. Just read through it, probably with the lens of a physician. Have you read it? Okay, I can surely tell you what would have happened in 1980s. This was the last day of this training, on the training. But while you're reflecting on what would happen now in this situation today, I remind you of this movie. I later on realized that there was much more to this movie than Sangeeta. So similarly, you would realize that there are more and more stakeholders and players today in evidence-based medicine than what we used to have at that point in time earlier in my career, and probably many careers in this hall. Have you thought about this? particular scenario that I had just posed to you, this particular scenario. Now, what do you think would have happened? Suppose this is an undergraduate medical student, not a graduate, postgraduate medical student. Would the professor of today have the guts to tell him to get out? No, sir. He has just deposited more than $1 million as his annual fee. And how dare you say that? So this is a changing word, sir. Anything and everything today is fluid. There's nothing like gospel anymore in medicine. And I'll try and show to you that for all practical purposes today, even evidence-based medicine is not a gospel. And the next couple of minutes that I have at my disposal, I'll try and highlight to you some pitfalls and some things to remember while you are in a state of apnao. Keep few things in mind, and you would find that you are now going to deal with more and more apne who are going to get parai during the course of their trainees. There are several difficulties with evidence-based medicine, ladies and gentlemen, and I'd be very happy to share the references that I've used to compile these cons in front of you. Have a read of them. Now, there are more and more challenges looking at the meta-analysis that have come out and have been used in guidelines. And more pitfalls in the design of RCTs are being found. And there are today many who would challenge the authenticity of a randomized controlled trial, which for you and me is a gold standard. Or is it not? This is the gold standard. And this is what we use in meta-analysis. So the issue is, if you're going to use a defective RCT to develop a guideline, what will happen to those who will adopt that guideline? So surely RCTs is no more the final word. It's being challenged around the world, the authenticity of RCTs. Now, the second query here is, can you have an RCT on virtually every scenario that you and I are going to face? Let us look at the life of somebody who is in Thal desert somewhere practicing medicine. And that is a situation that is going to arise in the days to come. Can he borrow a recommended guideline from NICE to be practiced in Thal, in those realities? That's a question that you can sit and ponder on. Is this professor not feeling challenged that his whole experience is being challenged through a mechanistic reasoning offered in the smartphone? Yes, sir, ye aap kya kar rahe hain? Ye dekhiye kya guideline mein likha hua hai. So, what is going on in the mind of this gentleman who has spent about 30, 40 years of his life in medicine, or in psychiatry for that matter? The values of the patient, the local patient. What are his values? What is his understanding of chemotherapy? What is his understanding of a drip or an injection? How does he interpret the recommendations that are made in evidence-based medicine? So these are challenges that you need to keep in mind. Is this really an ivory tower? Hard to climb. Ungettable sometimes. Those standards that are set somewhere in the corridors of power in the West, तो कहीं एविडेंस बेस्ड मेडिसिन भी किसी गुलामी की कैफियत का नाम तो नहीं है? आजकल गुलामी का बड़ा जिक्र है. There's a question to be pondered on. Think about it. Then, of course, is this issue. health economics is one of the serious considerations when you're making an international guideline. So, which health economics are we talking about here? Where the allocation for a psychiatric patient in Pakistan today, would you be surprised, ladies and gentlemen, if I told you that Pakistan spends 1 rupee and 8 annas? I would still like to stay in annas because it's ridiculous the amount that you're spending on the mentally ill of Pakistan. 1 rupee and 8 annas today. While we are making institutes for liver and kidney transplants and heart transplants and whatnot. That's what you spend on mental health. So, health economics. Every guideline that you would pick up is going to emphasize primarily on the medication or some intervention that has been recently devised, a radiological intervention or a surgical intervention, or whatever you have. How many of those guidelines are going to emphasize on psychosocial care? Very few, probably. Very few. A largely biomedical model that is still in practice, although we know that the biological reality of disease is probably grossly overestimated in many clinical situations. You know it and I know it. But probably the easiest way out is to just focus on the biomedical concepts in a patient's life and prescribe and tell him to leave your office. Our way of telling our patients to get out of the clinic is to hand him over your prescription. It's your way of saying goodbye to him. Ye lein aur jaएं, and rest could be history. Now, recently, when we were fighting the COVID-19 crisis, were we not really actually killing patients and then learning from why they got killed? Many of them died, you and I know, of iatrogenicity rather than the virus. And please do tell me if I'm wrong at the end of my talk. Did we or did we not contribute towards the accelerated death of our patients in COVID-19? Why? Because we didn't have any evidence-based medicine to practice. So we were learning as we went. And nobody is going to undermine that colossal effort that the medical community has made in fighting this menace. And I'm not here to undermine that. But let us look a little deeper and search a little deeper into our souls while we are reflecting on the practice of pulmonary medicine that went around at that point in time in COVID-19. Now, before you start to consider me an anti-science psychiatrist, there are several advantages of evidence-based medicine. So I'm not challenging it, don't apnao. There are several advantages listed in front of you here. And what I love most about evidence-based medicine is that it will probably let every prisoner who develops thrombolytic issues and platelet count disturbances to go out of Pakistan whenever he or she develops that kind of an issue. That's what the equity of evidence-based medicine is. It doesn't distinguish between the powerless and the powerful. A great equalizer that evidence-based medicine is. So don't think that I'm challenging its authenticity. No, there are. Obviously, the empiricism that is shown is very democratic. What do? You take out the best evidence, a particular intervention. When you are about to introduce it into the guideline, you democratize the RCTs. And then you bring in the one that has gotten the maximum votes. I've always wondered how empirical actually science is going to be if it starts to vote for what is right, rather than think philosophically of what could be right. There's a lot of difference between the two, and it's a subtle issue, ladies and gentlemen, that I'd like you to reflect upon. in some ways we are democratizing science. There are more people saying this, let's believe it. Democracy is fine, but remember, it is the best of the worst ways of governing. Many political scientists would tell you that. This is the best out of the worst, or the worst out of the best. That's what democracy is. And you are about to bring it into science, into empiricism. So therefore, it might be a good idea to actually review the whole concept of empiricism being challenged by democracy, and how the two are going to interplay now, and how they are going to interact, and what will be the sons and daughters of this marriage of convenience between democracy and empiricism. Again, a question that you need to sit and ponder. Probably I'll leave more questions for you than I answer by the end of this talk. My serious issue is that if a clinical trial proves a pathophysiological theory wrong, would you have the power, would the professor of physiology and professor of pathology prevail upon the evidence-based guideline? Because it has challenged the pathophysiology of that particular disease? Do you think there's any pathophysiological basis of the use of H2 blockers in every patient who comes to tell you कि मुझे खाना खाने के बाद डकार आते हैं और मेरे पेट में गैस हो जाती है? Is there a pathophysiological basis of prescribing omeprazole to this patient? You can call me an ignorant psychiatrist, doesn't understand the pathophysiology of gastroenterology. But I did my MBBS. And I know that dyspepsia does not augur for a prescription of omeprazole. No, sir. Pathophysiology wouldn't support this idea. Yet you and I probably are writing omeprazole right, left, and center. Because the guidelines say, go ahead, you can give it in dyspepsia. Think about it. Would you be able to stand in the court of law and defend your action on the basis of a pathophysiological theory? Probably not. So, issue of bias in our studies. Now, how biased can a scientist be when the issues related to designing an RCT depends upon the funding resources that he has? So one of the major issues today of research in the West is how much funds do you draw and from where? So would that introduce any kind of bias into your work, sir? Or would it not? Or was it just coincidental that all the profits were poor? Try to connect the dots between the two. Now, do I have an answer to the professor? Yes, sir. I have a recommendation, not an answer. I think this is the time for all of you, the scholars of internal medicine, the brain of internal medicine in this country, to actually consider, as my teacher, Professor Bashir, used to say, please do not think that West is synonymous with best and East is synonymous with beast. No, it's not. There is probably more and more need to go to that physician who practices in Thal, and maybe he has some wisdom to teach you. It could be qualitative, not quantitative. He may not be able to design an RCT sitting in those remote areas of Pakistan, but he might have accumulated wisdom that needs to be taken on board, which the RCTs lack or would never have. There is a need probably to bridge the gap. Right now, the one is clearly winning because of the democratization of the science, and the other is constantly losing ground. See, if you're not going to Link up the two. The science will die, sir. Funds will win. And the truth that can be bought no more is truth. Please, costs and care, very important. But keep the concept of equity that I had raised earlier in front of you. Now, what can be done? It's a very humble suggestion by a student of medicine for you to consider. The Apna model, the Apnao model, what I would call a deliberative model of care. Can we ask this young trainee to come to your office? Can you ask the patient and the family to come to the office and sit around a table, a round table where everybody is equal, and the professor no more is the demigod, and around this table are the possible stakeholders and the concepts that are playing role in generating disease in this patient. All brought around together. Look at the pluses here and see how many considerations are being made before you decide whether it is going to be clomipramine, SSRI, or CBT, which is a form of psychotherapy. Would it be only one of them? Could they all be combined? Could it be just SSRI? Could it be just CBT? Or can the wisdom of the professor prevail and clomipramine is the answer for this patient? But let it not be decided because the good professor thought so. And let it also not be decided because the postgraduate trainee represents the Young Doctors Medical Association. Let those not be the considerations when you make, ladies and gentlemen, a scientific decision. Let it be a judgment built around science, evidence, values of the patient, the realities of Pakistan. And above all, let this be an informed choice in the language that the patient and the family best understands. Ladies and gentlemen, thank you very much.
Sir, thank you very much. Questions will be at the end. Sir, thank you very much for enlightening us and giving us the insight that not only the evidence-based medicine, but we have to have our own Apna model. Sir, whenever you talk, I always have one dedicated poetry from the Bulle Shah for you, always. Sir, because whenever you talk, you tell us a different aspect of that thing as well, just like you did with the evidence-based medicine. It's the Parpar Alam Fazal Hoya, apne aap nu padya hi nahi. Dor dor varda mandar masita, apne man vich varya hi nahi. Sir, thank you very much for enlightening us and seeing our man. Sir, thank you very much. Big applause for sir. The next speaker is, as the corona came and the more and more digitalization was there, we have seen a lot of persons, medical persons using computer, and there were a lot of software were there who were making the diagnosis, just like this dermatology software. We don't need, I think in future we will not be needing dermatologists to make the diagnosis. Just a picture can make your diagnosis. So there are a lot of improvement, a lot of new things in this field as the artificial intelligence is improving. I will give you one example. In 6 hours, artificial intelligence just figure out 6,000 chemicals that can kill you. 6,000 chemical warheads in just 6 hours. what will this artificial intelligence, machine learning will do, the nanotechnology will do. So the next topic is being presented by the Professor Muhammad Tariq. He is MRCP, FRCP, he is Professor of Internal Medicine at AQU. He is Associate Dean Education and Chair Department of Education Development Program. He is also a Director Postgraduate Program at AQU. Please, ladies and gentlemen, for next talk, please welcome Professor Muhammad Tariq. Please, sir.
Bismillahirrahmanirrahim. Assalamu alaikum, and thank you for inviting me for this talk. Is it working? Okay. So today I was given this title, or maybe of my talk, Innovation in Medicine, Current and Future Medicine. So I was thinking, what should I talk about here? So what in my mind, clinical care and clinical teaching, learning and assessment and training of the residents and medical students goes hands in hand. So whenever you talk about clinical care in an academic medical center, I think the training aspect of the care, I think, need also to be discussed. So my talk would be focusing on the innovations in clinical care as well as teaching and learning. So I have no financial interest, arrangements or affiliation that would constitute a conflict of interest. I think this is a mandatory slide when you are working at AKU. So I will include always. So some background about the history of medicine. It shows that how approach has changed from illness and disease from ancient times to the present day. A number of new technologies, a number of new things, like as just said, that artificial intelligence is there, nanotechnology is there, precision medicine is there. Number of things are there, and again, assessment modalities of students and residents, online assessment, online teaching, online learning. I think number of things are coming up. So present medicine is changed. The Hippocratic Oath was written in ancient Greece in the 5th century, which is direct aspiration. Still we use that. Innovation of microscope was consequence of improved understanding during the Renaissance. And prior to 19th century, humorism was considered as, and which is replaced by germ theory later in 19th century. And military doctors started to do some surgeries in trauma, and then the concept of surgery begins. Public health measures were developed in 19th century, which rapidly grew. Advanced research centers opened in 20th century, and then connected major hospitals. Mid-20th century, antibiotics were introduced. So that was a new era which came. And these advancements, along with development in the chemistry, genetics, radiography, led to modern medicine. And medicine was heavily professionalized in the 20th century. So this is some background where how it started, maybe very early in the Egypt, in India, and in China, I think medicine started. And then Muslim civilization, Muslim doctors, a number of, they worked on a number of things. And then slowly and gradually, UK and US and other areas in the Europe, and they took all those, and then structured medical practice started. So you see here, this is William Osler. You see, he is inspecting, he is palpating, he is auscultating. And here what he is doing, he is contemplating. He is just standing there and thinking about the diagnosis, about now what I feel that so many, or a number of technology would come. Yes, definitely would come. Artificial intelligence would come. But still human mind would remain a major thing in the diagnosis and management of the thing, because the artificial intelligence again would be guided by the human mind. So whenever you have a complex patient, what I do usually when I'm seeing a complex patient sitting in the special care or high dependency unit and having difficulty in diagnosing, then stand there and think about thinking process, contemplation. So that's what William Osler was doing about maybe 100 years back. And then you get some good ideas from students or maybe a resident, and then you come up with the diagnosis. So history taking, physical examination, patient communication, clinical reasoning skills, approach towards the patient, professionalism, all learned in clinical setting. And clinical teachers in an academic medical center, a clinical teacher and a clinician. So there is a difference between a clinician. I strongly believe that a clinician is a person who diagnoses a patient. And a clinical teacher who holds a degree, or maybe who holds an academic title like assistant professor, associate professor, or a professor, that person has the responsibility of diagnosing a patient as well as diagnosing the ability of the learner. So हमारी responsibility is सिर्फ patient care तो है, लेकिन हमारे साथ जो students and residents हैं, I think we need to train them as well. So now about some new innovations which we are more interested in today. So artificial intelligence. What is artificial intelligence? Artificial intelligence is basically a computer or machine learning. The machine is fed with a huge amount of data. You can see a data is fed. A machine is fed with a huge amount of data, and then machine diagnose a patient, maybe develop a treatment plan through an algorithm or a number of things. So that's a machine learning which is now coming up and up again. But in some of the specialties, particularly in cancer management and in cardiovascular, early detection of some of the cardiovascular diseases, it has been used. In some drug discovery, it has been used. But I think a lot need to be done because a significant cost may also be involved in incorporating this artificial intelligence into the clinical practice. So you see, artificial intelligence is a branch of computer science capable of analyzing a complex medical data. But still, I think you need to feed in that data where human person would be needed. So I think without human, you may not be able. Their potential to exploit meaningful relationship with data can be used in the diagnosis, treatment, and outcomes. Machine learning can be create algorithms by using large amount of patient data and information. As I already said, algorithm can be used to get earlier and better diagnosis and to tailor treatment and management plans. And current examples include faster and more accurate review of mammograms, early detection of heart disease, and drug discovery mechanism, and a number of papers published. Number of people are doing in the West the artificial intelligence but I think still a lot need to be done. This is just in its infancy, artificial intelligence. But I think it is a potential for the future. And for that, we need to look up for new clinical trials, maybe new research, that how artificial intelligence can be. And then we need also see how cost effective it would be. So that's again a very important question I think we need to look into. And you can see here again in cardiovascular disease, it has been used and then artificial and cancer research and precision medicine and drug toxicity and safety. In these circumstances, it has been used with potential benefits. But I think again a number of new research modalities are needed to incorporate it into practice. What is precision medicine? Precision medicine is an individualized or a personalized care. This is also coming up very much into the cancer research. But in other research, again, it is being used. Precision medicine is a personalized, individualized care, keeping in view the genomes and genetics of an individual. So an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. So the treatment modality or the diagnostic approach could be personalized for individual patient. One patient with a similar cancer, another patient with a similar cancer, or maybe any other disease, where if you are using precision medicine, the treatment may be individualized. So that again would need a genomics and gene identification. Again, a significant cost may be included into it, but I still maybe in future it may be a good potential. Treatment can be personalized based on one's background rather than using universal plans. And again, in oncology research, it has been used. So you see here, this is a traditional medicine. The group of people are treated with a medication therapy, adverse events for all, no benefits for all, maybe benefit for all. So this is a traditional way of managing. Stratified, maybe if you see a person is from any specific background and look at those things, and then maybe a stratified treatment, then you can have some group benefits on those adverse. Precision medicine, you look at the individual patient level, genomics, lifestyle, history, health history, medical records, and a number of other things. So, and then you identify and do a treatment plan for that individualized patient. Not easy. It's very difficult, but I think it's coming up in future. So just I wanted to highlight precision medicine here. Again, review of precision medicine, cancer patients, number of literature is coming up, and in complex medical conditions, again, precision medicine is coming up. So individualized care, precision medicine for complex patients. Currently, only cancer patients are using in some instances, but but again, the future, we may see more and more of precision medicine. We may not see, but it would depend on all the clinical trials and research which would come up in future. Telemedicine, I think telemedicine with COVID-19, it is becoming more and more popular. And we have been using, I've been doing clinic online, and we have been seeing patients from maybe from Dubai and from outside as well. Referred patients are seen online using Zoom link, using sometimes those video WhatsApp. Which is very, very commonly used, and I think most of you may be doing this telemedicine, and definitely the patient touch is not there, but a number of times you may do, if you have seen a patient, complex patient from maybe outside interior of Sindh or maybe Punjab, and you have seen that patient, and now a follow-up if you want, they can be in their hometown and they can have a follow-up with investigation and things, so that you can have so in follow-up visits, I think this is very, very important, but maybe in initial visit as well. But maybe once in lifetime, maybe once at least in that illness, you may need the physical touch as well. So in some of the cases, without physical touch, you can manage as well. So again, telemedicine, tele-ICU is becoming more and more common. I've seen a number of critical care specialists in Pakistan managing ICU in US. 2 or 3 of our critical care faculty from Aga Khan University, they have resigned from AKU, and they're only doing ICU management of US patients, and they have been paid. So from here, the residents and people and a junior consultant sees the patient in those ICUs, and these are the people who are sitting on the Zoom link or maybe a video WhatsApp, and then manage patient from here. So again, tele-ICU and medicine is becoming more and more popular, particularly with the advent of this COVID. I think it has increased significantly. Again, I think there are literature there. I'm not going into detail. Virtual reality is coming up very much into it. I think virtual reality is you feel yourself immersed into by using those kind of devices. You immerse yourself into the real situation. And then a number of new things are happening. Healthcare simulation environment in which learners can experience visual stimuli delivered via computer graphics and other sensory. Immersive capacity of virtual reality, meaning that simulated environment surrounds a learner's perceptual field. The learner feels that he's himself indulged or immersed into that virtual reality, and then feel accordingly. So it has been used for psychological conditions by providing an augmented reality environment. Pain management sometimes can be used. And then virtual reality is significantly used for training of residents and medical students. For medical professionals, where they can face and practice challenging scenarios before they have to face them in front of the actual patient. So again, virtual reality is coming up again and again. And here are some of the literatures about virtual reality. Electronic health records. Electronic medical records, another thing which is coming up. In the US and maybe in the UK and all the civilized countries or advanced countries, it is there. But in our country, some of the institutions are doing partial electronic medical record. Few of them are doing health records to some extent, but I think this is the future. you would feed all the data into the system and take history, examination, and everything on the electronic health record system. Then you have a supporting formulary there for medication, maybe a medication alert. If you put any medication for the treatment, you would be alerted with the interaction or other things. And then supportive literature may also be there. Guidelines may also be provided in the electronic health record. So it's a comprehensive package which a number of institutions are doing in the US. AKU is working on it. Hopefully by next year we'll have full 100% electronic health records in our system. So let's hope everything goes well. Yeah. So I just highlighted some of the new technologies which are coming up. I'm sure there are a number of nanotechnologies, a number of other things are also there in the literature, but I think there is some limit to it, so I just focused on those. Clinical learning innovation during COVID-19. Now what COVID-19 led to? Social distancing, closure of medical schools, less number of team members in the individual team, use of PPEs, decrease in number of non-COVID patients, seeing patients with mostly non-touch technique, bedside teaching and team discussion limited, exposure with quarantine and isolation, less time spent at the bedside during the rounds. So I think we all experienced, particularly when COVID was very much into a system, I think we all experienced all these. But I think this led to development of a number of teaching and learning modalities for our students and residents, and I think some of them can be continued for future as well. So medical school suspended, literature on that, virtual bedside teaching rounds. So students connected to a video conference room remotely and were able to see and hear the attending physician-patient encounter. The students were sitting, in some of the institutions, students sit in the conference room with social distancing in a screen, and those are connected to a computer at the bedside, and the faculty with one or two residents sees the patient, and then a discussion, and the students can be connected and can be involved in discussion at the same time. So this has been used. Live stream ward round, a tool for clinical teaching during ward round. Now what in this Australia they did, live stream ward round, a consultant and a registrar or a resident does a round, and a single medical student via mobile phone was connected and listen everything what they do, see and listen everything. And then what students does, student case preparation phase. Student takes notes during the rounds, ward rounds, remotely. Student formulates ward round presentation if they will be able to, a junior resident like, and then on the third day, everybody sits into a conference room, and then student present those cases. So this was the live stream ward round which happened, and I think this can be easily used maybe in post-COVID as well. Virtual care, new models for caring, again virtual ward rounds happening right, left and center in number of institutions. We also did that. You can see here this is a Zoom meeting going on where this EEG was projected, and the students, they are all connected here, residents and students, and this is the faculty. So, and then a discussion takes place. So that's how the virtual ward rounds and virtual learning takes place for the students. Again, mixed reality handsets in hospitals help protect HoloLens with dynamic 365 assets, using Microsoft Teams to send a secure live video. From now, if I'm seeing a patient in a COVID area using this HoloLens, and then from the HoloLens a video develops, and that is projected into the conference room, and the patient and the students and residents sitting in the conference room sees what exactly is going on with the patient. They can see the patient, they can question directly. So these are the new modalities. The mixed reality handsets again come up for here, and maybe in future again with infection control in a high dependency unit. We may not take all students into the high dependency units. So then these are the modalities which can be used. Mixed reality teaching rounds where they saw the patient from the clinician's point of view with electronic records superimposed on the Microsoft HoloLens. Students were able to interact with the clinicians remotely, which facilitated participation in clinical reasoning. So I think that's how. So students' involvement through virtual grand round could provide an opportunity to reach clerkship learning objectives, minimizing the risk of exposure and nosocomial transmission, and reducing the demand for personal protective measures. Again, smartphones can also be used. Virtual, I already discussed that. Simulators and virtual learning also supports education during the COVID-19. Now, just a few slides about assessment. This is one of the consortium of International Consortium of Assessment, Umbrella Consortium Assessment Network, UCAN. It's a German consortium and world's largest assessment consortium, which is currently present. And AKU has become part of this consortium recently. And 77 UCAN partners of different institutions, and they have more than 7 lakh stored items and maybe a number of exams they conducted through the online system. So you can see the different modalities. This is just one consortium, but there are a number of new modalities of assessments of trainees, residents, interns, which is coming up there. Item management system of the UCAN system, where you can develop questions, store questions, and in a secure environment through a typical attributes into the online system. And then these questions can be grouped together, and then you can choose questions from there to conduct exams online. Exams could be online, exams could be tablet-based, exam could be paper-based. So T-exam is a tablet-based exam which can takes place. Again, tablet-based exams are coming up. A number of students are still we are doing it, but this is through this system. Whenever you are into the system, you are having exam of your students. There is a security system where you cannot browse internet. So the exam you can complete. Okay. Campus, again, computer-based exam, tablet OSCE, tablet presenter, EDGAR. These are different modalities which are coming up in this assessment systems, and I think I'm not going to detail of those. Just wanted to show tablet-based oral examination. Examinator is a quality assurance mechanism of assessment system where you identify what is the difficulty index, what is the discriminant index. So a number of things are coming up, and this is the future actually of assessing of students and residents. And these are different modalities which can be used. So in conclusion, innovation and medicine goes together, and in my mind, I think clinical care and clinical training of residents and students again go hand in hand. The next few years, medical technology innovations will fundamentally transform healthcare in the system. The innovation technologies are promising for diagnosis and treatment as well as for learning. And there is a need for future research and clinical trials which are appropriately designed before these emergent technologies, innovations find vast application in real clinical setting. And COVID-19 pandemic necessitated a remodeling of medical education. Virtual rounds again and live stream ward rounds have been introduced. And innovative solutions to virtual teaching can facilitate valuable and safe educational experiences. So I think I'm going to stop here, and I think I took 2 or 3 more minutes, but I hope if you have any questions, maybe later on we'll have, yeah.
Sir, thank you very much for giving us the insight about the new technologies, artificial intelligence, the thing, and the HoloLens. And I will tell you one thing that the Vice Chancellor of the University of Health Sciences is going to start a program that is Master in Artificial Intelligence in Health. And who are interested, they can contact us. And we would like, sir, you be the part, sir. I would like Professor Saab be the part of that thing as well, sir. So big applause for Professor Javed as well, that he is going to start this, this thing that is going to be the future. So, do you have any question you can ask from the both of the participants? Both of the, yes.
Excuse me. Can I?
Sir, mic please.
Ji, kaam kar rahe? Assalamu alaikum. My name is Dr. Tariq. My class of King Edward completed 50 years last year. So I thought I'd be the last of the dinosaurs here, but I'm in pretty good shape. And I basically am, like we do presentations, I'm basically Professor Modat's case today. And my only problem with this wheelchair is that it makes me look like a mesquite vulture. My shoulders come up. So basically, I'm here to speak about what happened to me because of gabapentin. And gabapentin was pushed in 2006 as an anti-epileptic drug, and then it washed over. It went into nerve pain, and I was on gabapentin when I had a really horrible crash. But for the will of God, I think I wouldn't be here. So I used to develop strange sleep. I would be speaking at a conference or doing my hospital rounds, and I would go to sleep uncontrollably, and that's what caused a crash. I went to my doctor and I said, look, have you warned people about this? This is uncontrollable. This sleep is uncontrollable. And I got some kind of a runaround and I really couldn't figure out what. So I looked it up, and starting 2006, gabapentin was pushed in the most unethical manner possible. And of course, like Professor Moudud was saying, this would not have happened if there were not medical personnel supporting this. So all said and done, naturally things came up with Neurontoin, and in 2014, Pfizer had to pay a $140 million penalty for misinformation. So this is basically what I came to say today, and I'm here as Moudud's case.
So this is your response. What is your question? He is supporting the evidence.
I find your remark rather,
Sir, thank you very much,
rather
sir.
irrelevant.
Sir, thank you very much.
Thank you very much. Thank you.
First of all, the last speaker from Aga Khan University,
Professor
Dr. Tariq
Muhammad
Sahib.
Tariq.
You see, he has given a good review of what is happening in the realm of medicine, advances, and I would like to very humbly bring to his notice that all these are mechanical aspect of treatment of diseases. You see, there is also a human aspect of medicine.
Yes.
There is no mention, unfortunately, on these matters that there should be an improvement and advancement of dealing with the patients. See, there are countless examples that people highly qualified about teachers, they write prescription, and if the patient wants to ask some question, they say, okay, my PA is sitting outside, you can talk to him. What I would like is that there is a concept of medical counseling and pastoral counseling even. So I will request the Vice Chancellor of the University of Health Sciences kindly put this point of human aspect of medicine into the curriculum. The second part is one question from Professor Moudud Rana. You see, he has mentioned the irrationality of prescription of proton pump inhibitor or antispasmodics in gastrointestinal diseases, although it may not be taken as a sort of, I apologize first of all from you. You see, when I was a final year student, I read Bromheld syndrome, gastrocerebral dysautonomia. You have a stomach problem, but your mood is changing. You are having a headache. In typhoid fever disease, in the pars patches, but you have frontal headache. You have constipation, you have mood change and headache. Nowadays it has been absolutely established that these medicines, you see, proton pump inhibitors or antispasmodics, they modify the frequency and intensity of nervous impulses going from these viscera to these. Now this is mainly from vagus or hypogastric nerves, from alimentary system. The only way to represent these things is the trigeminal nerve. The trigeminal nerve is the sensory aspect of expression of vagal territory, sensations coming from vagus territory. So I think if the doctors prescribe these things, or irritable bowel syndrome, see, just imagine. You see, all these things do have certain, you see, logic behind this. Use of antispasmodics or tranquilizers or these things, nobody can know more than you. This is just my comment.
Thank you, sir.
Sir,
I
thank you
stand
very much.
educated.
Sir, would you like to answer?
I think this is a comment by a very senior
Sir,
physician.
would you like to comment something?
No, I think I cannot really add to what you've said. All that I can say is that the point that I was trying to make is to bridge the gap between evidence and pathophysiology, not the other way around. Now, it does not mean that the pathophysiology that we have read is some kind of a gospel or is the ultimate statement that medicine has made about understanding of the problems and diseases. But there is an existing gap that I was trying to point out, sir. And thank you very much. I stand educated.
Sir,
I
sir,
think,
please, Professor Jwedakram, please, sir,
I
comment.
think two excellent talks, of course, by both dear friends. I wish we had a debate rather than a talk, but the second part is my talk tomorrow, which is exactly opposing your talk. So, because I am for evidence-based up now, only the thing I want to highlight was, when I say up now, we are not saying up now means doctors. Up now, in that up now, we have the patient and the relatives and the attendants and the public and the media. So up now is not just for the doctors. So I just wanted to clarify. And tomorrow I will try to clarify in my lecture this thing again. Thank you so much. Wonderful, as always, expected, and learnt a lot. I do not agree with most of it, unfortunately, but that's the beauty of talk, that it raises more questions than it answers. Another thing that in your first slide you highlighted, if you go into the history of evidence-based medicine, it was just what you explained, that there was no patient's perspective, no family perspective, and this term was invented by Sackett, and British Medical Journal was the first to publish it in 1996, I think March 1996 issue. And then just after 4 years, because of the reasons that you have pointed, it was thrown out. And now, the evidence-based medicine has a huge, the largest component, 60% of component is patient's perspective, the local. So what we still support evidence, despite your lecture, we still continue to support evidence-based medicine at PSIM. The reason is because, as I said, we are doing it, this is a patient-centric thing. This is not on the other side. As far as you are absolutely right about the RCTs and the bias, that is why all the trials done so far by PSIM or my university, you can see them, they are first posted on our website and on trials.com, which is a US website, so the transparency comes in those trials. RCTs should not be published, even there are Dr. Javed Sahab and other journalists, but published till they have been transparently highlighted 4 years, 5 years, until we have data safety monitoring board and their job is to take out the bias. Number of trials, talk of ACCORD, talk of advanced study, number of studies have been aborted because there was overwhelming harm or overwhelming benefit. So that is why I think there is always a room for improvement in things, as you just said, but not to abort it. That's what my point is, that absolutely huge room of, you see, if you look at evidence-based medicine, Peter Fleming invented penicillin in 1940, something like that, and then Tuskegee, they isolated black Negroes for syphilis, and then they withheld. Good clinical practice clearly tells you in the informed consent, one of the most important component of informed consent is you tell the volunteer or tell the patient and the family, and that is the implementation of good, that if a better treatment comes in during the trial, you will be shifted to that treatment. You will have an option. And this was denied from those Negroes. And President of United States, Bill Clinton, himself apologized from the whole world into this. So there are good and bad things about it. I'll say we should continue with evidence-based medicine. We appreciate the criticism deeply, and I will have to readjust my slides now for tomorrow with your input, wonderful input, but I think we should together make it better, more patient-centric, more country-centric, and more so that base of the pyramid we work on, not just the rich few. So that's why we say think global but act local.
Great,
Thank
sir.
you, sir.
Thank you
and
very much,
also
sir.
about, sir, what you said, yes, he himself is our professor at UHS, teaching behavioral sciences. He is the master of behavioral sciences, and that's an essential subject in my university, to improve the behavior. आधी बीमारी ख़त्म हो जाती है डॉक्टर के एटीट्यूड से. जहाँ तक सर पर्सियन मेडिसिन की मैं बात करूँ, Persian medicine is again patient-centric. I am doing a study, I am a principal investigator. It is a study funded by HEC. Again, I always believe in studies which are funded either by universities or HEC or Pakistan Science Foundation or international, not by pharma. Pharma, there is a bias. In pharma, there are two types of studies. Pharma initiated, that is, again, the data right goes to the pharma. If it's a negative study, they may not publish it. You can't do as an investigator anything. But if it is investigator initiated, supported by pharma, still I have the right. And I have published it, many negative studies. Protect is one of the examples that I published. Sir, this study that I am doing, just to clarify your question, sir, this is class 1A indication, because I am a fellow of American College of Cardiology. 1A indication is that every diabetic should be on a statin. Every hypertensive should be on a statin because of LHAT data, because of SCOT data and huge data that you prevent MIs, and every person who has had an event MI must be on a statin for lifelong. This is not a secret. Now when we look at the data, the mortality reduction is less than 35%. So this means 65% of the people do not benefit after 15 years of statin treatment. So now with the precision medicine, what we are doing at my university, we are profiling these individuals who are going to respond. So give statin only to those who are, you can predict. So we have this panel now. We have panels, sir, to decide that if you have those 3 mutations from chromosome 11 to short arm of 5, do not use statin because they are not going to respond. So precision medicine means your profiling genetically is done, and then you decide on the treatment. In future, what Tariq will also bear me out, that you will be profiled. These pharmaceutical companies have started profiling people, that which antihypertensive, calcium channel blockers or ARB. Now it will depend, just like blood group, it will depend upon your genetic panel, that what mutations are you carrying. And then it will be more appropriate to treat you. Because like blacks, we know they don't respond to many antihypertensive, they respond well only to diuretics. So these things are going to be, that is what to me precision medicine is, and it is patient-centric again. You are giving the most appropriate treatment after profiling their genes and genetic makeup. Thank you.
Sir, thank you very much, sir. Please, comments from the chair. Because a lot of questions there, but we are running short of time. And comments from the Professor Mubashir Sheikh, sir, please. From the chair.
Bismillah ar-Rahman ar-Rahim. First of all, I'm very thankful to the Society of Internal Medicine for accommodating psychiatry. I think this was a unique session in terms of, एक तो ये कि वक्त पे शुरू हुआ, बल्कि 10 मिनट पहले शुरू हुआ, और फिर very worthy participant जिसमें अगर हम देखें कि प्रोफेसर जावेद अकरम साहब, मोहसन आफ्ताब, बिखराम, जमान शेख, stalwart of medicine are there. Or regarding the our worthy speaker, I think Professor Mohadat Rana जो है, he knows the art of talk, and he किस तरह से परायों को अपना बनाते हैं, तो उन्होंने परायों को भी अपना बना दिया है. तो ये जो उन्होंने बताया कि evidence based medicine जो है, if you look at the vivo and vitro, there are total difference. اور پھر یہ کہ ہر چمکیلی چیز میری جان کب ہوتی ہے سونا. تو یہ بھی ایک ذہن میں رکھیں. اور اس پہ مجھے سندھی کا ایک شعر یاد آیا کہ روزو نماز پڑھن چنگو کم پر وہ کو بیو فہم جیسا پس چے پیرین کے. تو پہلے جس طرح سے کہتے تھے کہ جو ہیلتھ از اے کمپلیٹ فزیکل سائیکولوجیکل اینڈ سوشل ویل بینگ, بعد میں پتہ چلا کہ یہ کافی نہیں ہے, آکوپیشنل اسپریچول کمپوننٹ ہے. تو لہٰذا میں سمجھتا ہوں کہ دس واز اے تھاٹ پرووکنگ سیشن, اور خاص طور پر رانا صاحب نے اور پروفیسر طارق صاحب نے جو انوویشن بتائی, تو میں سمجھتا ہوں کہ اب ہمیں چاہیے کہ ایک نئی اس کے ساتھ آئیں, اور جس طرح سے بتایا گیا کہ ہم ہولسٹیکلی پیشنٹ کو دیکھتے ہیں. آرٹیفیشیل ڈائیکاٹمی ہیز بین ڈن بائی دی کرنٹ میڈیسن, سو وی ہیو ٹو سی پیشنٹ ہولسٹیکلی. اس کی جو ہے اگر ہم دیکھیں کہ جینیٹک, ایپی جینیٹکس, انوائرمنٹل, لائف اسٹائل, آئی تھنک ان دیٹ وے وی کین اوور کم اور ایٹ لیسٹ detect, defeat and the diseases at all level and by all means. I think due to the time constraint, we will I will say thank you to especially the participant کہ ان کسی کا موبائل نہیں بجا, تو میں سمجھتا ہوں کہ آپ لوگوں کے لیے تالیاں ہونے چاہیے. With this I'll end. Thank you very much to the secretary and my co-chair. Thank you very much.
Thank you very much. Sir, thank you very much. Please. Okay. Please proceed for the Juma prayer and the lunch. I should. Okay. Professor Aftab Mohsin have to do some housekeeping announcements, please.
Thank you so much. Professor Muwaddat Rana, you made the day for most of us. संगीता का जिक्र करके तो दिल खुश कर दिया आपने. बाकी जनाब के लिए एक फैज़ का शेर है, वो आपके लिए भी पेश किया था, मगर आज आपके नज़र करता हूँ. बड़ा है दर्द का रिश्ता ये दिल गरीब सही, तेरे नाम पे आएंगे गम गुसार चले. तो आपके आने का बहुत शुक्रिया. आपको तीसरी मेडिकल कॉन्फ्रेंस है PSIM की, तीनों दफ़ा इनवाइट किया गया. सेकंड टाइम यू हैड एन एंगेजमेंट विद द फैमिली, फैमिली में कोई ट्रेजेडी हो गई थी. यू कुड नॉट कम इन टू योर ओन सिटी इस्लामाबाद में, मगर आप लाहौर भी तशरीफ़ लाए और कराची भी आए हैं. आई एम वेरी ग्रेटफुल. और इन्होंने कहीं पे भी नहीं कहा कि इसको नहीं अपनाना, इन्होंने सिर्फ एज अ वाइज मैन कहा है कि देख कर अपनाना है. अपने हुए पराए, सिर्फ संगीता को नहीं देखना, पूरा चीज को देखना और समझना है, फिर अपनाना है. हाँ जी, थैंक यू वेरी मच. हाउस कीपिंग अरेंजमेंट्स ये हैं कि अब प्रोफेसर जावेद अकरम और जो मुक्तदर लोग हैं वो फार्मास्यूटिकल एग्जीबिशन की इनॉग्रेशन करेंगे ईस मोहम्मद साहब की सरबराही में, और हम क्लैपिंग करेंगे. दूसरा जो जवान लोग हैं जिसका मैं बेहद मशकूर हूँ, जो यंग डॉक्टर्स हैं जो कि रूह रवां है, वो इस पिछले हॉल में अभी तशरीफ़ ले जाएंगे और लंच शुरू कर देंगे. हम इनॉग्रेशन करके लंच करेंगे. उसके बाद जुम्मा प्रेयर्स हैव बीन अरेंज्ड एट द पूल साइड. 1:30 पे जुम्मा प्रेयर होगी, तो तकरीबन 1:40 हो जाएंगे. लंच के बाद जुम्मा प्रेयर है, और जुम्मा प्रेयर के बाद हमने जो फैमिली मेडिसिन का सेशन है वो 2:45 बजे यहाँ दोबारा असेंबल हो जाना है. 2:45 आई वांट एवरीबडी बैक, एंड द प्लेन of delegates from Lahore have also arrived. So there will be a challenge for beautiful young doctors here and from those coming from Lahore. So please be back by 2:45. Lunch now for everyone, but pharmaceutical inauguration first and Jummah at poolside by 1:45. And we start again with the family medicine, the backbone, at 2:45. Thank you. session, Hina is going to invite them, and this is going to be a panel discussion, and I'm so glad that some of the young doctors are here. And it is found in Pakistan that very few young physicians actually aspire to become family physicians, and this is an excellent opportunity. And we have invited the leaders in family medicine who have vast experience and they have specialized in this branch or field of internal medicine, the family medicine. So no formal presentation will be needed or required. The family physicians have been given 4 questions. Obviously the questions were given to sum up their thoughts, and so that they can make a brief panel discussion or remark. Basically, we will be taking questions, and then Dr. Hina will direct them to the chair of panelists, and they will then briefly answer it. There will be no formal presentation during this session. You may dislike it, but that is what the format is and has been decided beforehand. Unfortunately, there has been a misunderstanding, I don't know how, but that is the format, and we would like to involve all the young participants who are here to get actively involved. Thank you. All over to Hina.
Thank you very much, Professor Aftab Mohsin, for the introduction and providing family medicine fraternity this opportunity in your conference on day 1. I would like to invite all the panelists one by one on the stage. The first guest I would like to invite is Dr. Abdul Jaleen Khan. He's a consultant family physician with many years of experience in the NHS. He also holds a fellowship in general practice and is also a fellow of Public Health England. He's acquired 2 awards in leadership from the UK. My next guest is Dr. Tariq Mia. He is the president of Pakistan's Academy of Family Physicians, a very dynamic personality who's been very active and very vocal about quackery and antibiotic stewardship. The next guest is Dr. Arshad Humayun. He belongs to the Family Medicine Education Committee from Lahore, again hugely involved with Pakistan Medical Association in conducting academic sessions, regular CMEs, weekly basis. Another guest is Dr. Chima, Altaf Chima. He is the Senior Vice President of the Pakistan Academy of Family Physicians and has a very lucrative practice in a nice area in Lahore. Again, he's actively involved in a lot of academic activities, including guideline updates for family physicians. Mind you, there are certain areas of Punjab where GPs do not even have access to CMEs, and South Punjab is one of the areas where this deficiency is identified, has been identified, and still lacking. So thank you, gentlemen, for coming here. I'll just put forward some of the questions. Can we have that slide for the questions, please? So we hear every now and again that family medicine or primary care in a broader sense is the backbone. But the backbone seems to be missing. And we have identified 4 questions, and we will ask 1 question from each of the panelists here. I would appreciate if we stick to just 5 minutes for the sake of the time constraint. Okay, the next slide, please. Thank you. So these were the 4 key questions that were identified, focusing on family medicine, stroke primary care. And we aim to cover most of the questions that the public might have, but we would prefer this session to be interactive. So if you have any questions, just let us know at the end. What are the challenges faced by family physicians? Can I take this question from Dr. Tariq Mia, please? Because I know you've been very vocal on a lot of platforms about it.
Bismillahirrahmanirrahim. Thank you very much for putting this question to me. Basically, the family medicine, I think according to WHO, 70 to 80% patients are being seen by the family physicians and 20 to 30% by the other system of medicine. This big chunk of people which are seen by the family physician, but unfortunately, like other countries in the world, the primary care physician and the family physician, I think they are the most neglected field, very important but most neglected field in Pakistan. This is the reason that our health delivery system is not up to the mark and it is not meeting the challenges of present day. There is no, what is the reason behind? The reasons are that during undergraduate training, nothing is taught about family medicine, neither they are posted in the family physician's clinic so that the young graduates can have a better understanding what the family medicine is. Unfortunately, our seniors, they are the main hurdles for not promoting family medicine in Pakistan. You see, you just take the example of NHS, UK, Australia, even our neighbor Iran, Canada, America. Nobody can go to tertiary care hospital until unless he is being referred by his primary care physician, his family physician. In UK, even the consultants working in different tertiary care hospitals, they cannot have their medical checkup without being referred by their family physician. So I think this is the main thing which is lacking in Pakistan. The other thing is that the people, we think that this is primary, secondary and tertiary care. We think that the primary means the smaller one and tertiary, secondary means the intermediate and tertiary means the last one. So this is the main problem in conception of family medicine. Family physician, he is a whole body doctor. The consultants are a doctor of a system. So I think they are equally important. And you see, the second problem in Pakistan is that there is no proper training that who should be family physician. Once you go into the field, anybody who has done house job in just one subject, he can go and he can open his clinic. Nobody is going to check whether he is competent enough because he has to see the patient from head to toe. So this is the main problem, that we are not promoting family medicine, which is very, very essential. I will just give you two examples. That during there was an epidemic in Lahore in 2011 of and again there is a pandemic. So the family physician, they took the burden of disease and we trained our family physician on our own, not the government. So they have served the nation. And if they were not trained and they were not competent enough, so there will be a huge burden on tertiary care hospital. You see, in tertiary care hospital, if you see 80% of the patients which are from the primary care, they are being seen by the consultants, so they cannot do justice to those patients. If only 10 or 20% which genuinely needs the tertiary care, if they are referred to the tertiary care hospital, I think our honorable consultants, they can do justice to their job and they can see the patient. The other most difficult problem for the family physician is that there is no proper postgraduate or after their job training. So medicine, as you know, is changing day by day. Every day there are new guidelines, and those who have done MBBS, their graduation 20 years back, and they are not connected with any CME programs, I think their knowledge will be
almost 20 years behind, so they will be doing practice now almost equal to quacks. So the postgraduate training and the CME continuing medical education program and at the level of undergraduate the training of and the departments of family medicine. I think these are a few things which we have to, if we want that we should meet the comprehensive needs of the country and the health for all, for the poor masses. That is possible only if we give undergraduate training and then postgraduate and then continuing medical education. These are few points which I want to highlight. Thank you so much.
Thank you so much for your points. Thank you. Before we proceed with the panel discussion, I have spotted Dr. Shaila Naseem. She is the one of the key people of College of Family Medicine, Pakistan, an important institution for the entire country. Ma'am, I would like to invite you as a chairperson for this session, if you can join us on there. Thank you. Madam is very proactive in doing research work. She's currently holding an important post in Wonka, South Asia as well. So thank you for coming. I don't know if Dr. Unab Khan is with us in the hall. If she is, can she identify herself? Okay. Is Dr. Shahzad Ali Khan here? Right. Okay. No worries. Thank you. We'll move on to the next question, and can I take this question, ask Dr. Abdul Jaleel Khan to answer it. Do you think family medicine is getting its due recognition? And if not, why? And if you can just limit yourself in 5 minutes, thank you.
Okay, thank you very much. So do I have the full 5 minutes? Okay, so when it comes to recognition, I can ask the same question from all of you. I think Dr. Tariq Aziz has already highlighted it. No, family medicine is not getting its due recognition. And the reason being what? Ages ago, it's already been decided. If you guys know the history of family medicine or the history of medicine, Professor William Darley, who was an internist, who was an internal medicine specialist. So again, we are sitting here in an internal medicine conference. He, in 1961, he thought that fragmentation of healthcare into multiple specialties is causing fragmentation of patient care. So yet there is a need for a specialty where someone can provide that comprehensive, holistic care and take patient as a whole, or what we call a whole patient care or whole patient-centered care. So, no, family medicine is not getting its due recognition. What could be the reasons? 1992, our colleague from Aga Khan might be sitting here in the hall. CPSP recognized family medicine as a specialty, and a proper FCPS program was started in family medicine. Yet, we still have around 50 to 60 CPSP graduates in FCPS. Correct me if I'm wrong. I'm talking about FCPS. Luckily, we have a lot of MCPS family medicine program. Now, why are we not getting the recognition? The reason is we, as clinician ourselves, we are not giving it the due respect, the respect which family medicine need. Dr. Tariq Mia talked about NHS. I worked in NHS for 16 years, 7-8 years as a family physician. There, the GP have the same respect, rather more respect than any other specialty. In Pakistan, obviously when we talk, we need to incentivize it. Now when we talk about incentivization, people talk about money. So money is not incentive. What we need to do if we want to recognize it, I give normally people what I call Dr. Khan's 5R formula. So the first R is for respect. We need to give the same respect to this specialty like any other specialty. We need to recognize this as a specialty. Again, it's been recognized. There is CPSP programs, but why people are still not coming? So again, because we're not rewarding it, the other R is reward. We need to give the same reward. Just like any other specialist, you create job opportunities, you create district level posts, you create faculty positions, and then people will, the youngsters who are sitting here, they will come to this specialty. Now, if you do all these, then you will be able to retain them. Otherwise, what's been happening? We have started this diploma family medicine program, which is only a 1-year diploma program. And after training a couple of batches, 3-4 people left. Few got jobs in Canada even, few got jobs in Kuwait, Gulf. The same is with CPSP. People do MCPS and they get better jobs in Gulf and they leave the country. So we are having difficulty in retaining them because there are no opportunities here. So if you give all these 4s, respect, recognition, reward, and you will be able to retain them, and then they will give the result to the system. Now, we all want to improve the healthcare system. We decided to bring healthcare Sehat Sahulat card program, which is health insurance, yet we have no gatekeeping role of family physicians. So if you want to recognize this program, if you want to give the same respect to the family physician, then they will be able to deliver, and then your primary care will be able to improve. I know it's the next question, someone else will be able to answer it, but if you want to bring a comprehensive, cost-effective healthcare model, the only way forward is to gatekeep this by family physician, which means all the referrals, all the hospital admissions, all the preventive medicine, all the rehabilitative medicine, that should come under the umbrella of family medicine. So we need that recognition. Now, I can give you a few good news as well. Yes, in Pakistan, things have been moved forward in the last 3 years. And Alhamdulillah, at PMC level, we managed to get, Tariq, I mentioned earlier about undergraduate training of family medicine. We managed to get 100 hours in undergraduate curriculum. And in KPK, we managed to implement it by Khyber Medical University. So Alhamdulillah, in all 17 medical colleges of the Khyber Pakhtunkhwa province have now got 100 hours implemented as family medicine at the undergraduate level. And hence we will have now faculty positions at all the medical colleges. But we still need recognition for the service provider level. That means our BHUs are still led by not even doctors. In a lot of places, they have medical technicians. Everywhere in the world, primary care is always consultant-led. So that's what we need. And for service provision, obviously, we need the government to recognize this specialty and make it a compulsion. Anybody who wants to open a GP practice, anybody who wants to work in primary care, or any BHUs or RHCs, that should be led by somebody who have been trained in family medicine. Yet there is another model. I was talking to somebody, I think the government is working on this as well to achieve universal health coverage. They are thinking to contract out the primary care to local GPs who have qualification in family medicine. They have even calculated it, they have figured out the cost, and they're thinking the cost should be around $5 to $6 per registered patient per year. So if that got implemented, I'm sure most of these trainees or students sitting in the hall, nobody would want to go to any other specialty. Yet even I'm ready to open a practice with 20,000 population and the government paying me that much money. And trust me, that's still more cost effective. There's still going to be less money spent by the government than they are already spending in the current primary care system. Yet it will improve the referral system, it will improve better care to the patient, and it will help in reducing the cost of healthcare. Thank you.
Thank you very much. I know there are plenty of the younger lot sitting here. Are there any, we are open to any questions, so I'm going to open the microphone. Unko de dijiye, please. We have a good panel of the academic researchers and practicing physicians, so yeah. Sambi.
Hello. 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 Listen. Hello. Do you guys see me?
Meanwhile, let me ask a question while you're coming. You can come here. Thank you so much. It was a wonderful discussion. I think the biggest challenge to family medicine in Pakistan is there's no doubt that family medicine must be the backbone of any adequate healthcare delivery because they are the first line of defense. They have the opportunity to intervene much earlier than we are. People don't present to us with diabetes or hypertension. They present to us with complication once they are symptomatic, while most of these chronic diseases are asymptomatic for a very, very long time. And also the influence of family physician is not only a physician, he is a family member of so many people who are, and they have much more influence on the families for prevention, which we don't have because people come to us too late in the tertiary care. So I just give you one example. When I was working in UK, the control rate of hypertension was around 7.8% at that time. And then NHS decided to give, and people would come with some trauma or whatever, they would take a blood pressure. And once they would diagnose it, they would was incentivized. And just in about 7 years, the control rate of hypertension went up to a hefty 19%. So that's just one example. In Pakistan, the large, of course at UHS, we do have a very active family medicine department, and the moderator, Hina, is holding the fort for us. Our family medicine department is based at Gujranwala campus. We have many campuses. But the main challenge is that we are acting in parallel, and there is no integration horizontally with the government sector. They cannot refer, they cannot visit the government sector, or their patients just walk in, they are not referred, and they are not referred back to them. So unless the government takes a very serious note of this and integrate family medicine into mainline, because that is, the public sector is the base of the pyramid. Private hospitals, they are the tip of the pyramid. So I think we'll have to somehow motivate the government, and we have been trying with all my friends sitting on the stage right now, and all my life we have been doing, but so far miserably failed. We are working in parallel and there is no horizontal integration. So we have to devise a way how to horizontally integrate it with the public sector. And once we do that, then it will be a win-win situation, not for family medicine alone, but for the public and patients as well. Thank you.
Thank you for your comments, sir. And always supporting family medicine.
So it's working now. Hi, my name is Dr. Mohammed. Sure. I'm a postgraduate resident of internal medicine. So my question is, I'm just done with the training. I don't want to continue my internal medicine. So if I have to pursue the family medicine, what are my opportunities are, and how should I pursue it? And how can I, like later I just want to ask, where can I stand after 10 years in family medicine? So that's are the basic concepts I just want to clear out.
Good
Thank you.
question. Yeah.
Can I? Thank you very much. First of all, I must appreciate the dynamic leadership of Pakistan Society of Internal Medicine for involving all the chapters of family medicine and having this session, very important session. And the topic is that backbone of healthcare delivery system. Of course, family medicine is very important, and I think the lacking is that there should be a structured training at the undergraduate level, structured training at the postgraduate level, and structured involvement of family physicians in healthcare delivery system. And this is very important. The other thing, does anybody who has done his MBBS or even not done MBBS, just sitting quacks, so many quacks are sitting there, they can open their clinics and start practice. I think to open a clinic for a practice, there should be a licensed family physician, and there should be some criteria and some SOP, some protocol
to start the practice as a family physician. And I think family physicians are doing their CME program. I think that since the time of Dr. Bashir Malak in 1980, he started the CME program, regular weekly CME programs. And I think that this program can be compared with any part of the world, that the family physicians, they are updated to the latest development in medical science due to these CME programs. And now you know that the different segments of the family medicine, they are doing their CME activities. And I think that as asked by the question that if someone wants to start the family medicine, I think that family medicine is the holistic medicine, integrated medicine, as told by Professor Javed Akram, that it is the holistic medicine, and we cater the 80% the needs of the family physicians, and we enjoy being a family physician, and I am at least proud of being a family physician, because I think that the family physician are the real doctor, because they cater the needs from head to toe. And any problem, if a family physician is, if any patient is having any problem, the family physician can take care. Thank you.
Thank you very much for your answer. Yes, please.
I am Dr. Saeed from Lahore. पहले तो अपॉलोजी करूँगा कि इंग्लिश में नहीं बात करूँगा, और मैं अपनी बात को समझाने के लिए अपनी ज़बान यानी उर्दू में ही बात करूँगा। गाइडलाइन देनी चाहिए लोगों को। पहले नंबर पे बताना चाहिए कि पहले नंबर पे जो आपका क्वेश्चन है कि क्यों वो फैमिली मेडिसिन में आए, फैमिली मेडिसिन के क्या है। जिस तरह अभी वो हमारे यंग डॉक्टर ने पूछा कि मैं इंटरनल मेडिसिन छोड़ के क्यों फैमिली फिजिशियन बनूं, तो इसका अभी हमारे पैनलिस्ट को भी, हमें भी और उसको भी पता नहीं हम कैसे बन गए हैं डॉक्टर, हम कैसे फैमिली मेडिसिन में आ गए हैं, कभी हमने खुद नहीं सोचा। और आज अब जब हम इस कैरियर को आखिरी सेशन में हैं, तो अब हम सोच रहे हैं कि हम यहाँ क्यों आए, यहाँ क्यों उधर क्यों चले गए, या ये क्यों नहीं किया या वो नहीं किया। एक बात। दूसरा, पाकिस्तान में ऑलमोस्ट मोर देन 80,000 जो फैमिली फिजिशियन है रिकग्नाइज्ड हैं। अब आप इनको जो क्वालिफाइड जिसको लेवल आप देते हैं कि कम से कम ग्रेजुएशन के बाद पोस्ट ग्रेजुएशन 3 या 4 साल की हो और इतने लोगों को आप ट्रेन करें, तो फिर वो इन सब को रिप्लेस करेंगे। एक बात। दूसरी बात, जो रिकमेंडेशन है किसी भी स्पेशलिटी की पाकिस्तान में, फॉर एग्जांपल साइकेट्री की ले लें, साइकेट्री का प्रेवलेंस पाकिस्तान में जो उनकी सोसाइटी गाइड देती है वो मोर देन 15% है। अब वो जो पूरे साइकेट्रिस्ट हैं पूरे पाकिस्तान में वो 400 भी नहीं है। इसी तरह एंडोक्राइनोलॉजिस्ट हैं वो नहीं है। क्या आप ये चाह रहे हैं कि हम उनको कम करके ये बढ़ा दें या ये बढ़ा के वो कम कर दें? ये तो हो नहीं सकता। हमारी ये जो रिक्वेस्ट है ये अपने इसमें गाइडलाइन दी जाए कि जो फैमिली फिजिशियंस काम कर रहे हैं उनकी ट्रेनिंग पे तवज्जो दी जाए, उनकी CME पे प्रोग्राम पे तवज्जो दी जाए। फॉर एग्जांपल अगर कोई साइकेट्रिस्ट की साइकेट्री की प्रैक्टिस कर रहा है तो डॉक्टर साहब को ये समझा दिया जाए, यहाँ तक ट्रेन कर दिया जाए कि ये उसकी एंजाइटी और डिप्रेशन में क्या फ़र्क है और इसके बाद रेफरल कब होना है। आखिरी बात इसमें क्या होनी चाहिए, हर स्पेशलिटी में, डायबिटीज़ में ले लें, किसी में ले लें, पेशेंट जो है वो फर्स्ट विंडो या फर्स्ट टारगेट या फर्स्ट गेट कीपर अगर फैमिली फिजिशियन है तो वहीं से पेशेंट जो है वो सही लाइन पे चला जाए और रेफरल चला जाए। और अगर इस तरीके से हम काम करेंगे तो फिर हम अपना गोल अचीव कर सकते हैं, वरना हम गवर्नमेंट को ब्लेम करते रहेंगे, खुद भी ब्लेम करते रहेंगे। तो आज हमें एक कंक्लूजन इस फोरम से हमें मिलना चाहिए कि हम इस प्रोग्राम को कैसे आगे बढ़ाएं ताकि हम इसको अचीव कर सकें, लोगों को अच्छी हेल्थ केयर दें। थैंक यू।
Thank you, Dr. Saab, for a very honest response and opening the floor for more conversation. Dr. Saab को microphone दे दें, please. जी, sir.
My name is Shaukat Javed and I am student of medical journalism. Thank you very much for giving this opportunity. With due respect to the panelist, Dr. Tariq has already pointed to some of the problems which the family medicine faces. But the reality you should also know. majority of the GPs which are practicing, believe you me, they have never bothered to clean the table on which they practice. You go and see it. They don't know how to write prescription. They don't have proper waiting place for the patients. And you demand respect. Nobody should demand respect. You need to earn respect. If I go back to 70s, Dr. Naqvi, SH Naqvi in Karachi, Bashir Malik in 80s, they never asked for it. They were given due respect by the specialist. So they never asked for it. You have been given respect, you have been recognized, you are sitting on the table because of your work. It's on us, on you, to prevail upon your colleagues who are doing general practice. They should improve themselves, improve their practices, improve their clinics in working, they will earn respect. Thank you.
This has been a breakthrough in the conversation basically. जी सर का comment दे देते हैं.
Just एक मिनट इनका जवाब थोड़ा सा. हम हमेशा उलमा को कहते हैं जी कि इन्होंने पाकिस्तान में इन्हें पता ही नहीं है बात कैसे करनी है, इन्हें पता ही नहीं है ये चीज़ कैसे है. हम उन्हें हमेशा इल्ज़ाम देते हैं कि हमारे मुल्क के उलमा जो हैं उनका लेवल ये है. कभी हमने सोचा कि हम इंडक्ट कौन से करते हैं उलमा? यही हाल फैमिली मेडिसिन का है. अगर यहाँ पे प्रॉपर ट्रेनिंग होती, प्रॉपर अंडर ग्रेजुएट लेवल पे होती, बाद में उनको सही प्रॉपरली गवर्नमेंट उनको ट्रेन करती, और ये सारी चीज़ें जो आपने कहा है वो हमने इनपुट तो दिया कुछ नहीं, हम आउटपुट चाह रहे हैं उनसे. ठीक है जी. तो जिस हाल में अंदाज़ा करें हमारा मुकाबला क्वैक से है. एक तरफ क्वैक बैठा हुआ है जो हमसे कोई कम से कम 10 गुना ज़्यादा है. उनसे हमने मुकाबला करना है, हमने रेट अपना उनको कम्पीट करना है, और सर्विसेज हमने देनी है क्वालिफाइड डॉक्टर की. पेशेंट हमारा समझ रहा है कि डॉक्टर जो एक फैमिली फिजिशियन है या क्वैक है वो बराबर दोनों डॉक्टर हैं. तो ये कुछ चंद एक ज़मीनी हक़ाइक़ हैं जिनकी वजह से ये प्रॉब्लम आ रहा है, लेकिन आपकी सजेशन वैलिड है.
थैंक यू सर. जी
डॉक्टर मिनहाज कदवाई मेरा नाम है. यहाँ बात हो रही है बेसिकली फैमिली फिजिशियन एज ए रोल मॉडल ऑफ अ गेट कीपर. So it's very important that we establish that idea of a gatekeeper within our system. प्रॉब्लम ये है कि पाकिस्तान में हेल्थ इंश्योरेंस ना होने के बराबर है. सो मैं एक सजेशन प्लेस करना चाहता हूँ इस सूरत हाल में कि जो हेल्थ केयर इंश्योरेंस कंपनीज़ हैं पाकिस्तान में इस वक्त जो प्रोवाइड कर रही हैं हेल्थ केयर इंश्योरेंस, अगर फैमिली मेडिसिन की जो एसोसिएशन है वो उनके साथ मिलकर एक प्रोजेक्ट, पायलट प्रोजेक्ट डेवलप करे जहाँ पर ये कि रियल जो हम गेट कीपर की बात कर रहे हैं कि रेफरल बेस्ड सिस्टम हो प्राइमरी हेल्थ केयर के हवाले से. सो अगर वो एक प्रोजेक्ट डेवलप करें हेल्थ इंश्योरेंस कंपनीज़ के बाद तो इस्टेब्लिश वेरी सी के जो गेट कीपर मैकेनिज्म में कैसे सक्सेसफुल डॉक्टर शैला एंड अदर्स इन इस्टेब्लिशिंग दिस प्रोजेक्ट. एक तो ये बात. दूसरी ये कि बात यहाँ पर हुई एक और क्वैकरी के हवाले से. सो क्वैकरी जो है ना वो एक हम मेनिया से बेसिकली यहाँ पर, और अनफॉर्चुनेटली एज अ सोसाइटी वी हैव नॉट बीन एबल टू डील विद दैट. सो प्रॉब्लम ये है कि अगर हम क्वैक्स को या तो एक्सक्लूड कर दें सिस्टम से या इंक्लूड करें उनको, मगर क्वैक्स आर रियल पार्ट ऑफ अ सिस्टम वेयर द कम्युनिटी would like to see them because they are really available at the time of their needs. So हम एक ऐसा कोई solution devise करें where the quacks are trained to an extent under the family medicine umbrella, whatever it may be, and they are supervised by the family care physicians. That could even give incentive to the people who want to work. Or it's up to you what you want, but this is my suggestion. Thank you very much.
Thank you sir. जी सर. जी आप सर एक मिनट अगर मैं आपको Professor Shehzad Ali Khan is here. He's the VC Health Services Academy, Islamabad. Thank you for gracing us with your presence. If I can ask you to come on the stage, please. Thank you. जी सर. Can I start? Panelists. जी.
First of all, thank you very much, organizers, for inviting doctors from various parts of the country, and especially the family medicine doctors, and posting them on the stage. और उसके लिए भी यहाँ से भी एक हमें बताया गया कि जी आपके लिए बड़े एजाज़ की बात है कि आज आप स्टेज पे बैठे हुए हैं. यहाँ पे 4 क्वेश्चंस डिस्प्ले हैं. पहला क्वेश्चन है, व्हाट आर द चैलेंजेस फेस्ड बाय द फैमिली फिजिशियंस? बेचारगी कि जी आपको क्या क्या कोई मसले मसाइल हैं तो बताए जाएं. क्वेश्चन नंबर 2, डू यू थिंक इट इज़ गेटिंग इट्स ड्यू रिकग्निशन? आप बताइए कि क्या आपको कोई रिकग्निशन कोई मिल रही है? नहीं, बेचारगी, पसमानदगी. नंबर 3, हाउ डू यू थिंक वी कैन प्रमोट फैमिली मेडिसिन? मैंने 35 साल लाहौर में प्रैक्टिस कर ली, डॉक्टर तारिक मियाँ ने 40 साल, और बहुत सारे लोग ऐसे जिन्होंने 50 साल, एंड वी आर स्टिल इन द प्रमोशनल फेज. हमसे पूछा जा रहा है कि हाउ कैन वी प्रमोट फैमिली मेडिसिन. क्वेश्चन नंबर 4, डू यू थिंक द फैमिली फिजिशियंस आर डूइंग जस्टिस टू देयर जॉब? पहले 4 सवालों में पसमानदगी और ये सारा कुछ बताने के बाद आखिर में कटहरे में भी फैमिली मेडिसिन के लोगों को पूछा जा रहा है कि आप अपनी जॉब से जस्टिस कर रहे हैं. अच्छा, जस्टिस क्या है? सुबह से, बल्कि अगले 3 दिन का प्रोग्राम मेरे सामने है, मैं बड़े ही अदब के साथ, बड़ा हम्बली, बहुत दुखी दिल के साथ मैं ये ऑर्गेनाइजर्स से पूछने की जिसारत कर सकता हूं कि क्या कराची में आगा खान मेडिकल यूनिवर्सिटी में फैमिली मेडिसिन डिपार्टमेंट नहीं है? यूएचएस में फैमिली मेडिसिन डिपार्टमेंट नहीं था? फातिमा मेमोरियल लाहौर में फैमिली मेडिसिन डिपार्टमेंट नहीं था? आपने किसी भी डिपार्टमेंट से एक भी स्पीकर नहीं लिया एक्सपीरियंस शेयरिंग कर सके. सर मॉडरेट, लेट मी फिनिश. यहां से सुबह से इतने पैनलिस्ट, आपने किसी भी पैनलिस्ट के साथ आपने फैमिली मेडिसिन के बंदे से ये पूछा कि जी आप भी बताइए कि आप डायबिटीज कैसे ट्रीट करते हैं, आपका एक्सपीरियंस क्या है विद SGLT2, विद GLP-1 एनालॉग्स, विद हाइपरटेंशन, ऑल दैट. सो रिकग्निशन तो मैडम तब मिलेगी, हमारे वो टीचर्स, हमारे जो मोहतरम असातिज़ा कराम यहाँ बैठे हैं, जिनको देख के, जिनको हमने लर्न किया, ये हमें रिकग्निशन देंगे तो रिकग्निशन मिलेगी. अदरवाइज फैमिली मेडिसिन, यहाँ पे एक बच्चा था जो कह रहा है कि मैं इंटरनल मेडिसिन में, बेटा मेडिसिन इन दिस पार्ट ऑफ द वर्ल्ड, इस मुल्क में आप सिर्फ क्लिनिक करेंगे, आप जो म्यूनिसिपल कमेटीज हैं, इनकम टैक्स वाले हैं, पुलिस वाले हैं, उनसे उनके हाथों ब्लैकमेल होंगे और नोबडी वुड बी ऑन योर बैक. सो टू कट द स्टोरी शॉर्ट, मैं डोंट वांट टू टेक मच ऑफ द टाइम. फैमिली मेडिसिन को ड्यू रिकग्निशन दी नहीं गई इसी कम्युनिटी के साथ, अदरवाइज वी कुड हैव डन वंडर्स. और 2011 में, फिर कोविड में, फिर अभी अगेन डेंगू एपिडेमिक्स के अंदर वो वंडर्स लोगों ने देखे, और इसका इतराफ श्रीलंकन डॉक्टर्स ने जो यहाँ ट्रेनिंग के लिए आए थे. मैं उसके बाद बात खत्म कर दूंगा. उन्होंने कहा कि जब हमने पाकिस्तान में फैमिली मेडिसिन के डॉक्टर्स को देखा तो हमें हसरत हुई कि काश अगर इस तरह के फैमिली मेडिसिन के डॉक्टर्स श्रीलंका में या थाईलैंड के अंदर होते तो वहां पे डेंगू से इतनी अमवात ना होती. आप सबका बहुत शुक्रिया.
Thank you. Just to get the record straight, Dr.
एक मिनट सिर्फ उसका जवाब मुझे देने दें. ताहिर चौधरी साहब ने बड़ी जज्बाती बातें की एंड वी अप्रिशिएट इट, लेकिन हकीकत यह है कि बिलीव मी, ट्रस्ट मी, पूरा मुआशरा बहुत ज़्यादा इज़्ज़त देता है फैमिली मेडिसिन के फिजिशियंस को, और हम भी बहुत ज़्यादा देते हैं. दिस इज़ द रीज़न कि पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन ने एक सबसे बड़ा जो फोरम, सबसे ज़्यादा टाइम दिया हमने फैमिली मेडिसिन के इस डिबेट को दिया है, और हमारे सर आँखों पे हैं. देखें, इसमें कोई वी आर नॉट कम्पीटिंग विद ईच अदर, वी आर गोइंग टू कम्प्लीमेंट ईच अदर. सबसे इंपॉर्टेंट चीज़ है कि फैमिली मेडिसिन और हमें एक जैसा सोचना है, हमें एक तरफ खड़ा होना है, बीमारियों को दूसरी तरफ खड़ा होना है. इट इज़ नॉट के जो कंसल्टेंट या ऑर्गेनाइजेशंस हैं, मैं ज़ाती तौर पे आई एम प्राउड ऑफ माय फैमिली फिजिशियंस. बिलीव मी, मैं अभी इस मोहम्मद साहब के बैठे थे, मैंने इन्हें कहा था जी मेरी मुशाहिदा ये है कि जब भी कोई भगवानपुरे से ملکوں میں ٹریننگ کی, وہاں فیملی میڈیسن میرے جو کولیگز جنہوں نے سی پی کی بے انتہا تھے. جیسے یہ بچے نے کہا, یہ ہی از ناٹ دی اونلی ون, آئی کین ٹیل یو ڈزنز اینڈ ڈزن جنہوں نے ایم آر سی پی کر کے کنسلٹنٹ بن کے فیملی میڈیسن آپٹ کی. یہ دس از آپٹیڈ بیکاز یو آر دی ریئل بیس آف دی پیرامڈ, وی آر جسٹ دی ٹپ آف دی پیرامڈ. آپ بہت امپورٹنٹ ہیں. میں تو پہلے ہی کہہ رہا ہوں ہیلتھ کیئر ڈلیوری میں ایسا کوئی ایشو نہیں ہے, اینڈ ہم آپ سے سیکھ رہے ہیں اور اسی لیے یہ سیشن رکھا گیا. اور آئی ایم گریٹفل ٹو مائی سائنٹیفک کمیٹی عزیز الرحمان صاحب کہ انہوں نے رکھا, اور بڑا اچھی بات ہے. جو بھی باتیں ہو رہی ہیں آئی تھنک وی شوڈ ٹیک اٹ پازیٹیولی, اور بہت اچھی باتیں ہو رہی ہیں. اور میرا خیال ہے اس سب آپ کچھ کہنا چاہ رہے تھے سر.
بسم اللہ الرحمن الرحیم. یقین کریں کہ جب بچپن میں ہم بیمار ہوا کرتے تھے تو ڈاکٹر کے پاس جب جاتے تھے, اور جو ظاہر فیملی فزیشین تھے, تو ہم ان کو ایسے دیکھتے تھے جیسے یہ کوئی فرشتہ ہے, اور ان کے متعلق اتنی نظروں میں عقیدت اور محبت ہوتی تھی کہ ہم بعد میں بھی جب بھی وہ ان کے نزدیک سے کبھی گزرتے تھے تو ہم سوچتے تھے کہ ہم ایک بہت بڑے آدمی کے پاس سے گزر رہے ہیں. یعنی اتنی یہ بچپن سے ہمارے دلوں میں اتنی عزت ہے ہمارے جو ڈاکٹر جنرل پریکٹیشنرز ہیں. تاہم میں آپ کو صرف یہ عرض کرنا چاہتا ہوں کہ لاہور میں, یہ میں سارے اپنے ملک کے لیے بتانا چاہتا ہوں کہ ہمارے لاہور کے شہر میں ایسے ڈاکٹرز تھے کہ جنہوں نے, آپ یقین کریں کہ 15 سال تک ایک ہر ویک کلینکل کانفرنس ان کے ہاسپٹل میں ہوتی تھی, اور بغیر کسی ناغے کی انہوں نے کی ہے. اور ہر دسمبر کے ہر سال کے ہر دسمبر میں وہ ایک نیشنل اور انٹرنیشنل کانفرنس کروایا کرتے تھے. وہاں پر 2 آرگنائزیشن تھیں, دونوں ہی یہ کام اتنا کر رہے تھے کہ میں خود آپ کے سامنے اتفاق کرتا ہوں کہ کچھ عرصہ میرے اوپر بڑے برے دن آئے تھے, تو میں وہاں پر ایک بشیر ہاسپٹل تھا, تو میں وہاں پر نزدیک تھا, تو میں وہاں ہر ہفتے جا کے اٹینڈ کرتا تھا. اور جب میں ری انسٹیٹ ہوا تو میرے علم میں کوئی خاص فرق نہیں تھا کہ مجھے اتنی ایفرٹ کرنی پڑے کہ میں دوبارہ ٹیچنگ کر سکوں. دوسری بات یہ ہے کہ میں جب پاکستان میڈیکل اینڈ ڈینٹل کونسل نے جن کے یعنی کہ قصور کے دے دیں, ننکانہ صاحب کے دے دیں, شیخو پورہ کے دے دیں, لاہور کے دے دیں, جن میں ہم ڈائریکشن دیں ہر میڈیکل کالج کے پرنسپل کو کہ آپ نے ایک خاص مخصوص عرصے تک ایک بیچز بھیجنے ہیں انڈر گریجویٹ اسٹوڈنٹس کے. مگر میں میاں صاحب آپ نہیں تھے اس میں انوالو تھے, مگر میں عرض کروں کہ اس کا کوئی جواب نہیں آیا. میں کہتا ہوں کہ اگر اس کا کوئی جواب اپنے جو فیملی فزیشین ہیں ان کو یہ مارک کریں کہ, اور یہ پھر اپنی یونیورسٹی کی طرف سے انہیں کہیں گے کہ اگر آپ لوگوں نے بیچز جو ہیں ڈاکٹرز کے ادھر نہ بھیجے تو ہم آپ کی مطلب جو پوزیشننگ ہے اس کے ایک ڈیفیکٹو ہو جائے گی آپ کی. دوسری پروپوزل میں نے یہ دی تھی کہ چونکہ اگر کوئی فیملی فزیشین کی کوئی چیئر پروفیسر بنایا جائے تو پرائیویٹ اور گورنمنٹ ہاسپٹل اٹ از اے ہیوج, ایک فیکلٹی چاہیے اس کے لیے, پروفیسر چاہیے, ایسوسیٹ پروفیسر چاہیے, دوسرے سارے چاہیے. تو ہم نے کہا کہ اس وقت پی ایم ڈی سی کی طرف سے پروپوزل گئی کہ اس وقت آپ کا ایک آدمی ہم جنہوں نے ایف سی پی ایس کیا ہے یا ایم سی پی ایس کیا ہے, ہم ان کو ڈپارٹمنٹ آف کمیونٹی میڈیسن میں لے لیتے ہیں, اینڈ دین ہی شوڈ ڈو دی اسپیڈ ورک, اور اس کو بڑھا کے پھر ہم اس کو بہت پھیلا دیں گے. تو یہ آپ یقین کریں کہ آپ لوگوں کی عزت ہمارے دلوں میں جتنی
quality care is important. You need to have a very good integration. میں آپ کو باہر کی بات بتاؤں جو پوچھ رہے تھے. So in UK, 50% of the medical students should compulsory go to general practice. And the rest of the 50% should go to other specialties. پاکستان میں چونکہ پرابلم کیا ہے کہ ابھی تک سروس لیول پہ فیملی میڈیسن کا کوئی کیڈر نہیں بنا, تو اس لیے یہ پرابلمز آ رہی ہیں. لیکن کافی کام ہو گیا ہے. میں ان سب سے جونیئر ہوں کہ مجھے پاکستان آئے ہوئے صرف 3 سال ہوئے ہیں, لیکن 3 سال میں we managed to get 100 hours. اسٹوڈنٹ اب اس طرف آئیں گے. جس طرح ڈاکٹر صاحب نے سوال پوچھا تو اس کا جواب یہ ہے کہ بیٹا if you do FCPS in family medicine, yes, you can be a faculty in any medical college. یہ already approved ہو چکا ہے. تو آپ کو پوسٹ بھی ملے گی. You can work as your own practice آپ کھول سکتے ہیں. گورنمنٹ جس پہ کام کر رہا ہے کہ پرائمری کیئر کو مل سکتا ہے, لیکن جیسے اس نے کہا نا کہ بھئی if you want to bring change, you should bring your own change. یہ تو خیر وہ کنڈکٹر صاحب نے کہا تھا نا کہ if you want to bring change, bring your own change. تو لائٹر نوٹ پہ کہ چینج لے کے آنا ہے. But for that we need to change this attitude. ایک ایٹیٹیوڈ ہوتا ہے جیپنیز کا کہ if one can do it, I can do it. If no one can do it, I must. یا حبیبی how can I do it. تو ہمارا یہ والا ایٹیٹیوڈ جب تک ختم نہیں ہوگا تو کام نہیں ہوگا. لیکن انشاءاللہ ریکگنیشن بھی آ رہی ہے, گورنمنٹ لیول پہ ریکگنائز بھی ہو رہا ہے. اور جس طرح سر نے کہا نا صحت کارڈ, جب صحت کارڈ امپلیمنٹ ہوگا ہیلتھ انشورنس, یو کین ناٹ رن ہیلتھ انشورنس وداؤٹ اے پراپر ریفرل سسٹم. ریفرل سسٹم کے لیے آپ کو گیٹ کیپر رول چاہیے. گیٹ کیپر رول کے لیے فیملی میڈیسن ہوگا. فیملی میڈیسن میں جاب اپرچونیٹی جب آئے گی, پبلک پرائیویٹ پارٹنرشپ پہ جائے گا, تو پھر ان یو کے جیسے ہوتا ہے کہ فیمیل جو ہے یا کسی کا فیملی پرابلمز ہے یا پیپل آپٹ فار دی اسپیشلٹیز, ہم لوگوں نے آپٹ کیا تھا اسپیشلٹی کے لیے یو کے. تو انشاءاللہ things are going to be improved. I know ہم تھوڑے ہمارے کولیگ اس لیے فرسٹریٹڈ ہے کہ they have been doing the efforts for the last 25 years, لیکن everything have its time. میں ان سے زیادہ وہ ایکسائٹڈ تھا, لیکن when I met the PMC president انہوں نے مجھے ایک بات کی کہ if your dream come true while you are alive, so that's never been a dream. تو انشاءاللہ یہ ایک ڈریم تھا جو ہمارے بڑوں نے دیکھا اور ابھی ٹائم آ رہا ہے, اینڈ انشاءاللہ ینگسٹر ہمیں سن رہے ہیں اینڈ دے آر ہونی چاہیے. وائی وڈ اے پیشنٹ ٹرسٹ می جب اس کے پاس اپرچونیٹی ہے کہ وہ اسپیشلسٹ کے پاس خود جائے؟ بیکاز میں اس کو ایسی سروس پرووائڈ کروں تاکہ وہ ہولسٹک بھی ہو, میری کیئر بھی اچھی ہو, میری کنسلٹیشن سکلز بھی اچھی ہو, میرا کلینک صاف بھی ہو, وہ وہاں پہ کرسی پہ بیٹھ بھی سکے. اس کو تب جا کے وہ دیکھے گا کہ یار وائی وڈ آئی گو ٹو ہاسپٹل جہاں پہ مجھے دکے کھانے ہیں, میں نے رش میں بیٹھنا ہے, میں اپنے فیملی فزیشین کے پاس کیوں نہ جاؤں جو میرا پرابلم حل کر سکتا ہے. تو یس وی شوڈ ٹیک ریسپانسبلٹی, اور اس طرح کا کوئی میکینزم ہونا چاہیے اور اس کو ریگولیٹ کرنا چاہیے.
رائٹ. جی سر میں جی جی I'll take a comment from Dr. Farhan and then Dr. Sheila. آپ کا ایک کامنٹ لینا ہے. جی مائک دے دیں.
میں نے جی آئی ایم فرام کراچی. مائی نیم از پروفیسر ڈاکٹر فرحان عیسیٰ عبداللہ, اور میں ڈاؤ یونیورسٹی میں پروفیسر تھا انفیکشیس ڈیزیزز, اور ریسنٹلی آئی جوائن مائی فادرز لیب ڈاکٹر عیسیٰ لیبارٹری. میں جو آپ کی سر بہت اچھی باتیں آپ نے سنی, پتہ نہیں کراچی میں تو فیملی فزیشنس تو بہت ہائی سمجھے جاتے ہیں, یو نو, اینڈ اور بہت ان کی رسپیکٹ ہے, اینڈ وی ریئلی آئی پرسنلی فیل دیٹ بہت ہی کرٹیکل ہے. لیکن جو آپ نے کمنٹس دیے میں بڑا انٹرسٹنگ مجھے سمجھ میں آیا, کیونکہ ریسنٹلی ہمارا UHS میں ایک MOU سائن ہوا ہے پروفیسر جاوید اکرم صاحب کے ساتھ, اور مجھے یہاں سے پتہ چلا پروفیسر جاوید اکرم صاحب نے ہم سے کہا, کیونکہ یہاں پہ سر ہمارے ایوری 3rd ڈے ہمارا یا 2nd ڈے CME سیشنز ہوتے ہیں فار فزیشنز, فیملی فزیشنز, اور रेगुलर होते हैं, उसमें 100+ लोग पार्टिसिपेट करते हैं, और इसी तरह से हॉस्पिटल के स्पीकर्स भी आते हैं, तो एक बड़ा अच्छा रेफरल सिस्टम भी हो गया है. तो फैमिली फिजिशियंस पेशेंट्स को देखते हैं, इफ दे नीड अ सर्जरी वो सर्जन को भेजते हैं, सर्जन फिर पोस्ट ऑप के लिए वापस फिजिशियन को भेज देता है. तो जावेद साहब ने हमें बुलाया और हमें वहाँ पे UHS में बुलाया और बड़ी इज्जत दी, मुझे को चेयर कराया, और उन्होंने कहा कि हम ये चाहते हैं कि फैमिली फिजिशियंस को जो लाहौर के अंदर भी यही प्रोग्राम्स होने चाहिए, और बल्कि कराची में जो हम CME सर्टिफिकेट्स देते हैं वो अक्रेडिटेड नहीं होते. और प्रोफेसर जावेद अकरम ने कहा वी वांट ऐसा सिस्टम जिसमें फैमिली फिजिशियंस को टॉप मोस्ट प्रायोरिटी दी जाए, और हम चाहते हैं कि UHS के उनको क्रेडिट आवर्स भी दिए जाएं और एक पूरा सिस्टम किया जाए. तो जस्ट टू एज ए न्यूट्रल ओपिनियन मेरी गुजारिश कहने की सिर्फ ये थी कि एज फार एज आई कंसिडर, और मैंने तो कराची में आके सबको बोला कि अनबिलीवेबल है, कभी डाउ यूनिवर्सिटी में हम थे, हमें तो कभी उन्होंने क्रेडिट आवर्स की ऑफर नहीं की जितनी रिस्पेक्ट फैमिली फिजिशियंस की जावेद साहब कर रहे थे. तो जस्ट टू गिव अ सेकंड ओपिनियन.
जी जी, थैंक जी सर. जी Not at all.
प्रोफेसर जावेद अकरम साहब ने जितना फैमिली मेडिसिन को लाहौर में सपोर्ट किया, और हमारे उनके साथ कोई दोस्ताना मरासम या कोई कुलीग्स वाले ताल्लुकात नहीं है, इज जस्ट लाइक अ बिग ब्रदर. आप डॉक्टर साहब अगर कराची में हैं, मैं यहाँ पे बैठे हुए तमाम लोगों से ये सवाल करता हूँ, पाकिस्तान में जितनी ऑर्गेनाइजेशन है, स्टार्टिंग फ्रॉम पाकिस्तान एंडोक्राइन सोसाइटी, पाकिस्तान हाइपरटेंशन लीग, आज चलें ये भी उसी एक लपेटे में आ गए सारे में, आज तक जितनी भी पाकिस्तान के अंदर कॉन्फ्रेंसेस होती हैं नेशनल, आप मुझे बताइए कभी किसी कॉन्फ्रेंस के अंदर आपने फैमिली मेडिसिन के किसी शख्स को स्टेज पे बैठे देखा हो इन द पैनलिस्ट, और उसकी ज्यादा से ज्यादा, जी इट्स वेरी रेयर, इट्स वेरी रेयर. तो इस वजह से ये हुआ, एक प्यार भरा, एक मोहब्बत भरा, एक इसको शिकवा ना समझे, एक मतलब एक वी आर लर्निंग फ्रॉम ईच अदर.
थैंक यू सर.
जावेद अकरम साहब इज एन एक्सेप्शन, ही इज एन एक्सेप्शन इन ऑल दैट.
थैंक यू सर, आपका कमेंट आ गया. मैं रिक्वेस्ट करना चाहूंगी डॉक्टर शैला नसीम से, फिर अल्ताफ चीमा साहब, और फिर कंक्लूडिंग रिमार्क्स अगर प्रोफेसर शहजाद आप दे सकें.
Assalamualaikum. I represent College of Family Medicine, Pakistan, the oldest organization of family physicians in the country, and which came into being in 1974. And the organization has been working, and it's also been providing CME. It was the first organization to be recognized by PMDC to give credit hours to for the CME courses. And we've been conducting structured CME programs since 2006. We've also been the co-convener of MRCGP international exams, and currently also we have trained about more than 3,000 general practitioners in our structured programs, and we stopped doing these face-to-face programs in 2014. Our last program was in 2014, which was the 14th revision course in family medicine. 2015, because of we stopped it in 2019. After that was the 14th course that we did, and then we stopped because of the COVID, and now we planning to restart that. Now why I'm saying all this is the challenges faced by family physicians. Now interestingly, whatever we are doing here is sometimes it doesn't trickle down to the doctor who's sitting in Tandobago. I'm from rural Sindh. So the one who's sitting in Tandobago or in Sangar or in Sinjoro or in Shahpur Chakar, उन तक जो ये हम कह रहे हैं ना, ये मुश्किल से पहुंचता है. आइदर तो वो अपना वहाँ से आएँ, आके यहाँ अटेंड करें, या किसी हॉस्पिटल में अटेंड करें. So the college is providing an online training programs, और हमारे online training programs में what we are looking at is to create a 5-star doctors, जिनको at least 5 specialities के अंदर management कर सकते हों. Why we are aiming at it? Because in the rural areas no specialist will go. This doctor is the one who's providing everything. Very interestingly, we underestimate our family physicians, because this is a person, GPs are not, you'll be surprised that they're more knowledgeable than what you think about them. They don't have any interaction with a teaching hospital, but they are providing services in that downtrodden area. And to top it all, We have this DIE programs, NGOs who are training quacks and creating quacks. And we also have to confront those. Instead of training those doctors who are sitting in those areas, what we are actually doing is we are taking matriculates and we are training them. Why? So these are some of the questions we need to ask ourselves. And we need to ask those people who are making the PC1s and making these, interventions. Why can't you train those doctors? They are there. So, excuse me. These are the challenges that we are facing. The other challenge, the biggest one that we face is, then when we do make these programs, nobody wants to recognize them. There's so much red tapeism. PMDC, जहाँ पे हम 90% GPs हैं, जो हम उनको fees pay कर रहे हैं, या PMC for that matter, but they will not recognize those programs जो specially doctors के लिए जो कि general practice में हैं, उनके लिए बनाए जाते हैं. Nobody wants to. Why? So this is something that I've been trying to question, because they don't want to represent the general practitioner. So I feel that the challenge that we face is there's a look down attitude towards the general practitioners.
ठीक है मैडम, आपका पॉइंट आ गया है. अब डॉक्टर अल्ताफ चीमा को मैंने
मुझे एक लास्ट पॉइंट देना है. जनरल प्रैक्टिशनर्स को आप अंडर एस्टिमेट ना करें. दे आर स्मार्ट होलिस्टिक डॉक्टर्स हु आर सर्वाइविंग ऑन देयर ओन in all kinds of situations and provide cost-effective health care to communities. This is very interesting. Despite all that, हम उनके ऊपर बहुत सारी उंगलियां उठाते हैं, मगर एक बात याद रखिएगा, there are good specialists and there are bad specialists. There are good general practitioners, there are bad general practitioners. So you cannot, just एक दो की वजह से हर किसी का दिल चाहता है कि मैं जनरल प्रैक्टिशनर्स को ट्रेन करूं, लेकिन it has to be a two-way traffic. So I think this is what we need to do. Thank you.
Thank you.
Thank you, madam. बिस्मिल्लाहिर्रहमानिर्रहीम. आपने PMDC का जिक्र किया, PMC का, तो I have noted down some recommendations. I'll quickly go through them. The family medicine be given a fair representation in PM and DC. The senior family physicians of good standing be involved in policy making. Nobody understands primary care better than a doctor who has worked in a primary care setting with all its difficulties and challenges. Family medicine departments be developed in all medical teaching hospitals. Scholarships be introduced for family physicians aspiring for postgraduate studies. Institutions promoting CME for family physicians be supported by the government, both morally and financially. The family physicians who have undergone training and acquired diplomas of certificates like our MRCGP, MCPS, be given recognition by, हमने बड़ी efforts के बाद MRCGP को recognize करवाया था PMC से. उसके बाद है, this will help raise the standard of health care at the primary level. There is a need to make full use of the services of the family physicians in programs like population planning, immunization, TB control, typhoid, malaria, dengue, and so on. Their services can always be asked for in case of natural disasters or calamities. The medical graduates be encouraged to consider family medicine as a career, where they can have an opportunity to work both as a professional and an entrepreneur. Interest-free or soft loans be provided to the family physicians to set up or upgrade their clinics. Thank you.
Thank you, sir. I would like to request Dr. Shahzad Ali Khan, after listening to all the debate, if he can give some conclusion remarks, please.
जी, अस्सलाम वालेकुम, थैंक यू. एक तो सॉरी फॉर बीइंग लेट. मेरा ख्याल है हमारा से 4 बजे का सेशन था, तो डॉक्टर सोमिया से मैंने पूछा तो वो प्रीपोन हो गया, 3 बजे हुए. मैं 2 बजे पहुंच गया था उसमें होटल में. अभी जितना मैंने सुना है, अब पहले तो मैं ये बताऊं कि वाई आई एम सिटिंग इन दिस फैमिली मेडिसिन सेशन. हेल्थ सर्विसेज एकेडमी इज़ वन ऑफ द, आई थिंक इज़ द ओनली इन द फेडरल सेक्टर. फेडरल में हम वाहिद हैं जो فیملی میڈیسن کا ڈپلوما چلا رہے ہیں اور اس کے بعد ہم نے اس کو کنورٹ کرنا ہے ایم ایس میں اور فردر اس کو آگے لے کے جانا ہے. میں نے 2 کوہارٹس کمپلیٹ کر لی ہیں, تیسرا کوہارٹ ہم نے ابھی ایڈمیشن کیا ہے. 13 یا 14 مئی سے فیملی میڈیسن کا جو ایک ڈپلوما ہے اس کا 3rd کوہارٹ شروع ہو جائے گا. UHS میں جاوید اکرم صاحب نے شروع کیا تھا, اس کے بعد ہم نے WHO کے ساتھ اس کی لنکیج ڈیولپ ہوئی تھی. گورنمنٹ خود اس کو پروموٹ کرنا چاہ رہی ہے اور چاہ رہی تھی پہلے بھی اور ابھی بھی. اس کی وجہ یہ ہے کہ جس طرح ڈاکٹر صاحب نے کہا, جب آپ کا ایک بغیر کسی سسٹم کے ایک ہیلتھ سسٹم چل رہا ہو, ہیلتھ سسٹم سو کالڈ ہیلتھ سسٹم وداؤٹ اے سسٹم, تو اس میں سارے کے سارے لوگ اپنا اپنا رول پلے کرتے ہیں. تو اس میں جو جی پی جو ہوتا ہے وہ ایک بیس لیول پہ پرائمری کیئر لیول کے اوپر ایک اس کی اپنی ایک امپائر ہوتی ہے, ٹھیک ہے نا. تو وہاں پہ وہ کام شروع کرتے ہیں, وہ کسی سے انٹیگریٹ نہیں ہوتے اتنے زیادہ. تو آج جو یہاں پہ ایک تو میرا یہ وجہ ہوئی کہ میں چونکہ ایک ایکیڈیمک سیشن میں ایکیڈیمک آرگنائزیشن سے ہوں جس کا کہ فیملی میڈیسن ایک بڑی ہائی پرائرٹی میں ہے. خواجہ صاحب بھی ہمارے ساتھ آئے ہیں اور لوگ بھی, ہم نے کافی ساری فیملی میڈیسن کی کانفرنس کے اندر بھی ہم نے پریزنٹ کیا ہے. اینڈ وی آر آلسو پروموٹر آف فیملی میڈیسن ایجوکیشن, بیکاز ان اینی فارمل پراپر سسٹم, جب سسٹم بن جائے گا جس کو بنانے کی کوشش کی جا رہی ہے, چاہے وہ صحت سہولت پروگرام کے تھرو ہو یا نیشنل ہیلتھ انشورنس پروگرام ہو یا جو بھی اس کا نام دیں, اس کے اندر سب سے کریٹیکل رول جو ہوگا وہ جی پی کا ہوگا. میں اپنی بات کروں آپ کو تو میں خود جو ڈاکٹر بنا ہوں نا, وہ میں ایک اپنے خاندان کا جو جی پی تھا اس سے فیسینیٹ ہو کے ڈاکٹر بنا تھا. اور میجورٹی لوگ جو یہاں بیٹھے ہوئے ہیں یہ اس اسمارٹ آدمی سے, کیونکہ سب سے زیادہ ویل مینٹینڈ بندے جی پی ہوتے ہیں اپنے علاقے کے نا, جو سب سے زیادہ ٹائی شائی سوٹ جو انہوں نے پہنے ہوتے ہیں, اسمارٹ ہوتے ہیں, گورے چٹے. جو ذہن میں جو بندے کے آتا ہے نا ایک اچھا ڈاکٹر, وہ جی پی ہی آتا ہے ذہن میں. وہ جو میڈیسن میں کام کرتے ہیں, سرجری میں کام کرتے ہیں, ہسپتالوں میں ان کا تو حال ہی برا ہوتا ہے. دوسری بات آپ کو میں ایک اور مزے کی بتاؤں, یہ دے آر ویری ویل مینٹینڈ, نمبر 1. نمبر 2, آپ سروے کر لیں, پاکستان میں سب سے زیادہ لائف ایکسپیکٹینسی جو ہے نا وہ جی پی کی ہے. دے آر دا اونلی ڈاکٹر. یہ نسلوں کی نسلیں ختم ہو جاتی ہیں اور ان کی پریکٹس چل رہی ہوتی ہے, ٹھیک ہے نا. اینڈ دیر از اے ریزن فار دیٹ, بیکاز ان کی جو کی ٹو ہیپینس ہے نا, دا کی ٹو ہیپینس از سانو کی. دیر کی ٹو ہیپینس از سانو کی. بھاڑ میں جائیں سارے کے سارے, میرا اپنا کلینک ہے, میرا. دے ڈونٹ وانٹ ٹو ورک ود دا گورنمنٹ, دے ڈونٹ وانٹ ٹو ورک ود اینی آرگنائزیشن, بیکاز ان کی اپنی ایک امپائر ہوتی ہے, ٹھیک ہے. اور وہ بادشاہ ہوتا ہے اپنے علاقے کا. ایم این اے بھی اس کے پاس آتا ہے, ایم پی بھی اس کے پاس آتا ہے, لوکل لوگ سارے سے آتے ہیں. میرا اپنا اٹک سے میرا تعلق ہے, جو جی پی مشہور جی پی ہیں وہاں کے, وہ اتنے بڑے پاورفل ہیں کہ پولیٹیشین جاتے ہیں ان کے کلینک پہ کہ ساتھ ساڑھے ہستے کوئی بول دینا, ساڑھے سپورٹ ہستے. سو دے ہیو اے ویری 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 ہائی لیول آف فین فالوئنگ. دوسری بات یہ ہے, بچپن میں جس طرح میں 67 کی میری پیدائش ہے, تو میں بچپن سے 70s میں اگر آپ دیکھیں تو دا کرٹیکل بہت رول تھا جی پی کا, اور سب سے زیادہ پرائمری کیئر تو ساری جی پی نے سنبھالی ہوئی تھی. 80s میں ضیاء صاحب کے دور میں یہ جب ریفارم شروع ہوئی نا BHU والی, اور انہوں نے اس کو کیپٹلائز کرنے کی بجائے وہ جو ایک سب سے کرٹیکل رول تھا جی پی کا, اس کو نکال دیا سسٹم سے اور BHU کو بنا دیا پرائمری کیئر, اور اربن میں سینٹر بنا دیے, ڈسپینسریاں بنا دی جہاں پہ ینگ لڑکے, ایون فائنل ایئر کے اسٹوڈنٹ بھی انہوں نے بھرتی کر کے وہاں پہ لگاتے تھے ڈسپینسریوں میں. فائنل ایئر میڈیکل کر رہے تھے اور وہاں MO کی ڈیوٹی کرتے تھے ہاسپٹلز میں. تو یہ 80s میں یہ ہوا, جس کی وجہ سے بہت بڑا نقصان ہوا ہے فیملی میڈیسن کی, فیملی پریکٹس ماڈل کو, جس کو ریوائیو کیا جا رہا ہے ابھی دوبارہ سے. ایک اور چیز آپ ذہن میں رکھیں کہ یہ جو پرائمری ہیلتھ کیئر ہے, یہ جو گورنمنٹ نے جو پرائمری ہیلتھ کیئر جس کو سو کالڈ, اس کو پرائمری ہیلتھ کیئر نہیں کہہ سکتے, پرائمری کیئر کہنا چاہیے. پرائمری ہیلتھ کیئر تو پورا ایک فلسفہ ہے. پرائمری کیئر کہہ لیں, فرسٹ لیول کیئر کہہ لیں, جس کی کوشش ہے اربن اور رورل ایریاز میں. اس کے اندر بھی وہ چیز, وہ میگنیچیوڈ, وہ ایپیڈیمک ہم نہیں کنٹرول کر سکتے جو ایپیڈیمک ہماری آ چکی ہے, NCDs کی بھی اور انفیکشنز کی بھی. اگر آپ پرسنٹیجز دیکھیں, پاکستان میں جو اسٹیٹسٹکس کہتی ہے 1 in 4 adult is hypertensive and 1 in 3 above the age of 40 is hypertensive. 13 سے 16% ڈائبٹیز آ رہی ہے آپ کی, 9.7% ہیپاٹائٹس C ہے, 4 to 5% ہیپاٹائٹس B ہے, انیمیا 44% ویمن میں, وٹامن ڈی ڈیفیشنسی 80%. سو جو ہماری NCDs کا آپ دیکھ لیں, ساری کے ساری جو فگرز ہیں اس میں اتنی سیریس ایشوز ہیں کہ وہ کوئی بھی پرائمری کیئر دنیا کا اس کو جی پی کی مدد سے نہیں ختم کر سکتا. ضرورت کس چیز کی ہے, جو آخر میں سوال لکھا, بلکہ سیکنڈ اور تھرڈ سوال جو آپ کہہ رہے ہیں, آخری کا پہلے جواب دے دیتا ہوں. یس, دے آر ڈوئنگ آل دا جسٹس ٹو دیئر جاب. میرا یہ واحد ڈاکٹر ہے, یہ واحد ڈاکٹر ہے جو اپنی فیملی کی شادیاں چھوڑ دیتا ہے, جنازے چھوڑ دیتا ہے کہ یار نہیں میرے تو مریض بیٹھے ہونے, یا فٹافٹ شکل دکھا کے واپس پہنچتا ہے, ٹھیک ہے. اور اتنی ڈیڈیکیشن سے یہ جاب کرتا ہے کہ جب یہ 60 کراس کرتا ہے تو ہی بیکم سینیکل. وہ سسٹم سے ناراض ہو جاتا ہے کیونکہ اس نے اپنی زندگی جوانی لگائی ہوتی ہے اس پریکٹس ماڈل میں. سو میرے خیال میں سب سے زیادہ ڈیڈیکیٹڈ جو ڈاکٹر ہے, جو سب سے زیادہ پیشنٹ کے ساتھ کام کرتا ہے, وہ جی پی ہوتا ہے, اور بہت زیادہ جسٹس کر رہے ہیں. ہمیں صرف جو ان کا جو ایک تھوڑا سا مائنڈ سیٹ جو ابھی میں جس کی میں نے بات کی, they don't want to integrate with anyone else. PSIM نے ان کو ہم نے اس کو ایک پورا سیشن دیا. اس کا مطلب ہے کہ یہ بہت بڑی ریکگنیشن ہے. میں خود ہماری اینول پبلک ہیلتھ کانفرنس ہوتی ہے, ہم نے ایک دفعہ فیملی میڈیسن کا سیشن رکھا تھا. ادروائز سیشن رکھنا کسی کانفرنس میں اٹ از اے ویری کاسٹلی, پلس اٹس اے ویری, وہ کہنا چاہیے ٹائم نکالنا, سب کچھ کرنا, جب تک بہت ہائی امپورٹنس نہ ہو آپ کانفرنس میں سیشن رکھتے نہیں ہیں. تو آئی واز ویری ہیپی ٹو سی ڈیڈیکیٹڈ سیشن آن فیملی میڈیسن. اور جب مجھے ریکویسٹ کی, جاوید صاحب نے مجھے کال کی, میسج کیا, انہوں نے کہا اس کا تم نے سیشن چیئر کرنا ہے. میں نے کہا جی بالکل حاضر ہیں, ہم آ جائیں گے. تو اب اس کے اندر اور میں چونکہ فیڈرل گورنمنٹ میں ہوں اسلام آباد میں, ہم نے ہر جو اس وقت پلاننگ ہو رہی ہے نا, چاہے وہ میڈم شیلا کہہ رہی تھی PC1 ہو یا پالیسیز ہوں, ابھی ہماری ایک نئی اسٹریٹجی پہ بھی کام ہو رہا ہے, نئی ہیلتھ پالیسی, جو پہلے نیشنل ہیلتھ ویژن تھی اب نیشنل ہیلتھ پالیسی کے اوپر کام ہو رہا ہے. اس کے اندر بھی ایک پورا کا پورا چیپٹر ہے فیملی پریکٹس ماڈل کے اوپر, GP ماڈل. اس کے مختلف نام ہیں, کوئی اس کو فیملی پریکٹس کہتا ہے, کوئی اس کو جنرل پریکٹیشنر کہتا ہے, کوئی اس کو فیملی میڈیسن کہتا ہے, بٹ دا مین اس کا جو بز ورڈ ہے وہ GP ہے. جی پی کے بغیر NHS نہیں چل رہا, جی پی کے بغیر میڈیکیئر میڈیکیٹ سسٹم نہیں چل رہا, کینیڈین سسٹم نہیں چل رہا, پاکستان میں کیسے کوئی سسٹم چلے گا. سو ان اینی ایسپیکٹ میں آپ کو ایک اور بات بتاؤں کہ ہم نے اسلام آباد میں اور گجرانوالہ میں 2 جگہوں پہ چھوٹا سا ایک پائلٹ کیا ہوا ہے نیشنل ہیلتھ انشورنس پروگرام کا, جس میں ہم OPD شروع کرنے سے پہلے, OPD میں ابھی آپ کو پتا ہے کہ انڈور کے لیے ہے صرف, دی سیلس پروگرام از اونلی فار سلیکٹ پیکیجز آف انڈور. OPD کے لیے ہم نے ایک پورا پائلٹ ہم رن کر رہے ہیں, اور دیٹ از لنکڈ ود دا GPs آف دیٹ ایریا. تو اس کا مطلب یہ ہوا کہ اگر وہ کامیاب ہو جاتا ہے اور اس کے اندر ہم دیکھتے ہیں کہ اس میں بڑا اچھا سسٹم چل رہا ہے, اور وہ گیٹ کیپر آپ ان کو کہہ لیں, لیکن میرے خیال میں وہ سب سے زیادہ بیسٹ بندہ بھی وہی ہے جو کمیونٹی میں رہتا ہے. سو آپ ایک فکسڈ اماؤنٹ آف پاپولیشن ان کے ساتھ, آپ کہتے ہیں 10,000 کا BHU ہے, آپ 10,000 کی آبادی ایک GP کو الاٹ کر دیں تو اٹ وڈ بی مچ بیٹر دین اے BHU, بیکاز BHU میں بلڈنگ کا خرچہ, باقی چیزیں ہیں, یہ تو سارا زبردست اس کا سسٹم بنتا ہے. سو یہ آپ ذہن میں رکھیں کہ جو ہماری ٹریننگز ہیں اس میں فیملی میڈیسن کے جو ایگزسٹنگ جو فیملی میڈیسن کے چاہے وہ PAFP کے لوگ ہوں, اچھا PF کی بھی میں نے نوٹ کیا, مجھے پہلے نہیں پتا تھا کہ ان کے اپنے اندر بھی بڑی سیاست ہے.
سر وہ
ان چیپٹرز ہیں, ان کے بھی چیپٹرز ہیں. وہ ندیم صاحب سے پوچھ لیں, خواجہ صاحب سے, باقیوں سے پوچھ لیں, ایک کو بلاؤ دوسرا ناراض ہو جاتا ہے, یار وہ ساڑھے آئی نہیں ہوں تو انہوں نے کیوں بلایا, فلانے نے کیوں بلایا. سو دا یونٹی ان دیم سیلف نیڈس ٹو بی مچ مور. اور دوسرا یہ کہ نکل کے آنا, انٹیگریٹ کرنا, والنٹیئر کرنا. گورنمنٹ کے ساتھ کام کرنے کو تیار نہیں ہوتے, انہیں پتا ہے گورنمنٹ پیسے ہی نہیں دے گی, سیدھی سی بات ہے. اگر تھی سارے کو کام لے لینا ہے, پیسے تم دو گے نہیں بعد میں, اعتبار ہی نہیں ہے گورنمنٹ پہ کسی کو. سو یہ ایک چیز, 2-3 چیزیں ہیں جو میں نے جاوید اکرم صاحب نے, آفتاب محسن نے, سومیا نے, ہم نے سب نے یہ چیزیں اسی طرح اسی ٹاک کے بعد ایک آپ بنائیں بریفنگ پیپر, ایک پالیسی بریف بنائیں. میری اس کے بعد جا کے میں نے, اب تو آپ کے کراچی کے ہیں ہمارے فیڈرل ہیلتھ منسٹر, میں نے ان سے ٹائم لیا ہوا ہے. نیکسٹ ویک آئی ول گو اینڈ آئی ول میٹ ہم, آئی ول پریزنٹ دیٹ بریفنگ پیپر, آپ مجھے دیں. آئی ایم یور ایڈوکیٹ. تھینک یو ویری مچ.
جی سر, آپ کا کامنٹ, لیکن کیپ اٹ ویری شارٹ پلیز. تھینک یو. سر کو مائکروفون دے دیں پلیز. I think while we are waiting, I think on behalf of Family Medicine Fraternity, I would like to thank PSIM President Professor Javeed Akram and his entire team who provided us this opportunity to debate.
Assalamu alaikum. Dr. Muhammad Ayub Khan, working as Assistant Professor of Medicine, Sedu Group of Teaching Hospital. I'm representing from SWAP. I'm the only person who is representing that community. While telling you about the family medicine, I'm not sure what is family medicine until now. There is no concept of family medicine over there. And we are still thinking that the people who are sitting is GP over there, they can refer the patient very well than any person else that. جو ہم یہاں پہ بتا رہے ہیں, آپ کو ایک دوسرا حقیقت یہاں پہ بتا رہا ہوں فیملی فزیشین کے لیے. ہمارے کالج میں 2 پوسٹ ہے فیملی فزیشین کے, ایز اسسٹنٹ پروفیسر اینڈ ایسوسیٹ پروفیسر. فار لاسٹ 10 years those posts are vacant. Recently a person who is being selected on a said post 18. The first conference of 18. So those societies is just created in 2016 onward. I have attended the last Pakistan Gastroenterology Society conference, 38 conference of Pakistan Society of Gastroenterology. So those our kids have poked to develop societies. So we have created like this ourselves. Now we are having two society, Pakistan Society of Internal Medicine and Pakistan Society of Physicians. So I ask you, sir, why you are not going to develop your society, and you should ask us that we should present ourselves over there and we can give and refresh our knowledge. दूसरा, मैडम ने एक ज़बरदस्त बात की, लोग हमारे ऊपर उंगली उठाती है. हम जब आपसे पूछते हैं कि आपको ये आता है तो आप उंगली नहीं उठाते, इसलिए लोग आपके ऊपर उंगली उठाते. आप आगे आ जाए, हमको बुलाए, हम अपना नॉलेज शेयर करेंगे और दूसरी स्पेशलिटीज भी अपना नॉलेज शेयर करेंगे. इंशाल्लाह इसके जरिए हम आगे चले जाएंगे.
इसका मैं जल्दी जवाब दे देता हूँ एक सेकंड में. सेकंड में ये है कि आपने कहा ना कि क्या हुआ, तो उसकी मसला यही था कि जो तारिक मियां ने और हमारे डॉक्टर साहब ने पॉइंट रेज किया कि जब आपका पब्लिक सर्विस कमीशन उसकी इंडक्शन कर रहा था, इंटरव्यू कर रहा था, आई वॉज अप्रोच्ड बिकॉज आई एम हेड ऑफ द फैमिली मेडिसिन डिपार्टमेंट एट खैबर मेडिकल यूनिवर्सिटी. सो बीइंग अ सब्जेक्ट एक्सपर्ट आई वॉज नेवर इन्वाइटेड. किसी और ने उसको इंटरव्यू किया और उसको जॉब भी दे दी. बाद में फिर आपके प्रिंसिपल साहब ने मुझे कांटेक्ट किया कि इस बंदे की तो डिग्री इंटरनल मेडिसिन की है, तो अब वो बंदा मेरे पास आया है, उसको इंशाल्लाह हम डिप्लोमा फैमिली मेडिसिन में एडमिशन दे रहे हैं और उसको हम फैमिली फिजिशियन बना के आपके पास पोस्ट कर देंगे. तो हमें इंक्लूड करें तो इंशाल्लाह आपके मसले हल हो जाएंगे.
Right.
ठीक है.
On this positive note, I think we will end. Sorry, sir, एक comment. Okay, thank you. इनको माइक्रोफोन दे दें प्लीज. सर बिल्कुल शॉर्ट रखिएगा क्योंकि फिर वो बड़ी हीटेड डिबेट हो जाती है. जी.
अस्सलाम वालेकुम. मैं डॉक्टर अनवार मोहम्मद कुरैशी, हैदराबाद से ताल्लुक़ है. मैं किसी अस्पताल में गवर्नमेंट हॉस्पिटल में मेडिकल सुपरिटेंडेंट के तौर पे काम करता हूँ और बहुत सारी बातें हुई, बड़ी अच्छी बातें हुई. फैमिली मेडिसिन बैकबोन है हमारी. लेकिन देखें, जब हम MBBS करके निकलते हैं तो हम सिर्फ 2 फील्ड में हाउस जॉब करते हैं 6-6 महीने का, और उसके बाद में हमारे अक्सरियती जो स्टूडेंट हैं डॉक्टर बनने के बाद वो जिस अस्पताल में भी जाके बैठते हैं वो काम कर रहे होते हैं एज ए फैमिली मेडिसिन, चाहे वो प्राइवेट हॉस्पिटल हो या गवर्नमेंट सेक्टर का हो. लेकिन वो काम करने के लिए तो बैठ जाता है. मैं अपना एक्सपीरियंस, अपने स्टूडेंट्स का एक्सपीरियंस बताना चाहूँगा कि जब फौरी तौर पर हम जाके जॉब शुरू करते हैं हाउस जॉब के अगले हफ्ते में, तो हमारे पास बहुत सारे मुख्तलिफ पेशेंट्स आते हैं जिनको हमें डील करना नहीं आता और उसके लिए कोई तरीक़ेकार, कोई ट्रेनिंग कुछ भी नहीं होती. तो सबसे पहले तो ये कि ये सारी बातें जो गवर्नमेंट लेवल पर हो रही हैं और सीटें क्रिएट होंगी और ये होगा और वो होगा, वो सब अपनी जगह बिल्कुल कारामद चीज़ें हैं. लेकिन हमें एक तवज्जो देनी चाहिए. एक नए डॉक्टर को सबसे पहले आप फैमिली मेडिसिन की एक छोटी सी ट्रेनिंग तो दें. अब उसके लिए मैं 2 शहरों की बात करूँगा. मेरा ताल्लुक़ है हैदराबाद से और इत्तफाक से मुझे नेशनल हेल्थ सर्विस उसमें जो सर्जरीज होती हैं GPs की, उसका 20 साल का एक्सपीरियंस है डायरेक्ट ऑब्जर्वेशन का और थोड़ा बहुत काम करने का. तो ये सारी चीज़ें पाकिस्तान बने हुए 70-75 साल हो गए, आज तक यहाँ इम्प्लीमेंट नहीं होती. कोई ट्रेनिंग नहीं होती, किसी कॉलेज में सीट नहीं होती. हैदराबाद में हमारे पास सिंध के दूसरे गांव और छोटे शहरों से लोग आते हैं. तो एक मैं क्रेडिट दूंगा प्रोफेसर पीखा राम साहब को, जिन्होंने 2014 में डिप्लोमा फैमिली हेल्थ केयर वो स्टार्ट कराया और लोगों को एक अवेयरनेस दी कि फैमिली मेडिसिन भी कोई फील्ड है, कोई स्पेशलिटी है और आपको ज़रूरत क्यों है. अब उसमें आप मेंटल हेल्थ भी पढ़ रहे होते हैं जो आमतौर पे नहीं पढ़ते, उसमें आप रिमेटोलॉजी भी पढ़ रहे होते हैं, उसमें आप न्यूरोलॉजी भी पढ़ रहे होते हैं. लेकिन जब हम GP शिप में जाके अपना काम करते हैं बगैर ट्रेनिंग के, तो हैजर्डस जो है वो नुकसान पैदा करते हैं मरीज़ के लिए, और वो मरीज़ जब सेकेंडरी टर्शरी केयर की तरफ चला जाता है तो वो पूरा ख़ानदान उसका तकलीफ में आ जाता है. तो हमें तवज्जो देनी चाहिए इसकी. सबसे पहले प्राइवेट लेवल पर पाकिस्तान मेडिकल एसोसिएशन इस सिलसिले में काम कर सकता है. हर शहर में PMA होता है, वो एक ये दें. दूसरा मैं क्रेडिट दूंगा डॉक्टर फरहान ईसा को. हैदराबाद में उन्होंने एक लैब शुरू की आज से 5 साल पहले. कराची एंड हैदराबाद दोनों जगहों पर मुस्तकिल वो फैमिली डॉक्टर्स के लिए CMEs जारी रखते हैं अपने तौर पर. तो इस तरह से अपने तौर पर हम बहुत सारे डॉक्टर्स हैं जो आगे लोगों को ट्रेन कर सकते हैं ताकि एक सिस्टम तो ठीक हो, एक समझ में तो आए ना कि आप ट्रीट किस तरह करने जा रहे हैं। अब जो LHWs होती हैं वो भी कोएक्स की तरह पूरा एक बोरा भर के दवाओं कर ले जाती हैं और वो सब काम कर रही होती हैं। थैंक यू, बहुत शुक्रिया।
थैंक यू वेरी मच। थैंक यू। वी वुड लाइक टू thank you for the enthusiasm and all the questions. I'm grateful to all the panelists who came and far away. Thank you to the PSIM team for the session, providing us this opportunity, and to the audience for the lovely debate. Thank you, Ji.
Thank you, Dr. Hina, for the excellent moderation, and thank you very much, audience, for being so active and so interactive during the last session. Ladies and gentlemen, with this we come to the last talk of the today. Last but not the least, another very important aspect of internal medicine, which is emergency medicine. So we have a brilliant speaker from UAE with us. I'm going to introduce our speaker, Dr. Mueed Ahmed. He's a fellow of Royal College of Emergency Medicine, London, Royal College of Surgeons, Edinburgh, and holds a master's degree in medicine from National University of Singapore. Can I have silence in the hall, please? Can I have silence in the hall, please? Dr. Mueed Ahmed has completed his specialty training in emergency medicine from Queen's Medical Centre, Nottingham. And after completing his CCST, he joined as a consultant at Royal Albert Edward Infirmary, Manchester. Dr. Mueed has a specialist interest in trauma, acute medicine, and medical education. He is also the instructor for ATLS, Resuscitation Council UK, and tutor for School of Medicine, University of Manchester. He is also a senior examiner at the Royal College of Emergency Medicine, London, and a regular speaker in many national and international MediConference. Currently, Dr. Mueed is working as consultant emergency medicine at American Hospital, Dubai, UAE, and as clinical assistant professor at College of Medicine, University of Sharjah. Please welcome, in a round of applause, Dr. Mueed Ahmed for his talk on emergency medicine.
Excuse me, can the audience be seated now? Please. We have a keynote speaker all the way from UAE, and this is the last presentation for this afternoon. I want complete attention, and then the young doctors can go and get checked in hotel, and then the buses will take them from there to the facility of GETS, and the senior people sat on the first two rows will leave for the GETS facility at 5. The rest, another set of people will leave at 6 from here, जो रह जाएंगे. तो जो senior लोग हैं वो अभी जाएंगे. And I'm sorry, sir, for this interruption, but it was absolutely necessary to lay the ground for your presentation. And take your time.
Assalamu alaikum everyone, Professor Aftab Mohsin, Dr. Somia, thank you very much to giving me the opportunity and honor to speak here. Professor Javed Akram साहब ने मुझे invite किया कि emergency medicine के ऊपर you give a talk. So basically talk तो clinical talk है. It will probably 15 minutes, I'll make it brief. So very interesting session about family medicine earlier. तो हमारे पास family medicine है, हमारे पास internal medicine है. And then the most important specialty is emergency medicine. क्योंकि पाकिस्तान में unfortunately जितना ज़्यादा trauma है और जितनी infectious disease है, meningitis है, malaria है, rabies है, मैंने rabies पाकिस्तान में देखी, tetanus भी पाकिस्तान में देखी है. I practiced for 15 years in England. Nobody has seen rabies, nobody has seen tetanus. I have seen 4 gunshot wounds there only. That's it. तो जो emergency medicine सबसे important specialty in Pakistan at the moment, और इंशाल्लाह उसको हम develop कर रहे हैं. And my dream is कि next few years में जब भी हो जो district hospitals हैं, teaching hospitals हैं, उनके अंदर हमारे पास functional emergency departments बन जाएं. तो I'll go through this talk और इसमें जो recent advances हैं last 1 or 2 years में जो papers आए हैं, I'll go through that. So it will be clinical talk and hopefully it will be useful for you. और उसके end में I'll make an announcement, very important announcement. which will be applicable to all of you, and you'll be happy to hear that announcement. So, अभी मैं आपको एक सिनेरियो देता हूँ. जो एंडोट्रेकियल इंट्यूबेशन है, इट्स अ वेरी इंपॉर्टेंट स्किल, और ये आप सबको आनी चाहिए. और जो मेडिकल स्टूडेंट्स हैं और जो जूनियर डॉक्टर्स हैं, यू नीड टू लर्न दैट स्किल. और उसके लिए मैं एडवाइस ये करूँगा कि आप हाउस जॉब में या उससे पहले या दौरान 1-2 महीना एनेस्थीसिया ज़रूर कर लें, क्योंकि आपका एयरवे सिक्योर हो जाएगा. उसके बाद आप आईसीयू करें, आप इंटरनल मेडिसिन में जाएंगे, आप प्राइमरी केयर में हों और आपको किसी पेशेंट को रिससिटेट करना पड़ रहा है, तो आपकी एयरवे स्किल्स होंगी. तो दिस इज़ वेरी वेरी इंपॉर्टेंट. तो एक नॉर्मल सिनेरियो होता है कि आपके पास पेशेंट है जिसको एयरवे कॉम्प्रोमाइज़ है और आपने उसको इंट्यूबेट करना है. 120 kg ओबीज पेशेंट है, इट्स अ डिफिकल्ट एयरवे. तो नॉर्मल आप कौन सा मसल रिलैक्सेंट यूज़ करेंगे और किस डोज में यूज़ करेंगे. तो अभी एक रीसेंट पेपर आया था, तो मैंने कहा मैं एयरवे से शुरू करता हूँ. एयरवे ABC कम्स फर्स्ट. तो दिस इज़ कैनेडियन जर्नल ऑफ इमरजेंसी मेडिसिन का पेपर है 2021 का, और अच्छा पावरफुल स्टडी है. 8000 पेशेंट्स इसके अंदर हैं, एंड नॉर्मली दे गो फॉर रोक्यूरेनियम डोज 1.4 milligram, विच इज़ द मैक्सिमम डोज. नॉर्मली मैं प्रैक्टिस में ये करता हूँ कि आई गो फॉर 1 milligram, मैक्सिमम 1.1. दे आर सेइंग टू गो टू 1.4, 1.5 milligram per kg. उसमें ये होगा कि आपकी जो फर्स्ट अटैम्प्ट में सक्सेस रेट है वो ज़्यादा है, and there is no undue complications on high dose. So this is something which is obviously practice changing for me as well. I'll go with high dose of rocuronium. कोविड PCR के मुतालिक एक लेटेस्ट अपडेट आई है. अभी आप ट्रैवल करते हैं तो अभी तो थोड़े रिलैक्स हो गए हैं रूल्स. यू डू अ PCR बिफोर ट्रैवलिंग, यू लैंड इन पाकिस्तान, यू डू अनदर PCR, यू गोइंग बैक, you do another PCR, and then total 4 PCRs you do if you have to come to Pakistan to visit. तो ये recent advances है, अप्रैल की आई है. तो this is a company है Inspect IR. So they have FDA has approved their breathalyzer, and the result is only in 3 minutes. It's a portable machine, and the sensitivity and specificity is 91 to 99% as compared to the PCR, to the normal PCR. So this is something which is going to come, or at least will the waiting time for the PCR and the cost will come down. This is something new which will come. Surviving sepsis very important. पाकिस्तान में इन्फेक्शन बहुत ज़्यादा है. इसकी क्रिटिकल केयर की नई गाइडलाइंस आई हैं, क्रिटिकल मेडिसिन 2021 की. इसमें मैं सिर्फ आपको 4 पॉइंट्स दूंगा जो आपने याद रखने हैं. तो जब whenever you have a patient with sepsis who has a systolic blood pressure less than 90, mean arterial pressure less than 65, so the first thing you do is make sure you oxygenate them, airway, oxygenate them. Second is you give them fluid bolus, saline, crystalloids, 30 ml per kg. अगर 70 kg का patient है तो you go for 2 liters, over 2 liters. उसका blood pressure maintain कर लिए. First thing is fluids. और fluids से अगर वो respond नहीं कर रहा within 3 hours, then you go for vasopressors. So vasopressor is norepinephrine, and then antibiotics. और आपने शुरू करना है जो भी आपका प्रेवलेंस है, कराची में है, आप जिस एरिया में है, जो ज़्यादा जो इन्फेक्शन उधर है, उस हिसाब से आप अपनी ब्रॉड स्पेक्ट्रम एंटीबायोटिक शुरू कर सकते हैं. एंड ऑब्वियसली जस्ट टू रिमाइंड यू अबाउट दैट कि आपने ब्लड कल्चर्स रूल लेने हैं एंटीबायोटिक्स शुरू करने से पहले, बट डोंट डिले द एंटीबायोटिक्स इफ यू कांट टेक द ब्लड कल्चर्स, बिकॉज एंटीबायोटिक्स विल बी लाइफ सेविंग इफ इट्स एंड अप टू बी अ मेनिंजाइटिस, एंड अप टू बी एंडोकार्डाइटिस और समथिंग सीरियस. इसमें जो नई चीज़ आई है वो ये आई है कि अगर वेजोप्रेसर्स आपने शुरू किए हैं, आपने फ्लूइड्स दिया है 30 ml पर kg, वेजोप्रेसर शुरू किया है, नॉरएपिनेफ्रिन, स्टिल प्रेशर इंप्रूव नहीं हो रहा, तो देन यू गो फॉर हाइड्रोकॉर्टिसोन, फिर आपने उसमें ऐड करने हैं. दिस इज समथिंग दे मेंशन इनटू इट. अच्छा, ये बड़ी इंपॉर्टेंट है. तो हम इंटरनल मेडिसिन की बात कर रहे हैं एडल्ट्स की, लेकिन व्हेनेवर आई स्पीक इन पाकिस्तान तो मैं ये हमेशा मेंशन करता होता हूँ. ये एक बच्चा आपके पास आ रहा है जो कि वॉमिटिंग कर रहा है, लिथार्जिक है, डिहाइड्रेटेड है. एक चीज़ हमेशा याद रखें, जब भी आपके पास कोई सिक चाइल्ड आए, बीमार बच्चा है, ही लुकिंग सिक, उसके ब्लड ग्लूकोज जरूर चेक कर लें. इट टेक्स लेस देन 1 minute, आप उसकी ब्लड शुगर जरूर चेक कर लें, अदरवाइज यू कैन मिस DKA. और पीडियाटिक DKA की हाई मोर्टेलिटी है पाकिस्तान में अनफॉर्चुनेटली. तो व्हेन एवर आई गिव अ टॉक मैं ये कहता हूँ कि मैंने अगर आपको पीडियाटिक DKA पढ़ाया है तो मेक श्योर कि कोई बच्चा जो है ना उसकी मोर्टेलिटी मॉर्बिडिटी ना हो, आपके हॉस्पिटल में, आपके क्लिनिक में. तो pediatric DKA is very very important. Or this child, excuse me, so now blood glucose is more than 200 milligram, 11 millimole, और pH less than 7.3 है, metabolic acidosis में है. تو ڈی کے ان مور ڈیٹیل آئی کین گو, لیکن اس میں جو آپ نے امپورٹنٹ کیا, آپ نے ریکگنائز کرنا ہے ڈی کے, اور اس کے بعد آپ اپنے ڈپارٹمنٹ کے اندر, اپنی ایمرجنسی کے اندر, اپنے ہاسپٹل میں, اپنے کلینک میں ڈی کے کا ایک پروٹوکول بنا لیں. یہ میری پریزنٹیشن جو ہے یہ آپ کو ای میل کر دیں گے, اس کے اندر ڈی کے کا لکھا ہوا ہے آپ نے کب انسولین شروع کرنی ہے. انیشلی یو اسٹارٹ ود اے فلوئڈ بولس, اس کے بعد آپ نے آفٹر 1 hour یو اسٹارٹ دا انسولین, اور اس میں پوٹاشیم ریپلیسمنٹ آپ نے ایڈ کرنی ہے. تو مین جو 3 پوائنٹس ہوتے ہیں اس میں یو گو ود والیوم ڈپلیشن, الیکٹرولائٹ امبیلنس اور ایسیڈوسس, یہ 3 چیزیں کریکٹ کرنی ہیں آپ نے. بچوں میں جو سب سے پرابلم کمپلیکیشن ہوتی ہے جس میں ہائی مارٹیلٹی ہوتی ہے وہ ان کو سیریبرل ایڈیما ہوتا ہے. وہ اگر جتنا ایسیڈوسس زیادہ ہو, اگر آپ ڈیلے ان ٹریٹمنٹ کریں تو دین دے گوئنگ ٹو دیٹ. اینائن گیپ کیلکولیشنس کرنی ہے, اور آئی وی فلوئڈز ہے آپ نے کس طرح شروع کرنا ہے اس میں. اور انسولین جو ہے نا وہ آفٹر 1 hour آف آئی وی فلوئڈز ہوتی ہے, 0.1 kg پر آور جو انسولین انفیوژن ہے. تو آئی وی فلوئڈز میں یہ سمپل ہے, 5% ڈی ہائیڈریشن اگر آپ کیلکولیٹ کرتے ہیں تو 20 kg چائلڈ میں 83 ml پر آ رہا ہے. یہ انکلوڈنگ دا ڈیفیسٹ اور انکلوڈنگ جو آپ نے اس کو مینٹیننس ہے یہ ایڈ کر کے. اسی طرح تو یہ سم تھنگ یو کین مینٹین اے چارٹ, یو کین کیپ اٹ سو دیٹ یو آئیڈینٹیفائی دا چائلڈ اینڈ یو کین اسٹارٹ دا ٹریٹمنٹ. پوٹاشیم آپ ریپلیس کرنا ہے. اوکے, سو ایڈلٹ ڈی کے کو میں اسکپ کر لیتا ہوں. آئی ول گو فار ٹوسیلازماب کووڈ سے. تو اوکے, دیر از اے 55-year-old male patient with a stable ischemic heart disease. So he is taking aspirin and he is taking statins. And he is asking you, doctor, مجھے کوئی اور میڈیسن آئی ہے جو آپ ایڈ کرنا چاہتے ہیں ٹو میری ischemic heart disease کا یعنی ایڈورس ایونٹ مائوکارڈل انفارکشن یا اسٹروک کو پریونٹ کرنے کے لیے. تو یہ ایک ریسنٹ پیپر آیا ہے, اس کو میں ایڈ کر دیتا ہوں اس کے اندر. یہ نیو انگلینڈ جرنل آف میڈیسن کا 2020 کا پیپر ہے, اور 5522 پیشنٹ سے آر سی ٹی ہے, رینڈمائز کنٹرول ٹرائل ہے کالچسن کے اوپر. کالچسن از این اولڈ میڈیسن, وی آل نو کالچسن, اور اس کو ہم گاؤٹ میں یوز کر رہے ہیں, فیملیئر میڈیٹرینین فیور میں یوز کر رہے ہیں. 0.5 ملی گرام 500 مائکرو گرام, اس کے یو نو اٹس ویری ایکسلنٹ کارڈیو ویسکولر پروٹیکشن ہے اس کے اندر, کالچسن کے اندر, کمپیئر ٹو دا کنٹرول گروپ. سو دس از سم تھنگ نیو وچ آئی مین وی ور ناٹ شیور اباؤٹ کہ کالچسن کو یوز کرتے ہیں, لیکن اس کی اینٹی انفلیمیٹری پراپرٹیز ہیں جو کہ آپ کے ویسکولر کمپلیکیشنز کو پریونٹ کرتی ہے. اور یہ اچھا پیپر ہے, نیو انگلینڈ جرنل کا ہے, 5000 پیشنٹس ہیں. ایک اور کارڈیولوجی ریلیٹڈ نیا پیپر آیا تھا, 55-year-old میل ہے وتھ کرونک ایٹریل فبریلیشن, اینڈ آپ کیا کریں گے, اس کا ریٹ کنٹرول کریں گے کہ ریدم کنٹرول کریں گے. ہمارے پاس پیشنٹ ہوتے ہیں کرونک ایٹریل فبریلیشن میں چل رہے ہوتے ہیں, ان کو وارفرین پہ آپ نے ڈال دیا ہے, ڈائریکٹ اورل اینٹی کوگولنٹس پہ کر دیا ہے. تو جو پیپر یہ نیو انگلینڈ جرنل کا پیپر ہے 2020 کا, اور یہ ٹرائل تھا 2800 پیشنٹس کا. تو اس میں انہوں نے کہا ہے کہ یو نیڈ ٹو کنٹرول دا ریدم بیسیکلی, دین دی آؤٹ کم از بیٹر. تو ویدر ابلیشن کریں اس کی اینٹی ریدمک میڈیکیشن کے ساتھ کریں, یور ٹارگیٹ شوڈ بی ٹو کنٹرول دا ریدم, ڈونٹ لیو دا پیشنٹ ان ایٹریل فبریلیشن. جو کہ بعض اوقات پیشنٹ ہمارے چل رہے ہوتے ہیں ایٹریل فبریلیشن, کرونک ایٹریل فبریلیشن میں, ان کا ہم ریٹ کنٹرول کر کے رکھ دیتے ہیں. تو وٹ ایور دا ریسورسز آر اکارڈنگ ٹو یور فیسلٹیز, اگر آپ کے پاس الیکٹروفیزیولوجسٹ ہیں تو آپ یو گو فار ابلیشن, نہیں تو اینٹی ریدمک کے ساتھ ان کا ریدم کنٹرول کریں, دین دا آؤٹ کم از بیٹر. 70-year-old فیمیل کو آپ ٹریٹ کر رہے ہیں ایکیوٹ ریسپریٹری فیلئر میں اور کارڈیوجینک پلمونری ایڈیما کے ساتھ ہے. یو آر ونڈرنگ ویدر ہائی فلو نیزل آکسیجن will help the patient and prevent intubation. کیونکہ جو میرا بگسٹ فیئر یہ ہوتا ہے کہ اگر پیشنٹ پلمونری ایڈیما کا ہے and is not responding to medication, nitroglycerines, Lasix آپ دے رہے ہیں ان کو, اور آپ سی پیپ بائی پیپ شروع کیا آپ نے, they are not responding, so then I end up intubating them, اور which is obviously patient ventilator پہ جائے گا, آئی سی یو میں جائے گا. تو how to prevent it. تو this is again Annals of Internal Medicine کا 2021 کا ریسنٹ پیپر ہے, میٹا انالیسز ہے 29 randomized trials کا. تو اس میں ہائی فلو نیزل آکسیجن is highly successful in preventing intubation. تو ہائی فلو نیزل آکسیجن کو ہم نے کووڈ کے اندر کافی ایکسپیرینس کیا ہے, اینڈ I found it very useful. اور یہ پیشنٹس کو آپ کے سی پیپ بائی پیپ نان انویزیو وینٹیلیشن اور انٹوبیشن کے درمیان میں بفر کر دیتی ہے, برج کر دیتی ہے. تو اگر آپ کے ہاسپٹلس میں ہائی فلو نیزل آکسیجن موجود ہے تو یوٹیلائز دیم, not only in COVID, in respiratory failures, also in pulmonary edema as well. تو یہ آپ کے انٹوبیشنز کو پریونٹ کرے گی, اور بائی دا ٹائم فلوئڈ شفٹ آپ کا لنگ سے ہو جائے گا تو پیشنٹس کا ریسپریشن آکسیجنیشن بیٹر ہو جائے گی. اٹس اونلی میٹر آف دا ٹائم کہ جب آپ فلوئڈ کو آپ نے شفٹ کرنا ہے فرام دا لنگ پیرنکائما. سو ویری امپورٹنٹ پیپر یہ, دس ون از 77-year فیمیل ہے, شی از پریزنٹنگ ود شارٹنس آف بریتھ. اس کا چیسٹ ایکس رے آپ نے کیا ہے, ای سی جی کیا ہے, لیبس کیا اور آکسیجن پہ اسٹارٹ کیا ہے. تو آپ you're wondering کہ اگر میں بیڈ سائڈ الٹرا ساؤنڈ کروں تو will that help in the diagnosis of the patient? Now here I mention something, all of you, especially the young graduates, you should learn ultrasound. Ultrasound is so useful in emergency medicine. It's like an extra tool. It gives me an extra eyes and ears. تو میں ٹول کے ساتھ الٹرا ساؤنڈ کے ساتھ میں ڈی وی ٹی دیکھ لیتا ہوں کہ آپ کی ویسلز فیبرل کمپریسیبل ہے, نان کمپریسیبل ہے. آپ ایکو کریں پیشنٹ کا, آپ پیشنٹ کا لنگ الٹرا ساؤنڈ کریں اور اس میں دیکھیں کہ نمونیا ہے, پیشنٹ کے اندر رائٹ وینٹیکل ڈائلیٹیشن ہے, پلمونری ایمبولیزم کی طرف جا رہا ہے. اگر ویٹ لنگز ہے تو پھر بھی اس کے اندر سائنز آپ پک کر سکتے ہیں الٹرا ساؤنڈ کے اوپر. اٹس ویری ہینڈی, بیڈ سائڈ آپ کی کلینکل اسیسمنٹ میں ایڈ ہو جائے گا. اور یہ آپ نے سیکھنا ہے, تو الٹرا ساؤنڈ بھی اپنی ٹک باکس میں رکھ لیں کہ یو شوڈ لرن الٹرا ساؤنڈ ایز پارٹ آف یور کلینکل اسکلز. یہ 52-year-old patient presenting with flu, fever, body pain, headaches for 2 days, returned back from Tokyo and he is concerned about COVID. اب دیکھیں یہ جو پریزنٹیشن ہے بڑی کامن پریزنٹیشن ہے. آپ کو فلو ہے, فیور ہے, ہیڈ ایک ہے, یو ڈونٹ نو پیشنٹ کو کیا ہو رہا ہے ایگزیکٹلی. اب اس میں تھوڑا سا لیکن میں سلائڈ میں ایڈ کرنا چاہتا ہوں یہ والا کوشچن, اس میں ریسورسز ایڈ ہو جاتے ہیں. تو فارچونیٹلی ویئر آئی ایم ورکنگ وی ہیو دس پریویلیج کہ ہمارے پاس یہ لیبس بڑی اچھی ہیں اور ہم وائرل پی سی آر کرتے ہیں. سو وائرل پی سی آر ڈیٹیکٹس آل دیز وائرسز اینڈ اٹس گیو اس اے ایگزیکٹ ڈائگنوسس کہ مجھے اینٹی بایوٹک دینے کی ضرورت نہیں پڑتی. اب ان میں جب میں نے سواب کیا تو اس پیشنٹ میں کرونا وائرس NL63 which is the old version of the corona family, rhino virus was positive and influenza A was positive. So patient کو آپ بتا دیں کہ this is your diagnosis, I gave the paper to the patient, 4-5 دن میں آپ ٹھیک ہو جائیں گے. ہائیڈریشن, آپ اینٹی انفلیمیٹری سمپل لیں, no need of antibiotics. So this is the where investigations makes a difference. آپ unnecessary antibiotics نہیں دیں گے پیشنٹ کو. اور سملرلی میرے پاس ایک 42 پیشنٹ آیا, یہ ریئل پیشنٹس ہیں, وہ ٹرکی سے ٹریول کر کے آیا and he has diarrhea and vomiting for 2 days, fever, dehydrated. اب آپ اس میں ٹریول کی ہسٹری بھی ہے, آپ کہیں گے کہ میں اس کو اینٹی بایوٹک کوریج دے دیتا ہوں. جب ان کا میں نے گیسٹرو پی سی آر کیا, اس کو ہم اسٹول پی سی آر کہتے ہیں, تو گیسٹرو پی سی آر از نیگیٹو فار آل دیز and it came out positive for astrovirus. Now astrovirus is a simple virus, you just need hydration. آپ زوفران دے دیں vomiting کے لیے, vomiting کو stop کریں اور پیشنٹ صرف ریہائیڈریٹ کریں and this will doesn't need any ciprofloxacin, doesn't need any flagyl antibiotics, anything. Diagnosis patient کا ہو گیا. So this is again something which helps in your correct diagnosis of the patient. یہ ایک چائلڈ انڈیا سے آیا تھا 15 سال کا. اگین اس میں جب میں نے گیسٹرو پی سی آر کیا تو اس میں کمپائلوبیکٹر پازیٹیو آیا. اس میں بھی اگین یو کین ٹاک ٹو دا مدر. آئی اسپوک ٹو دا مدر کہ یو لک اف 2-3 دن میں پیشنٹ ٹھیک ہو جاتا ہے تو یو ڈونٹ نیڈ اینی اینٹی بایوٹکس فار دس. یہ سیلف لمیٹنگ ہے, خود ہی ختم ہو جائے گا, اونلی نیڈ ہائیڈریشن. لیکن اف اٹ پرسسٹ یو کین دین گیو اینٹی بایوٹک, ڈیلیڈ اینٹی بایوٹکس کین بی گیون ان دیٹ کیس. اچھا, دس از امپورٹنٹ کوشچن, جو سب سے کامن کوشچن ایمرجنسی میں, فیملی میڈیسن میں, انٹرنل میڈیسن میں آپ پوچھتے ہیں کہ پیشنٹ ایک کمنگ آ رہا ہے وتھ چیسٹ پین, 30 منٹ کی چیسٹ پین ہے اور 2 hours ago, ابھی 2 گھنٹے تھے چیسٹ پین, اس کو فنش ہو گئی ہے. ناؤ از پین فری, اس کی EKG نارمل ہے اور ہی از ڈسلیپیڈیمک, اسموکر, از ہائپر ٹینسو, تو اس کے رسک فیکٹرز ہیں. تو جو مجھے کوشچن میرے ذہن میں یہ ہوتا ہے کہ یار کین آئی سینڈ دس پیشنٹ ہوم, اس کے EKG نارمل ہے, اس کا ایک ٹراپرین نارمل ہے اور میں ایڈمٹ کر لوں اس کا. تو اس میں بڑا اچھا پیپر ہے which gives us some guidance and answer as well. نیو انگلینڈ جرنل کا پیپر ہے 2019 کا. تو اس میں پرائمری آؤٹ کم تھا کہ مائوکارڈل انفارکشن ایٹ پریزنٹیشن, کہ اس وقت جب آپ کے پاس پیشنٹ پریزنٹ کر رہا ہے آپ نے رول آؤٹ کرنا ہے اور ود ان 30 days اس میں کوئی ایڈورس ایونٹ تو نہیں ہو رہا. تو 120 منٹس آپ ایک ٹراپرین ابھی کریں اور ایک ٹراپرین 120 منٹس میں کریں 2 hours میں. If both troponins are negative and patient is pain free with a normal EKG, 30 minutes میں کوئی ایڈورس ایونٹس نہیں ہے, 0.2% ہے, تو اس میں یو کین رول اٹ آؤٹ دیٹ پیشنٹ. اور اس کو اوبیسلی آپ نے پھر کارڈیالوجی میں بھیجنا ہے, اسٹریس ایکو کے لیے, کارڈک CT کے لیے, ٹو میک شیور اس کی ایویلیویشن ہو جائے. ناؤ لاسٹ, دس از دا لاسٹ سلائڈ. اینافیلیکسس ویری ویری امپورٹنٹ, لائف تھریٹننگ. ٹھیک ہے, پیشنٹ اف ناٹ ٹائملی ٹریٹمنٹ نہ ملے پیشنٹ کو ایپینیفرین, تو پیشنٹ دے کین لوز دا ایئر وے. اور اینافیلیکسس میں سب سے زیادہ جو پرابلم ہوتی ہے, پیپل ہو آر ایستھمیٹک, وہ بچے, وہ پیپل جو ایستھمیٹک ہوتے ہیں, دے گوئنگ ٹو برانکوسپیزم, اور دیٹس ہاؤ دے گوئنگ ٹو ریسپریٹری فیلئر اینڈ انفارچونیٹلی دے کین لوز دیئر لائف. تو اگر کوئی پیشنٹ اینافیلیکسس میں جس میں ہسٹری ہے تو اس میں 18% چانسز ہیں کہ اس کو اینافیلیکسس دوبارہ ہوگا ود ان 1 year, 18%, ویری ہائی ریٹ. اور اس میں ہوتا یہ ہے کہ اگر ایستھما بھی ہے ساتھ تو اٹ از اے ہائی رسک کہ پیشنٹ جب بھی ہوگا یہ انفارچونیٹلی دے گوئنگ ٹو برونکوسپیزم, اور اس کو ریورس کرنا ٹائملی ویری ویری امپورٹنٹ. تو اس میں آپ کیا کر سکتے ہیں, اس میں ہمارے پاس ایپی پین ہوتا ہے, ہم پیشنٹس کو ایپی پین دیتے ہیں جو کہ ایپی نیفرین ہوتا ہے, ٹھیک ہے. اس کی ڈوز اپ ٹو 5 ایئر 6 ایئرز 150 مائکرو گرام ہے, 5 to 12 ایئرز 300 مائکرو گرامز ہے, اور پھر 12 سے آن ورڈز 500 مائکرو گرام ہے جو ایڈلٹ ایپی پین پین ہوتا ہے, اپنے لیٹرل تھائی میں انجیکٹ کرنا ہوتا ہے, اور دیٹ از لائف سیونگ, وہ برونکو ڈائلیٹیشن کرے گا اور پیشنٹ بائی دا ٹائم کین کم ٹو دا ہاسپٹل. تو یہ بچہ جب اس نے جانا ہے تو آپ نے اس کی والدہ کو یہ ایپی پین اس کو دے دینی ہے کہ یہ ایپی پین آپ نے ساتھ اس کے بیگ میں رکھنا ہے, گاڑی میں رکھنا ہے, اس کے اسکول میں رکھنا ہے. اگر بچے کو پینٹ الرجی ہے, کسی قسم کی الرجی ہے, اینڈ ہی اینڈ اپ انٹو اینافیلیکسس, تو ٹائملی ایپی پین کین بی گیون بائی دا ٹیچر. اب ایپی پین کیا پاکستان میں اویلیبل ہے, اس ایکسپینسو میڈیسن ایکچولی ایپی پین. تو اس کا حل کیا ہم کر سکتے ہیں, تو اس کا سمپل سولوشن یہ ہے کہ یہ انسولین کی سرنج ہے سمپل 1 ml کی, ٹھیک ہے, جو آپ کا ایپی نیفرین 1/1000 جو کارڈک اریسٹ میں ہم یوز کرتے ہیں وہ 1/10,000 ہے ڈوز اسٹرینتھ ہے ایپی نیفرین کی. اینافیلیکسس میں جو ہم یوز کرتے ہیں وہ زیادہ کنسنٹریٹڈ ہے, وہ 1/1000 ہے. تو 1/1000 ایپی نیفرین کا انجیکشن بڑا سستا ہوگا, آئی ڈونٹ نو کتنے کا, 50 یا 100 روپے کا ہوگا, ناٹ ایکسپینسو دین دیٹ, 5-6 روپے کا. تو اس میں آپ اس کو 1 ml کا انجیکشن 1 ml میں اس کو ہاف کر دیں اگر آپ, تو وہ 0.5 ملی گرام بن جائے گا, 500 مائکرو گرام بن جائے گا. اس میں 0.3 ml کر لیں تو وہ 300 مائکرو گرام بن جائے گا. آپ 3-4 انجیکشن لے کے بنا لیں 0.3 ml کے, وہ 300 مائکرو گرام کے بن جائیں گے. اس پہ آپ ایکسپائری ڈیٹ لگا کے, اس ٹیپ لگا کے بند کر کے ماں کو 3 دے دیں کہ اس کے بیگ میں رکھ لیں, اسکول میں رکھ لیں, اپنے پاس ایمرجنسی میں رکھ لیں. تو دس از ہاؤ یو کین امپرووائز. اور جب تک ایپی پین ہماری فارماسیوٹیکل میں ہوگا, ادھر بننا شروع ہو جائے گا, تو انشاءاللہ دین یو نو ایٹ لیسٹ یو کین سیو دا لائف, ادروائز اٹ ہائیلی ڈینجرس. تو آئی ول کنکلوڈ مائی ٹاک ہیئر. دس از جسٹ اے بریف انٹروڈکشن آف ایمرجنسی میڈیسن, جو ریسنٹ پیپر تھے, میں نے کہا میں اپنا انٹروڈیوس کروا دیتا ہوں, اینڈ آئی ایم ہیپی ٹو ٹیک کوشچنز ان دی اینڈ. ایک میں اناؤنسمنٹ جو میں کرنا چاہتا تھا, وہ جو میں آپ کہہ رہا تھا کہ اس کے اینڈ میں, وہ یہ ہے کہ آئی ول سی آل آف یو ان دبئی آن 8th and 9th of October. So the next PSIM conference will be in Dubai, Movenpick hotel, اور اس کے ساتھ پاکستان ایسوسیشن پیڈ ہے, کافی بڑی اچھی بلڈنگ ہے, بڑا امپریسو سیٹ اپ ہے. تو اس کے اندر کانفرنس بھی ہوگی, اور اس کے اندر انشاءاللہ انٹرنیشنل اسپیکرز ہوں گے ہمارے فرام UK, US, اور ان کے ساتھ پاکستانی اسپیکرز ہوں گے. اینڈ دین انشاءاللہ وی ول ہیو اے ویری نائس ایکیڈیمک ایونٹ 8th and 9th of October this year. اور اس کے لیے آپ ڈاکٹر سومیا کو کانٹیکٹ کر سکتے ہیں فار رجسٹریشن. تھینک یو ویری مچ.
تھینک یو ویری مچ جی, آپ نے بہت اچھی باتیں بتائیں اینڈ ویری انٹرسٹنگ. مجھے صرف ایک آپ نے بتایا تھا کہ اسٹیٹنس لے رہا ہے اور ایسپرین لے رہا ہے, مجھے صرف یہ پوچھنا تھا کوانزائم Q10 آج کل بہت ویوز کریٹ کر رہا ہے, اس کا کوئی رول ہے اس میں, جیسے جو اسٹیٹنس اینڈ وہ لے رہا ہو ایسپرین؟
اس پہ جو کولچسن کے ساتھ ایک تھوڑا سا سائیڈ افیکٹ ہے ان کا, کولچسن اور اسٹیٹنس کو جب اکٹھا ہم دیتے ہیں تو ریپڈومائلائسس کر سکتے ہیں, یہ CK جو ہے کافی انکریز ہوتا ہے, یہ صرف اس کا سائیڈ افیکٹ ہے. باقی جو کوانزائم جو آپ نے مینشن کیا ہے ان کا رول بھی ہے, اس آل ان ڈیولپنگ اینڈ ریسرچ بیسس. تو جس طرح اس میں کوئی نئی اپڈیٹ آتی ہے تو یو نو آئی ایم ناٹ اویئر آف اٹ, تو لیکن پرابلی اے کارڈیولوجسٹ ان دا آڈینس کین آنسر دیٹ.
Thank you, Mohit, for a wonderful talk. I just want if you can share your experience of treating accelerated hypertension or malignant hypertension in American Hospital, Dubai, because we have very limited intravenous drugs. How do you treat somebody with a blood pressure of 240/140, especially for our PGs sitting here, and obviously with little bit of fourth heart sound and going into LVF, how would you manage this patient there? دوسرا مجھے یہ بتائیں کہ جیسے آپ کی امریکن ہاسپٹل میں how do you triage the patient? How, I mean, like if the patient comes in impending shock, it could be a surgical cause or a medical cause, okay? I mean, like obviously somebody see that patient, and then either it could be acute pancreatitis, right, or it could be a perforating bleeding ulcer or whatever, maybe. So the patient presents to emergency medicine irrespective of whether it's a gynecological emergency or a surgical emergency or a medical emergency or a cardiac emergency, and then you triage it there and then send it to the respective department, or somebody else triage for you and then it comes to you. these two questions.
So very important question. So उसमें जो triage है, that is the most important part of the emergency setup. कि उसमें patient ने आपको जैसे front door पे आना है, तो you don't know what's happening to the patient. Patient is saying I've got abdominal pain. उसमें appendicitis भी हो सकता है, pancreatitis भी हो सकता है. If it's a young woman, that could be ectopic pregnancy as well. So how we develop this system is कि patient के vital signs लिए जाते हैं, patient की presentation ली जाती है, और usually the most experienced nurse, she sits in the triage room and she briefly takes the vital signs, examines the patient, and after that she directs inside the emergency. Or the beauty of emergency medicine is this, when I did my training in emergency medicine, we got trained in pediatrics, cardiology, obstetrics and gynae, medicine. Emergency physician को सारी training उसमें होती है कि आपने इसमें कहाँ rule out करना है. I have my bedside ultrasound which will rule it out कि abdomen में fluid है, ectopic pregnancy है, beta HT हमने करना है. So everything will come in the under one door in emergency, और वहाँ के उसके बाद जब हम उसको diagnose कर लेंगे, उसकी treatment शुरू करके, and then it will go to pancreatitis है, surgery में जाएगा, appendicitis है, surgery में जाएगा. If it is just simple enteritis है, so it go to the medicine. That will be all on the discretion of the emergency physician. तो अंडर वन डोर सारा का सारा हो रहा होता है.
अच्छा सर, आपकी प्रेजेंटेशन एक्सीलेंट. हमने शायद क्रिटिकल मेडिसिन में आज तक कोई ऐसी प्रेजेंटेशन नहीं देखी. टाइम की कमी की वजह से तशनगी रह गई. तो मेरा ये है कि अगर आप थ्रू PSIM, चूँकि जितने क्रिटिकल केसेस आपने बताए हैं, बीइंग अ फैमिली फिजिशियन आई हैव सीन अ लॉट ऑफ देम इन माय प्रैक्टिस, आई थिंक दिस इज एन एक्सीलेंट मैनेजमेंट प्रोग्राम. तो आप अगर ये अपनी प्रेजेंटेशन PSIM जो लेना चाहे उसको दे दें, हमारे लिए ये बड़ी यूजफुल होगी.
जी इंशाल्लाह. थैंक यू वेरी मच. I'll provide my presentation and to all the audience. Thank you.
I don't know whether this is medical emergency or something else. I remember a case when I was a trainee of Part 2. I was sitting in the casualty in the emergency room, and one girl has been brought about 11 to 12 years. She's fully cyanosed, unconscious, but her heartbeat was, when I ausculted, heart was beating, and pulse, although she was cyanosed, but pulse is weak and thready pulse. And at that time, time is very crucial. I've seen that her two little fingers of the right hand were unpolished. All nails were polished on the left hand. In my mind, something clicked that there should be a foreign body in the mouth, in the trachea. So I performed, because she was dying, almost dying. There was no endotracheal tube, there's no any other facility, there's no any anesthetist. I did the procedure of Hamilton maneuver, and that foreign body, that was the cap of that nail polish, you see, and that came out, and then I given, at that time, ambu bag and all these things were not available in Pakistan. We have to give the mouth-to-mouth breathing. After putting gauze, I giving the mouth-to-mouth breathing, and then she survived, and now she is the mother of many, many children, and she always comes. So, are the emergency physician, when you are sitting in casualty, you should know all the things of the your surroundings, and you have to, because if I was unable to see the two nails unpolished, I cannot catch that point. So emergency is emergency. Emergency means life. Life means seconds and minutes, not more than that. Thank you for your nice presentation. Thank you.
Thank you.
Thank you very much. I have a design query. When you're looking at ESI 1 and 2, we don't have too much problems that they're going into the resus straight away. What are you doing with ESI 2, 3, 4, 5?
So the triage, what happened is that the triage 1 and 2 should be seen immediately.
They're going to the resus. No
They're
problem.
going to the
Yeah,
resus.
2, 3, 4.
And
3,
2,
4,
3,
5.
4, accordingly, we have a waiting time maximum 30 minutes. So 3 and 4, somebody will coming with ankle sprain, somebody coming with a headache. So the nurse takes the vital signs, she talks to the patient, checks, makes sure no fever, and she can give a Panadol tablet there if the patient accepts it. Otherwise, she will tell the patient that doctor will see you according to...
We have the SIs. What I'm looking, like I said, I'm looking at design. So
3, 4, 5 would be something like slightly more urgent GP clinic sort of a thing, right?
Yeah, so what we do is, according to our workload, we'll put our workforce. So if like 11 to 11 is the busiest period of the day. So from 7 to 11 usually is quiet, so we have one physician.
We were working at a new ER design. We're teaching a new ER design. I teach design. So we're looking at a situation where you have the 1 and 2s, whether from pediatrics or from anywhere else, not obstetrics so much. They're going straight into the resus area. So the resus area is in the back and the flows are to them.
Yeah.
But the 3, 4, 5s are on one side and they have a heavy load, 75%.
Yeah.
So probably design like a urgent ER,
Yeah, I can provide you more, advice on that, how to design the emergency and how much workforce you need to provide and all to be seen in timely way, So I'll meet you after the talk and
Thank you very much. I'm grateful. Thank you.
Discuss that. Thank you. Thank you very much. Thank you.
Okay, the next, as Aftab Mohsin already announced, that a group of senior faculty members, they have to visit the GATS facility. We have to assemble in lobby at 5, right? And the junior doctors, they would be traveling directly from their hotel to that facility, and rest of them, you can take a bit of rest, and at 6 there will be costers in the lobby. They have to assemble there in the lobby, and then they would be joining us over there. 5 one group, 6 another group. If that's right. Chalo, if it's the decision is that everybody is, so at 5 in the lobby, everybody.